Provenge is an established cellular immunotherapy used to treat certain men with advanced prostate cancer. Provenge is customized to each individual and is made from his own immune cells. Immunotherapy is the prevention or treatment of disease with substances that may stimulate an immune response. The immune system has memory and can recognize substances it has encountered previously. Immunotherapy is designed to boost the immune system to target and attack advanced prostate cancer. This is why immunotherapy empowers the immune system to fight the cancer immediately and allow the effects to last over time. Indication: Provenge is a prescription medication used to treat certain men with advanced prostate cancer. Provenge is an established cellular immunotherapy and is customized to each individual by using his own immune cells. Important safety information. Before receiving Provenge, tell your doctor about any medical conditions, including heart or lung problems, or if you have had a stroke. Tell your doctor about any medicines you take, including prescription and non-prescription drugs, vitamins, or dietary supplements. The most common side effects of Provenge include chills, fatigue, fever, back pain, nausea, joint ache, and headache. These are not all the possible side effects of Provenge treatment. Provenge is made from your own immune cells, which are collected during a process called leukapheresis. The cells are processed, returned, and then infused back into the patient through an IV, intravenous infusion, approximately 3 days later. This process is completed in 3 cycles, about 2 weeks apart. Each infusion takes approximately 1 hour and requires 30 minutes of post-infusion monitoring. Provenge infusion can cause serious reactions. Tell your doctor right away if you have signs of a heart attack or lung problems, such as trouble breathing, chest pains, racing or irregular heartbeats, high or low blood pressure, dizziness, fainting, nausea, or vomiting. Have signs of a stroke, such as numbness or weakness on one side of the body, decreased vision in one eye, or difficulty speaking. Develop symptoms of thrombosis, which may include pain and/or swelling of an arm or leg with warmth over the affected area, discoloration of an arm or leg, shortness of breath, chest pain that worsens on deep breathing. Have signs of infection, such as fever over 100 degrees Fahrenheit, redness or pain at the infusion or collection sites. Tell your doctor about any side effects that concerns you or does not go away. For more information, talk with your doctor. You are encouraged to report negative side effects of prescription drugs to the FDA. Visit www.fda.gov/medwatch or call 1-800-FDA-1088. Please see accompanying full prescribing information.
The Prostate Cancer Research Institute is an educational organization for prostate cancer patients, their caregivers, and their families. We put patients first and are an unbiased source of information and support. For over 20 years, our goal has been to meet the educational needs of prostate cancer patients at every stage of their journey. Medical technology is advancing rapidly, and new treatments are becoming available. Patients have to make complex choices which have lasting implications. They face unexpected industry biases and doctors who may not be up to date on the latest research. Your donation helps men receive the latest, most up-to-date information, which empowers them to make informed decisions. Our website, PCRI.org, is a wealth of information and resources. Our conferences and webinars are a way to get patients' questions answered by leading physicians and researchers. And we have a helpline for men to call with questions about their diagnosis, treatment choices, and side effects associated with these treatments. Each week we produce multiple videos covering concepts and every patient question that we can think of about the disease in a straightforward and easy to understand format. This was a brief overview of what we do at PCRI, and to learn more, you can visit our website. Your donation directly funds our educational programs, which give life-changing information to men during a very vulnerable time in their life, and we thank you for your consideration. You can visit PCRI.org to learn more.
Why do we come? Because knowledge is power, and knowledge provides hope.
And this is a place of hope and healing, and that's why I like coming here.
People come to this conference, they're uncertain, and they walk out of here with hope.
This is my 5th time. I learn something every year.
That was my first conference.
This is my 4th.
I think this is my 6th, and I love it. It's part of my treatment plan.
I've come to quite a few of these PCRI conferences and enjoyed all of them.
I've been to probably 9 PCRI conferences. Every one there's something different, so I keep coming every year.
The key is to be able to go and even have direct, individual questions answered with such kindness and such patience by folks that are at the top of their field.
It surprised me how accurate and up-to-date all the physicians are.
And they're very warm, they're open, they're available, and they present scientific information in a way that's very easy to understand and also quite entertaining.
The way they keep it moving and engaging, I mean, this is not a dull conference. This is, I don't want to use the word entertaining. I mean, it is entertaining, but it keeps you focused, keeps you engaged, anxious to hear the next thing.
I would say you have to come here and experience it.
Excellent beyond description what this conference brings to our lives.
this meeting has singularly been able to propel forward many of the concepts that are changing the field throughout the world. So even though you guys think that you're just sitting there as participants or audience, just through your social networking, just by sharing ideas, just by changing referral patterns, other institutions are going, well, crap, we better set up a PET scanner, or gee whiz, we better get into a more aggressive mindset about therapy. I like this meeting. I like talking to patients. I think patients get it much better than doctors. So for me, that's why I come and speak to you. And for me, the privilege is simply that some of you are doing better, all right? That's all I need.
Hi everyone, I'm Alex with the PCRI, and today I have the honor of presenting our 2026 PCRI Men's Health Conference. Now we are so excited to present this to you, but before we get there, we're going to have a short invocation and I'll be right back.
God, we come before you and we recognize that you are the God of all healing and all wisdom. And we're really grateful that you've given humans the ability to understand how the human body works, that medical science really is a miracle, and that you today are going to be communicating through the speakers the realities of how we can align to your purposes for our bodies. I pray that people, wherever they're coming from, whatever situation they're in right now, would be blessed by the information given today, and that they would be able to go away and apply it to their lives. Lord, give everybody wisdom today as they seek to understand more. And it's in your name that we pray. Amen.
Thank you so much. Now, we have an epic conference here. There's going to be some incredible content, and I want to let you know that you can actually see some further resources at pcri.org/men's health. If you're already watching the conference on our website, you can just scroll down and see our exhibit hall and see our men's health brochures. But we are going to have our weightlifting protocol. There's so many resources that we are going to be listing, and I would just encourage you to take advantage of it, download it, use it in your everyday life. There's just some awesome resources, and we wanted to make sure that those were available to you. You could also find out more about our speakers and learn how to get in contact with them, and also reach out to our helpline if you have further questions regarding your health and prostate cancer care. Now, I'd like to thank our sponsors, Bayer, Pfizer, and Dendreon, for supporting this conference and making it free for all of you. We appreciate their support, and they've just been great partners to us. You can also visit their information in our exhibit hall, again, on this webpage, pcri.org/men's health. Now, we understand that this is a long presentation. Typically, our live streams are anywhere from 6 to 8 hours, which is awesome that we get to present all that content, but it is quite a lot to sit through. So I would encourage you, go ahead and push pause on the live stream. Even while we're live streaming this, you can push pause and it'll pick up right where you left off when you come and push play. Or if you need to step away and you're not able to watch all of it in its entirety right now, you can go ahead and watch the replay, which will be on our YouTube channel and also on this webpage permanently. And we just like to remind you that that is an option for you because we are presenting a lot of different topics today and it's a lot to take in. So for those of you who can stay with us for those, 8 hours, thank you so much. And for those of you who need to leave, we look forward to having you again. Now, please click that subscribe button because it is a great way to support our YouTube channel. There is so many free resources and so many topics we're going to be covering, so much information that we get to present, but clicking the subscribe button helps push that information to other prostate cancer patients and caregivers around the world. And the bigger we grow this channel, the more people we impact. If you would like to support the work we do here, you can do so at pcri.org/donate. And that's a great way for us to basically, turn your funding into resources for millions of prostate cancer patients and caregivers all around the world. We get to make more videos like this, we get to make supplemental resources, and we get to have in-person conferences. It's just a great way to support the prostate cancer community. And also, speaking of in-person conferences, this September, we have an in-person prostate cancer patients and caregivers conference. We're going to have world-renowned experts answering your questions in person. And the greatest part is that not only do we make a lot of time for that, but you also get to meet each other and learn from other patients who are experiencing very similar things as you. And it's just a great way to learn in a community where you're not alone. We get to put those words to life in our conference. You get to meet people who are going through the same thing, and then you also get to be with us, the PCRI team, as we get to support you in person. You can learn more at pcri.org/conference. For this conference, as well as all the other PCRI conferences, we get to have our incredible moderator, Dr. Mark Moyad. He's a personal friend, but he's also an incredible God-given gift to PCRI because he's able to get all sorts of incredible speakers like the ones we have today and help us reach out to world-renowned experts, and they come together to give us presentations like this. Now, he's the Jenkins Poe Kempner Director of Complementary and Alternative Medicine for the University of Michigan Department of Urology, and he has written books, thousands of papers. He just donates so much of his time to public education and to getting the word out about the latest updates in all sorts of health, but he definitely focuses in prostate cancer. And we're so lucky to have him. Today, he's going to be working with our speakers as he's already worked for countless hours reviewing their slide decks and working with them and getting them prepped and ready for these presentations. But he's also going to be breaking down the talks within the Q&A section and asking the questions that we've had submitted beforehand to these speakers. He does an incredible job bringing levity to the situation when we're talking about prostate cancer and men's health, but he also does a beautiful job of just making our questions come to life in reality and being able to make it more tangible, more understandable, and helping us get into the nitty-gritty details that we really need to learn about in order to take care of ourselves. So I really appreciate him, and he is going to be our moderator for today. Our first speaker is Dr. Brian Helfand. Now, he is such an advocate for prostate cancer patients. He's the chief of urology at Endeavor Health, and he has just been such an advocate. He has done so many talks for us in the past, but he also works with other advocacy groups. Today, he's going to be talking about urinary flow and BPH, and he's going to be breaking down the different treatments for BPH and these procedures and how they work and what you can do. And then Dr. Moyad does a great job going into the details of what these different treatments mean. When it comes to Dr. Helfand, he is just somebody who knows how to make something that is very complex very simple. And so we appreciate his time today. Without further ado, here is Dr. Brian Helfand.
Hello, my name is Brian Helfand, and I'm excited today to talk about a relatively new topic in the field that really bridges the most common prostate diseases, and that being BPH, an enlargement of the prostate, as well as prostate cancer. And really the excitement that I have is, 2 for 1. Can we actually treat BPH and prostate cancer concomitantly? And so here are my disclosures. Really most relevant are that I am an advisor and study investigator for aquablation, which is a therapy that I will talk about later during this presentation that is relevant to today's talk. And so here's the outline of today, is to really kind of hopefully establish the overlap and the clinical problems that exist between BPH and prostate cancer, which raises that possibility if we can treat both conditions at the same time. And look at some of the available therapies, whether that's medications or surgery, that can potentially address both of these. So this all starts really with the story of urinary symptoms. And most men at some point in their life will develop urinary symptoms. And when I'm talking about lower urinary tract symptoms, or we, most familiar call them LUTs. But I'm talking about things like getting up in the middle of the night, we call nocturia, or using the bathroom too often, or frequency, or urgency, or weak stream. And these are very common, especially among aging men. And it is certainly the most common reason why men seek urologic care. And we often attribute this to an enlarged prostate, right? Is that most men come in, they think, well, my prostate is growing. I've heard that my father or my grandfather had this, and that's just part of aging, but it's bothersome for me. I'm peeing too much on the golf course compared to every other of my friends. And so I'm going to, ask and get help for this. And we always assume that it's derived because of an enlarged prostate, or what we call a prostocentric view of urinary symptoms. But the truth is, there are many other reasons that men develop urinary symptoms, some that we can control. Meaning, if we drink a lot of fluids, we're going to use the bathroom more frequently. So we certainly can decrease that. But other conditions, sleep apnea, diabetes, etc. And certainly this talk is not directed on those other causes of urinary symptoms, but really the fact that prostate cancer in advanced forms can also have urinary tract symptoms. And because both a benign enlargement of the prostate and prostate cancer both start in the prostate proper, we get some of those confused, but there is some overlap between those two very common conditions. And again, when we look at the prostate itself, so here's a diagram here. Here on top is the bladder, and this pink organ in the cartoon is shown below is the prostate. The urethra is a tube that kind of goes through it. And the prostate itself grows with age, right? And this growth is not cancer. It is what we call benign prostatic hyperplasia, or BPH. And it's really the inner part of that prostate that grows. So I always explain to patients that the prostate is kind of like an orange, and the juicy part grows with age. And that juicy part, we call the transition zone, is really where most of the BPH enlargement actually originates. So it starts there. Now, prostate cancer also develops in the prostate, and that usually is not in the juicy part of that orange. It's really stereotyped to be in the peel. And so as prostate cancer develops, at least in about 85% of cases, it starts in that peel and grows. Now, in advanced forms, when that growth is really big, it can also press that tube that leaves the bladder, the urethra, and cause urinary symptoms. But again, both of these diseases start in the prostate. And when you compare this, again, BPH and prostate cancer are the main reasons why men seek care at the urologist. And when you look at the prevalence, they're both very common diseases, right? 1 in 2 US men will develop or complain of urinary symptoms throughout their lifetime. And prostate cancer, despite the fact that everyone thinks that everyone dies with prostate cancer, only about 1 in 8 US men will be diagnosed throughout their lifetime. Both similarly increase incidence with age. So it has been shown that about 85% of men will have either moderate or severe urinary symptoms by the time they're 85. And prostate cancer, about 13% of men throughout their life will be diagnosed. Both of these are required to have male hormones around to start them. So both BPH and prostate cancer need testosterone. Testosterone is just the men's hormone, and the presence will actually stimulate the growth of BPH and prostate cancer. Now, its utility and importance in prostate cancer fluctuates throughout the development of prostate cancer. But it is important that both of these diseases are hormone-dependent diseases. Both of these diseases also have a strong heritable component. Again, they're very common, but when you estimate and say, well, if my father had it, or their father, or my brother had it, what are the chances that I would get this? They run strong in families. And when you do twin studies, It has been shown that over 72% of the heritable component for BPH can be explained by genetic factors. And similarly, for prostate cancer, it's been thought of that it's one of the most heritable out of all solid tumor types, and about 67% of that heritability can be explained by genetic factors. Again, both of these diseases are overrepresented among Black men compared to white men, meaning that it's more likely that a Black man will come in and present with urinary symptoms related to enlarged prostate, and it's about 2.2-fold higher risk of being diagnosed in prostate cancer in that same racial population. Both can be associated with urinary symptoms. The hallmark of BPH is really urinary symptoms and the presentation there. Prostate cancer, again, in advanced forms, can present with urinary symptoms. And again, when you look at the cost to society for each of these diseases, they both are associated with millions and millions of dollars per year. So they have a huge economic burden that they put on the US, but certainly the global population. So in many ways, again, while these diseases both start in the prostate, they're very different, both in their location, their implications, right? BPH, that benign enlargement, is a benign process, and prostate cancer certainly is a cancer and can be associated with mortality. But when you look at the actual similarities in their origin in the prostate, there's a lot of overlap there. And this may be beyond this talk here, but certainly we have asked, as well as many other groups, to say, is there really a high association between BPH and prostate cancer? And the truth of the matter is, yes, there is. So we did an analysis in a large data set that was conducted out of the United Kingdom. And certainly they recruited 250,000 men, and they followed them over a 15-year period. And among men who were diagnosed with benign enlargement of the prostate over that time, it was about 11% of the overall population. Again, this is not lifelong, it's only a 15-year period. And in that same time period, about 6.8% of those men developed new prostate cancer. There was an overlap. About 3,000 or more cases both complained of both BPH and had a diagnosis of prostate cancer. And when you look at the timing of these diseases, they were highly correlated, right? Is that this was more than just chance, but the presence of BPH and prostate cancer were concomitant in many patients, more than just chance alone. And if you had prostate cancer, there was about a 1.6-fold higher risk of also having that diagnosis of BPH. And similarly, if you were diagnosed with BPH, there was about a similar increased odds of being diagnosed with prostate cancer. So in that way, their incidence was the same. And we said, well, is this just based on chance? Because these men were seen in the urology clinic, and if you were there for one, you were likely to be diagnosed with the other. So we asked the question is there a genetic component there? And again, this is beyond the scope of this talk here, but the answer is that yes, there is a shared genetic basis between BPH and prostate cancer, and the shared genetic basis, again, originating in the prostate, but can explain the diseases in a subset of all patients. So there are a certain genetic signature for prostate cancer, there's another one for BPH, and then some men actually share those signatures. And you can use those genetic signatures to kind of distinguish the risk of any patient. So again, it makes sense that we see a lot of men who have prostate cancer and BPH in those in the same patient. So again, do we want to, because they are so common, is there a way we can kind of treat both of those at once? And so we do know that both BPH and prostate cancer are common. They originate in the prostate and they negatively impact a man's life, right? The quality of life, if you have, urinary symptoms related to BPH, or certainly if you have prostate cancer, those negatively impact that man's life. But if you treat those, especially for BPH, if you can do a procedure or give a medicine that helps alleviate some of the obstruction of the bladder because of that prostate enlargement, you will improve that man's quality of life. And most of those therapies for BPH, because you're just dealing with the juicy part of the prostate, are associated with minimal side effects. The problem for prostate cancer, again, is that it originates in the peripheral zone. And that peripheral, that's the peel of that orange, is very close to critical structures that are required for erectile function. So the nerves that control erections are very intimate with the peel of that prostate. And certainly the muscles that keep you dry are also near there. So any type of removal or radiation or therapies that we commonly use to treat prostate cancer have that potential to disrupt the nerve supply to the prostate or around the prostate, as well as the muscles that keep a man dry. So most of these kind of radical treatments with curative intent, surgery or radiation, have been associated with urinary leakage, what we call stress incontinence, with erectile dysfunction, with bowel issues, because again, the prostate lives on top of the rectum, so that can, if you use radiation, you can irritate the bowel, increase urinary symptoms, blood in the urine, blood in the stool. So there's a lot of things that are stereotyped to be associated with those therapies. And sometimes we don't even help the urinary symptoms, especially with radiation, we can make them worse. So again, the current and most commonly used therapies may be good for one thing, to treat prostate cancer, but they may make urinary symptoms worse. And the current treatments for BPH, while they improve quality of life, generally don't touch the prostate cancer. And so what if you have a patient who comes in and they have prostate cancer and urinary symptoms? And what if you say, well, I'm going to address the prostate cancer first, and then I'm going to use traditional therapies to treat any type of urinary obstruction. And people have looked at this in a sequential manner. And if you do it in these sequences, one before the other or one after the other, that there's a risk of side effects. That could be urinary leakage, that could be more complications, blood loss, toxicities, scar tissue, rectal irritation. So all of these things are really kind of factored in here, and they're really not sufficient. And anytime we have things that we can identify as a problem, that's an opportunity, right? We say the current modalities, and even though they're the most commonly used, are insufficient to treat men who have both urinary symptoms as well as prostate cancer. So what other things can we do? Are there things that we currently have access to or that are emerging that, provide evidence that we can treat safely both BPH and prostate cancer in that same patient? And I think some of the evidence from this really started with medical therapies. And medical therapies are systemic therapies. So when you take a medicine, they go everywhere in your body, including the prostate. And we do know, as I said, is that the opportunity here is that both BPH and prostate cancer start in the prostate, and both of these are sensitive, their growth and initiation, to testosterone. So we have many drugs that are most commonly used for men who have advanced prostate cancer that totally eliminate testosterone. And so when you look at these therapies, the question is, we know that they have some utility for men with advanced prostate cancer. In fact, we commonly, and it's standard of care for a lot of men who come in, that their cancer has spread beyond their prostate. So we give them medications to kind of starve their tumors, get rid of that testosterone, and shrink and control their tumors. But the question is, does that also help with urinary symptoms? And again, there are many studies in this space, but this is one that is more recent, called the ANALUT study. And what they did was they looked at a specific type of testosterone inhibitor. So again, they block the agent by blocking its production. These group of therapies are called LHRH analogs. Again, beyond the scope of what and the mechanism of how these drugs work, except that they block testosterone. And the truth is that we know that these have good cancer control for men with advanced prostate cancer. And they specifically ask the question, do these also improve urinary symptoms? And the truth is they do. It is no surprise that over time, when you get rid of the testosterone, the overall prostate itself shrinks, including that transition zone part. And that opens that bladder and makes it happier. So patients not only get a stronger stream, they get less urinary symptoms, they improve their quality of life. And the frequency of having events happen where they can't pee is significantly lower. So again, this shouldn't be considered the standard because again, this is systemic therapy. There are a lot of side effects, hot flashes, weight gain, mood swing, bone loss, etc. when you use these type of drugs, which outweigh the risk of just giving it for urinary symptoms. But I think it points out that there's a common mechanism that we can target to help, kind of treat both prostate cancer and BPH within the same patients. And again, there are even newer type of hormone therapies. These fall under a class, and it's an evolving name, but they're called androgen receptor pathway inhibitors. So they block the mode of action of testosterone at the cell level. And again, these are just inhibiting testosterone production. And whether you use these newer drugs or some of the older drugs, which I just showed you, they're not only is improved cancer control, but certainly they do improve urinary symptoms. And again, some of these drugs have been used as single agents among men with lower risk prostate cancer on active surveillance. And again, that has decreased the risk of upgrading in a short time period by about 10%. But when you look here, not only do they have good cancer control, but they also improve men's urinary symptoms, again, showing that there is improvement and a potential there. Now, a more common used therapy for BPH are what we call 5-alpha reductase inhibitors, or 5-ARI drugs. The generic name of these drugs is finasteride or dutasteride. And the way that they work is they manipulate testosterone. Testosterone normally acts in a form that is converted to what we call dihydrotestosterone, which is a much more active form of testosterone. Again, the point here is that there are drugs that can block that conversion and make it less active even in the prostate. And we know that these drugs can be used safely among men who have enlarged prostates. It's recommended that if you have a prostate over 75 grams, that you can consider the use of these medications. They themselves have very little side effects. There's a potential that they may have some sexual side effects. Nonetheless, they also have been used to grow hair on top of the head. So there is another benefit outside of the prostate that men may experience. But they're, in the cancer space, very controversial. Because both finasteride and dutasteride have been studied, because it was noted that men on these drugs had a lower risk of developing prostate cancer. In fact, the randomized trial of these drugs showed that approximately 25% of men who were on these drugs had a significantly lower risk of being diagnosed with prostate cancer. In fact, it went based on these trials before the FDA, and they unfortunately did not approve these drugs as a prostate cancer preventative manner because of the fact that if men were diagnosed with prostate cancer and taking one of these 5-ARI drugs, that there could have been an increased risk of more aggressive disease. Now, there's a lot of controversies in that, and again, beyond the scope of today's talk here. But again, it is something that is evidence that if you use a drug that manipulates testosterone, it has that potential to influence the natural history of both urinary symptoms as well as prostate cancer. And in fact, a separate trial beyond that was done, so men who had low risk, Gleason 6 or grade group 1 prostate cancer were assigned to either dutasteride, one of the 5-ARIs, or a sugar pill. And again, at 3 years, about 10% fewer men in the dutasteride group had worse disease that developed over time. So it is one of those where there may be some potential there. They themselves should not be considered standard of care for men who have prostate cancer or low risk. But again, bringing up that a lot of these drugs if they directly manipulate testosterone, or they manipulate the conversion of that pathway into its more active form, have that potential to treat both BPH and prostate cancer. But is there more here? And the truth is that there is. And there are now surgeries that have that potential to address both BPH and prostate cancer. They're a more definitive curative with intent to do a surgery to remove either part of the prostate or the whole prostate with these surgical therapies. But it is also important to note that these are all considered novel treatments for both BPH and prostate cancer. And according to the AUA, our guiding society, they should all still be considered experimental. And while all of these are under study right now, and there's accumulating evidence for this, is that the routine use of these therapies should be as part of a clinical trial and are not yet considered standard of care. However, they are exciting, and that is really why these early results we're talking about today, because there is so much potential here to treat both of these in the same setting. And so the three surgical therapies that I want to talk about today is Resume Vanquish. Resume is the trade name that is used for BPH, and Vanquish is the trade name that is used for prostate cancer. Similar type of devices that utilize steam, hot water, if you will, to treat and ablate the prostate cancer as well as benign prostate tissue. The second one is called TULSA-PRO, which is a form of ultrasound heat energy to destroy prostate tissue. And the third is aquablation, which is a cold water heat-free way, a high-pressure power washer, if you will, to treat both BPH and prostate cancer. So the rest of this talk will really be dedicated to going through how each of these three therapies are used in both the BPH and prostate cancer settings and show some of the data that support their utility. So again, I don't mean to harp on this point, but again, removal of prostate adenoma is the benign prostate growth. The BPH is really in the middle, the juicy part of that orange of the prostate. And again, when we remove that inner part, the juicy part, we know that it improves men's urinary symptoms. You free up the bladder, you make it happier, and men pee less often, more efficiently. And again, for a prostate cancer treatment, this is a stereotype thing, is that we have to be able to get to the peripheral zone, which is a zone that the peel of the prostate, where most prostate tumors reside. And conventional treatments say we are just going to remove or treat the whole prostate so that we can get to the peripheral zone, the peel of that prostate. And most of them also treat the transition zone at the same time. Now, we've come a long way. So it's much more complex than just, hey, we have an orange and there's the inner part and the peel. But when we look, we can actually identify using MRIs. So MRIs are the most common way that we image the prostate these days, that are used during biopsies to make them more accurate. And the reason why we use them is it can help identify larger tumors that are potentially more aggressive. And so the thought there is that for some men, if you can identify a spot in your prostate, you could potentially just treat that area focally, and these therapies are called focal therapies, And you can potentially cure or keep everything under control by just treating that part of the prostate. And if you just treat just a part of the prostate that you can see based on the MRI that has the tumor, then you mitigate or minimize any risk of side effects because you're only hitting one part of the prostate. The chance of you hitting the nerves that control your erections or the muscles for incontinence or certainly bowels goes way, way down. But this is also limited because 40% of aggressive tumors may not show up on the MRI. So again, we have to understand that MRIs are not perfect. They're the most frequent used, but they do open up a potential for how we can treat and come up with plans to treat certain men and certain types of prostate tumors. And so again, when you look at strategies here, is that if you have an MRI region that's of concern, in this would be the right side of the prostate here, and you can go about treating that with many different ways. You can focally just treat that area. You can just treat part of that, that area, and then additionally some more of that side of the prostate. You can go for half of the side of the prostate, or you can actually treat the whole prostate, period. And that risk, if you will, and the amount of tissue you treat is associated with the risk of you having side effects. Again, as you treat more and more of the prostate, and as that potential to hit both of the nerves that live outside of the prostate that control your erectile function or the muscles that keep you dry increases. So again, we can kind of schematically visualize that. And some of the newer technologies really take advantage of the fact that you can do some focal therapies, and other of these newer technologies really kind of get at the fact that we want to treat as much of that prostate as we can. So the first therapy to talk about is Resume and Vanquish. And this is a cartoon of how the procedure actually works. In disclosure, I got this from the company itself, but I think it's a nice cartoon that makes people understand how it works. So this is a procedure that can be done relatively quickly, anywhere between 15 to 30 minutes. It can be done in an outpatient setting, so in the office or potentially an ambulatory center, or sometimes people still will do this in the operating room. And what happens is that once the prostate is numbed up, so they'll often do a regional kind of block or nerve block of that prostate, make people comfortable. Sometimes they'll give them a oral sedative that's kind of just to make them comfortable, like Valium. And then once that happens, what they do is that they insert a cystoscope, a camera that can look at the inner part of that prostate. You can align these images with MRIs, etc. And once you identify a spot, in this case, this spot that they're showing here would correspond to an MRI area, you can actually press a trigger, which puts out a needle, and that needle then injects steam. And steam is, heated water energy that will actually ablate and or kill the prostate tissue and or cells. And again, this is just a schematic of showing how steam by convection can destroy this tissue. This is based on years of cell discovery and analysis of how it actually works. But certainly it has been shown for both BPH, and now it has been explored for prostate cancer as certain treatments. And the difference between Resume and Vanquish is a lot of times in the length of that needle. So again, for BPH, they just need to use that steam to destroy the juicy part of the prostate. But for prostate cancer, that needle has to be long enough and specific enough to get out toward the shell, the peel of that prostate. And so, again, looking at BPH, it has certainly established itself as a viable therapy. Again, most viable long-term therapies, durable therapies, do destroy tissue. This does destroy it. And so, as it destroys tissue for BPH, it has been associated with improvements in urinary symptoms. We use a questionnaire called the International Prostate Symptom Score, or IPSS, that shows that if you use this, you will have a significant between 10 to 15 point improvement in that score, meaning that men who are treated for BPH with Resume do improve their symptom score. They do improve their what we call a Qmax, or urinary flow rate. They pee better, stronger. And it is associated with, durable results for some men. There is a retreatment rate that exists, is that, some men after the procedure will require other therapies to get them cured because the steam didn't work as well. And that within the first 5 years is anywhere between a 4 to 10% retreatment rate. So it is one of those that is to note it may not be durable for all men. But importantly is that there is no change in erectile function after Resume. And there certainly is no or minimal change in the amount of ejaculate. So when you orgasm, the amount of fluid that comes out afterwards is not affected by the treatment of Resume for BPH. So if you use the water steam, these men have good improvements in in their urinary symptoms, but also improve in their sexual function. And again, when you look at the real world that are outside of these studies, again, men improve. They reflect a lot of the studies within the, the first year. There's about a 4.6 to 5% retreatment rate. So it is one of those where it is a effective therapy, but it may not be as durable as some of the other resective therapies that are out there for BPH. But what about for prostate cancer? And this is where Vanquish comes into being. And it's a different company that offers it. Again, a longer needle, and the monitoring system of it is a little bit more sophisticated. But because you're just putting a needle out and that needle can get to the peripheral zone, you can really destroy any part or any amount of that prostate that you would like. And again, this is just some images on an MRI after the Vanquish procedure, showing that you can successfully destroy that prostate tissue. Again, a healthy prostate is shown in that gray. The darker regions here, the more grayed out or black areas, are showing that areas that have been treated. And you can do anywhere from focal to whole gland ablation. Again, the risk of you potentially having side effects, the more whole gland you do, because it is a heated procedure, likely exist. But if you use it just for focal therapy, you should theoretically have a low risk of side effects. And so the large scale studies of these have really not been published as of yet. But the focal therapy has been really kind of studied in 2 different trials. One was called Vapor 1 and one was called Vapor 2. Again, if you're going to use Vanquish for prostate cancer, it is still considered experimental. And so the first Vapor 1 was really the first in men trials. It involved a small series of men, 15. They were all treated with focal therapy. And then they were subsequently biopsied to see how successful that therapy was to treat the prostate cancer. And in that first series, 87% of them had good results with non-clinically significant cancer that existed afterwards. There was a low incidence, really less than 5% of erectile dysfunction or urinary incontinence, and it was safe in these patients. So that spurred on the second trial, what we call Vapor 2, This Vapor 2 is currently being published and under study investigation, but certainly I've seen the results of this. And about what they did was they did focal vanquish therapy to use that steam to destroy just part of the prostate, and they re-biopsied only that area of the prostate that they destroyed. Certainly the other invisible parts, MRI invisible parts of the prostate, were not tracked. But when you look at this, they had a 91% clearance of, kind of more aggressive tumor in that area that was treated. And again, a very low incidence of any type of side effects, showing that potential to use steam to treat prostate cancer. And again, when you look at that, you could envision that someday you can do Resume or Vanquish to treat both the BPH and then use the Vanquish to really treat any prostate cancer. So that potential for a 2-in-1, doing both BPH and prostate cancer exists. And again, the advantages here is that this is relatively fast and easy to use. You can do that even in your office. You can, it is assuming the patient is numbed up and comfortable. Certainly you can use that to target those specific regions in the prostate. It's associated with very little, if any, side effects, and certainly sexual side effects. So it has that potential to be a therapy that is incorporated and used more routinely as we progress here. So again, knowing that this is a more minimally invasive type therapy that can ultimately be used. The next treatment that is certainly under investigation and has some evidence both for prostate cancer and BPH is called TULSA-PRO. That has a cool name, and it stands for transurethral ultrasound ablation of the prostate. And again, have a video here to show. Again, got this from the company. We don't need the music here. But ultimately, this uses ultrasound heat energy that can be used to destroy the prostate tissue. It is something that is done under general anesthetic. It is done in an MRI scanner. The general time is about 3 to 4 hours that a patient is in that scanner sedated asleep. And once that patient is sedated or asleep, they have 2 different probes that are inserted into their urethra and rectum. You have a probe that has a ultrasound in it that it can be parked in the prostate, and you also have the ultrasound transrectal imaging. You have a ultrasound in the rectum that is also acting as a cooling device. And so both of those probes are cooled by water. And so they're temperature controlled, so that avoids the potential for that heat energy created by that ultrasound to be spread to adjacent nerves and rectum, etc. But it's really through that trans prostate probe that you see here that you can design a plan that includes either BPH, the juicy part of the prostate, or any tumor that is there. And so this is really that potential that it can treat both of these with that ultrasound energy. Again, it's even more accurate because it's done within an MRI machine. So in real time, you're actually watching that tumor get destroyed, and you are in real time watching the prostate and designing your plan accordingly. And this type of procedure, the TULSA-PRO, has been used both and studied and published on for both benign prostate enlargement as well as prostate cancer, as well as men who have recurrent prostate cancer, or what we call in the salvage setting. And this has been done using more focal or partial gland therapy, and it's also been studied using whole gland ablation. And again, remembering that the more prostate tissue that you destroy, the increased risk for side effects or complications. And again, just to show you some of the data that is out there now, and again, this is still under trial for BPH, but this is something that can be performed, that you put the patient in the scanner, you insert the instrumentation, you design a plan that is really focused in on the transition zone, and you use that ultrasound to ablate it. Usually leave a catheter in for about 6 to 7 days after the procedure. But when you do this procedure, ultimately you improve urinary symptoms. And again, using that same IPSS symptom questionnaire, you have significantly improved urinary symptoms. You have an improved quality of life, max urinary flow, and this has little, if any, effect on any type of sexual function. So again, it has that potential there. This may be somewhat overkill because again, it's a cost that we have to factor in here to use a MRI scanner, but the precision that we can resect tissue is here, and so it does have that potential to be used for BPH. But a lot of this will be come forth with data as we move forward. And again, this is just another example that was done in real time. This is a Turkish patient. He was 63 years old. He was on dual therapy with dutasteride, that 5-alpha reductase inhibitor we talked about, as well as tamsulosin, but he still had persistent urinary symptoms. He had an enlarged prostate. He underwent this TULSA-PRO as part of a trial. And again, within the following year, he reduced his urinary symptoms. He went from really bad urinary symptoms before the procedure to very mild, if any, of those symptoms afterwards. He had, in whatever metric that we used, whether that's urinary flow, whether that's PVR, he had significant improvements in all of those domains, and certainly no change in sexual function. This is also being studied in the prostate cancer realm, both as a focal treatment, but also a whole gland treatment. There have been several studies now involving several hundred patients, and there are good results in terms of their cancer control. About 80% of them remain free of other procedures afterwards. There's very little blood loss or side effects with most of these type of trials. But knowing that the more prostate tissue in that setting, because you are going out to the peripheral zone, the increased risk of potential for side effects. Again, this is just an example here in a patient who has both BPH as well as prostate cancer, that the TULSA-PRO was really able to target all of these lesions. Again, in real-time MRI, you are monitoring this. You're using the cooling devices to mitigate any type of damage to the surrounding tissues. And when you look at these images, initially had a target that you can see here denoted by that PIRADS3 lesion. That area was destroyed, as well as the rest of that transition zone. So this patient improved urinary symptoms, but also treated his prostate cancer throughout that process. So again, a lot of potential here. We have to ultimately weigh that into the practicality of everything, but certainly I think this has a lot of potential to treat both. What I'd like to end this talk on is aquablation. This is something that I'm most familiar with. Again, my disclosure is that I've been highly involved in some of the development of the technique for prostate cancer. But am also an investigator on the current trials for this as well. And so aquablation, again, is not water steam. It's actually a high pressure power washer to get rid of or ablate prostate tissue. And so again, the schematic here, we're going to shut off. Everyone loves to put music on here, so I apologize. But it's a robotic machine that is used in the operating room. This is about anywhere between a 30 to 90-minute procedure, depending on if you're treating for BPH or prostate cancer. And the advantages here is that you image in two different ways. You have an ultrasound probe in that you can image the prostate both in the sagittal, the long plane, as well as the short plane, and you can map out a patient's prostate anatomy, including any type of MRI area. And you can map it out from the inside all the way out to the capsule, the covering of that prostate. You then, after you use the ultrasound and you can map that out on the computer screen, you can insert a camera into the penis and see the prostate on the inside. So in this way, you have simultaneous imaging of the inside of the prostate, but also the ultrasound simultaneously. Once it's positioned, you kind of lock it in place here, which is being shown there. And once it's positioned, you can then activate the water jet, the pressure power washer, and that will talk to the program that you are actually creating here. And so the schematic here is showing how you can create a program that is designed for any individual's prostate, which can include the transition zone, but also has that ability to go to the peripheral zone where the tumor could be. And by this, you can actually design it. The other part of this procedure is that you can identify for non-cancer cases where those ejaculatory ducts come in, and you can preserve all aspects of sexual function, meaning that afterwards, about 90% of men will be able to have forward ejaculation. You have fluid that comes out at the time of orgasm. After the procedure with the water jet is done, you use a separate camera to just make sure that all blood loss is under control as you obtain hemostasis, and then you're done. Typically, men have a catheter in anywhere between 12 hours to several days, depending on if it's a BPH or prostate cancer procedure. But the healing is easier, if you will, in comparison, the best we can tell, because it uses water jet and it's generally heat free. And so where is the data here? Again, this aquablation was really developed for the treatment of urinary symptoms related to BPH. And again, this was recognizing the fact that all prostates are shaped differently. So every man has a different shape or size prostate. And if you had historically a really big prostate, you would use a resective procedure. You would use something like a laser, or you'd make a big incision or a robotic procedure to remove the entire prostate, and that would prioritize symptom relief. But again, you would have a lot of complications, whether that's sexual dysfunction, you would have no fluid when you orgasm, or even erectile dysfunction. But certainly, there are more minimally invasive procedures that certainly didn't remove as much tissue or to remove any tissue at all. So they prioritized, kind of the lack of side effects, but they didn't provide durable relief. And that's really where aquablation came into being, is to say you could design a plan for any size or shape prostate, and you can improve urinary symptoms, but you would also have that ability for men with BPH to preserve all aspects of their sexual function. And again, from the BPH standpoint, this has now been well studied in many, many prospective trials, and certainly their pivotal trial was known as the WATER study. This compared it out of the gate to TERP, the Roto-Rooter, so to say. And in this study, it really set the grounds to say that, yes, it does improve urinary symptoms to the same degree as the historic Roto-Rooter, but it was at the lack of, or without the expense that you would compromise your sexual function. So most patients who had aquablation not only had a durable improvement in urinary symptoms that was sustained over time, but they didn't have any compromise, 90% of them, of their sexual function. And again, this has now been reproduced in many studies. Here's just a list of those studies that have been published to date, and there are many, many more that have been studied. It has been done now in over 100,000 men for BPH. And again, when you use the IPSS, that symptom questionnaire, as a measure of symptom improvement, it is a sustained improvement in urination over time. And so by BPH, it is, in guidelines as an established therapy. And the question is now, in an experimental fashion, can this be used to also treat prostate cancer? We know that it can treat BPH, but can it be used as a prostate cancer therapy? And again, in that same type of equivalent is for BPH, there's a spectrum of prostate sizes and shapes. And if you use the traditional therapies, that whether that's HoLEP, whether that's open prostatectomy, you got a durable symptom response, but you compromise your sexual function. But if you use a less invasive therapy that doesn't get rid of tissue, you prioritized your sexual function and your continence, but you didn't improve your urinary symptoms. So for prostate cancer, the same kind of thing exists, right? Is that we have a spectrum of aggressiveness of prostate tumors. Again, this all resides in the prostate. But if you have a low-risk prostate cancer, a grade group 1, grade group 2, non-aggressive type of tumor, we usually put you on active surveillance. And we say, you know what? You're fine. This tumor is so slow growing, you should be okay. And in that way, it really prioritizes your lifestyle. You have no risk because we're not doing anything. We're just watching you over time. So we're really prioritizing your lifestyle, your erectile function, your continence, but we're not doing anything for your cancer. But if you have a more aggressive tumor, we're prioritizing cancer control. We're saying, hey, you need radical surgery, you need radiation, and those were great to treat prostate cancer, but they compromised your erectile function, your continence, and so there's a lot of similarities here in the treatment strategies for BPH and prostate cancer. And the question is, can aquablation be also used to kind of bridge that? We know that it improves urinary symptoms, but can it also treat the prostate cancer with minimal side effects? And again, that's really where it can hopefully prioritize both. And so when we look at why this happened or what was the rationale, we can look at a large prospective trial that was again done in the UK that looked at men with prostate cancer. Now, most of these men had what we call grade group 2 or Gleason 7 type of cancer, and they were randomized to either active surveillance, radiation, or surgery. Again, this is all historic data, and when we look at men who had, a little bit, intermediate risk, grade group 2 type of prostate cancer, and we looked at their outcomes over 15 years, it really didn't make a difference what we did, whether we watched these men on active surveillance or we treated them initially with prostatectomy or radiation. They all did well. No one really died of prostate cancer in this setting. And whether you started off with active surveillance, you did equally as well. But the caveat, and the devil is all in the details, is that if you started off on active surveillance, over 60% of that men who were initially assigned to just watching it were ultimately treated with either prostatectomy or radiation or hormones at some point throughout that 15-year follow-up. So it is a kind of a conundrum, is to say, we know you're seemingly low risk, but 60% of men are ultimately going to need to be treated. So active surveillance is not just simply a watch and see. It's it's an intentional delay for a lot of men, but ultimately most men are ultimately going to need some therapy. And so is there a space where aquablation can be used to treat prostate cancer? And again, aquablation is different than it's not a focal therapy, and it's not a radical therapy where it would remove the whole thing. It's what we would refer to as more of a subtotal therapy, because it has the ability to get rid of the transition zone tissue, the juicy part, but it can get rid of all of the tissue until the capsule, the shell of the prostate. It leaves the shell. So really the difference between aquablation for prostate cancer and radical therapy is just that the aquablation leaves the shell, and that's where all of the nerves and the muscles live, so you shouldn't have those side effects. And in addition, it's heat-free, so we shouldn't have transmission of that energy to the surrounding tissues, which would potentially compromise that erectile function or those muscles there. So again, this is important because we do know that, as I said, is that 40% of aggressive tumors are missed on the MRI in the current setting. So this has the ability to treat the things that we can see on an MRI, but also treat the invisible areas as well. So it's not a focal therapy, it's a subtotal resection of the prostate. And again, it is because the aquablation has the ability to access and treat the transition zone as well as the peel, the peripheral zone. It can resect 95 to 98% of all prostate tissue, and that really allows us to preserve the prostate capsule, resulting in better safety outcomes. And again, is this safe? We're taking a high pressure power washer and, washing or treating the prostate. Does that, create risk of spread? And to the best of our knowledge and all the experimental data that we have, the answer is no. So if we even look at circulating tumor cells as a surrogate for spreading or metastasis, there is no evidence that this significantly increases the amount of tumor spread or metastasis in doing so. In fact, there would be more tumor cells that are in the bloodstream after surgery, radical surgery, than compared to aquablation. So it is one of those where it is considered safe. There is no evidence to date that this spreads prostate cancer. And again, when you look at the type of defect that is actually created by the water jet, if we take a baseline of prostate here that looks like a kidney bean, if we just do it for BPH, we create a hole in the prostate so that men can pee better. We get rid of that transition zone. But for cancer, we truly get rid of all of that tissue from the inner all the way to the shell of that prostate, and we preserve the nerves and the muscles for continence in that process. And again, just highlighting here the amount of tissue that's actually resected. And again, we've studied this in many different ways. One of the first reports was from our group. This was a retrospective analysis where we looked at 3 different groups of patients. We looked at patients who had just benign prostate hyperplasia, BPH only. They didn't have cancer, and they received aquablation per standard of care treatment. We had a second group of patients who had both BPH and low risk grade group 1 prostate cancer. And then we had a third group of patients who had only prostate cancer who were undergoing active surveillance, and they were matched in terms of their grade group low risk prostate cancer. And when we looked at the outcomes here, we first asked the question is, do we have similar outcomes? If you do aquablation among men with both BPH and prostate cancer, do you have the same degree of improvement in urinary symptoms? And the answer is yes. Whether you do aquablation for BPH or in men with both BPH and prostate cancer, you have the same degree of improvements in urinary symptoms, quality of life, as well as maximum urinary flow. So again, this is not that surprising, but certainly a positive signal to say we're not doing any harm, we're only improving urinary symptoms. And again, the type of protocol and of aquablation procedure that was used in this initial study was more like a BPH plan. But even just doing a more minimal aquablation among men with prostate cancer has positive cancer control outcomes. So this was unexpected, but we decreased the risk of having upgrading events so that their cancer was getting worse over a 5-year period by just 44% over that 5 years. Again, such a suggestion that you can use aquablation to treat for prostate cancer as well. No evidence of any kind of spread, and these patients not only improved their urinary symptoms, but also received the benefit that their cancer actually was treated potentially in that process. Now, since that study, there have been many other studies that have been performed. One of them is called PRCT 001. This was patients that are about 124 patients that were recruited and treated for this trial. They had both urinary symptoms as well as prostate cancer. This was all studied and recorded. Again, most of the patients in the study had either grade group 2 or grade group 3 prostate cancer. Most of these had tumors in the peripheral zone or the peripheral zone and transition zone. So most of them were in the peel of that prostate, which was expected. And when we looked and we said, well, if they had aquablation, did that impact any of their other outcomes? So we know, and we compared this to men who underwent radical surgery. And you said, well, if we look at historic data sets and studies, it is known that if you have radical surgery, not aquablation, if you have radical surgery, that you have a significant impairment in your erectile function. But among men who were in the PRCT 001 study who had aquablation, there was really no change in erectile function that occurred over time. So none of these men had impairment in their erectile function over time. Again, a positive indicator saying we can do aquablation and a cancer treatment that without the compromise of any type of erectile function. Now, all of these men have retrograde or anejaculation because we're intentionally getting rid of their ejaculatory ducts, but they still have the ability to have normal erections, normal function and sensation that is no different than before the aquablation. What about risk of urinary incontinence? There is no risk of urinary incontinence after aquablation that is sustained the best we can tell. And if we compare this to after radical surgery, where we remove the whole prostate, including the shell of that prostate, there's a significant risk of leaking urine afterwards. But again, when you look at the PRCT 001 data, certainly at a year afterwards, no one has any significant leakage out of the 120 some patients that were treated in that study. What about urinary symptoms? Again, very similar results to what I showed in our active surveillance cohort, that if you have aquablation, you are going to improve your urinary symptoms over time. Even men who say initially they don't have a lot of urinary symptoms, they themselves continue to improve in terms of their overall severity of urinary symptoms post-operatively. What about the need for other treatments? Is it effective, or do we do this and other patients need to, you're going to shortly do radical surgery or radiation afterwards? And again, when you compare this to the prostatectomy cohorts, the risk of needing subsequent therapies is extremely low. Even years later, we have treated very few patients in the PRCT 001 study cohort after aquablation. Again, showing from a cancer standpoint, aquablation is offering a viable cancer control surgery. And so the Water 4 trial, which just actually finished accruing actually within the past few months, is the trial we're most excited of to see the results. This was a international trial over 33 urology sites accrued patients for this. These were 280 patients that were either assigned to aquablation or radical prostatectomy in a randomized fashion. 3 in a ratio of 3-to-1, so 3 aquablations to every 1 radical surgery. And the cool part about this trial is it's certainly looking at cancer control. We want to compare cancer control and aquablation to radical surgery. But more importantly, we want to also look over a 10-year time period of how much harm, if you will, or how many side effects are done to patients in each of these arms. So if you start off with aquablation and you do well and you don't have any erectile dysfunction or you don't have any incontinence, we're going to record all that. But if you have aquablation and it fails and you need other therapies and you end up needing radical surgery or radiation and you subsequently have side effects related to that, all of that is going to be recorded. So we'll be able to compare the total amount of side effects or harm in the aquablation arm compared to a radical prostatectomy arm in a randomized trial fashion. So we're really excited to see these results as they move forth, and certainly we'll be able to share with this group over time as the data becomes more forthcoming. And so I've talked a lot here, but I'm really excited about these possibilities because we do know that the prostate itself really does nothing good after reproductive years. It either enlarges and causes urinary symptoms or gets prostate cancer or, for, some men, both of these throughout, a man's lifetime. And really, the current standard treatments are really insufficient, right? They are good at cancer control for prostate cancer, but they are associated with side effects. And so if there's a way that we could use treatments that we can take from the BPH realm and improve urinary symptoms, but don't increase the risk of side effects and also treat prostate cancer, I think that there's a lot of potential there. And whether we're talking about Vanquish or TULSA-PRO, aquablation, I think all of these will find the right spot. And I think that all of them have potential to treat both simultaneously. And so again, just to emphasize that these are not considered standard of care as of yet, but data as it accumulates from these studies will help change our guidelines. And so again, right now, I wouldn't rush out to get these, but it is one of those where that potential exists. And so certainly if there are trials and you're interested, you can look to participate. But I think really to emphasize my overall enthusiasm that there are new emerging therapies that can really influence the outcomes of both BPH and prostate cancer are there. So with that, thank you for the opportunity today because I've really enjoyed putting this together and I'm so excited about the data as it comes forth. Thank you.
I love that lecture, the 2-for-1. First of all, I'll tell you, I had to go downstairs in my basement. I will never look at an orange the same way. Never. You use the word orange and juicy about 6 times. So now it kind of makes me want an orange, but not also wants me to stay away from an orange. Does that make sense?
100, like why we talk so much about the prostate and related to fruit or different sizes. It's amazing from a nut to a grapefruit to a, God knows what, a mango. I don't know.
Right. And you had a slide with the avocado, and I'm going, I don't want the avocado, but I know that anyway. So I thought I would show you, I don't know if Peter has the 2 pictures. I thought I'd show you 2 pictures of my dog during your lecture. Do you want to see it?
Of course. Big dog guy.
Okay, that's number 1. And let's go with number 2. And let me explain why this is important because we know that male dogs also have prostate. See? But in both cases, if you notice, he's not sleeping. He's actually paying attention to your lecture. So I know you gave a great lecture because it was a great lecture. But second of all, when my dog pays attention to a lecture, then I know it's a super great lecture. Is that helpful?
Yeah, I mean, you're going to say shortly that your dog has no eyelids, so it's you can't really tell. But
he's literally right in front of me. You just can't see. And before we get into the nitty gritty, I do like to do my quick quiz just to make sure you're up to date on your knowledge. Dr. Helfand, who won the 2026 NCAA National Basketball Championship? Who's number 1 in the country?
You're just going to take credit there.
No, I'm not taking credit. It's just a basic. I just thought of a quiz question.
I know I should know that right off the bat because I watched the whole dang thing.
Yeah.
It wasn't Michigan, was it? Was it?
You only have a chance for 1 answer.
In Michigan, but it was Michigan. That's why you love them.
Is that what you're going with?
Michigan. I've kind of put that out of my my memory so quickly, but
your answer is correct. Our second national championship. The first one was I basically was in college. Thank you for answering that. Quiz question number 2. Michigan plays Ohio State in anything. Which team do you like more? And you have to pick one. It doesn't matter if you dislike both of them.
Well, so my son goes to Indiana. So I've become a huge Indiana fan, although historically I was the biggest Michigan fan. But now that Indiana eats my tuition, I It's a tough call, but I will say I will still go with Michigan for sure over Ohio State. No loyalty to Ohio State.
Correct answer. I like Ohio State some days, but not the day we play them, that's for sure.
I had to bring up the football championship because I now feel part of that.
I mean, it's cool. I didn't know that. So you know what? Michigan plays Indiana at home this year. So maybe you want to give me a call.
For sure, for sure.
Yeah, they are on our schedule. So I'm excited for them. That's exciting. Your son goes to Indiana. That's a great school. All right, you ready for question number 3? I talked with Dr. Helfand, MD, PhD. I want to highlight the PhD because I told him the story where I was only about a half a year away from getting a PhD and I bailed. I was supposed to get a PhD in pathology and then I got accepted into med school and I've always wanted to go back and get it. And so I'm always jealous of MD PhDs because I wanted to be one. And I'm an MD MPH. So it kind of annoys me that he got an MD PhD and I didn't. But that's for my therapist and not you. All right. Are you ready? So what I'm going to tell the audience is we talked with Dr. Helfand about doing the first ever lecture of possible BPH technologies that could also treat prostate cancer. So that's why when he covered those 3 technologies, that had never been done before that I had seen at a medical meeting or a patient advocacy meeting. So he delivered the first one and it's awesome. It just gets you excited for the simultaneous treatment because BPH and prostate cancer simultaneously happen so often. But what we wanted to do for the rest of the time we had, which is about an hour or so, is I just kind of want to go through the landscape of BPH, all the treatment options, things to ask about if you're going to be treated, things to think about, nuances from beginning to end there, A to Z, we call it. But at the same time, we're going to do something as a part 2 down the road because we're not going to be able to cover a large portion of it. So he doesn't know what's coming. He has no idea. He never has any idea what's coming. We don't tell him. But let's just start at the beginning and then we'll move finally through all the different treatments. Does that sound good? All right. Here's a really actually question I've never seen posed on a website or a BPH company. And I think this is pretty significant. I don't know if you want to comment on it. What's the number 1 cause of hydronephrosis, which can lead to damage or kidney failure in adult men? What's the number 1 cause in adult men of a condition that can actually lead to kidney failure and kidney loss? And guess what the answer is based on your lecture today? You know the answer. It's a rhetorical for you. It's BPH. And the reason I think that that's an incredible statistic is that people kind of think of BPH as this little nuance, like it's a little bee or a mosquito. Get away from me. But really, I wish somebody, and I've seen this in a couple sites, I wish somebody would summarize the things that can go wrong with BPH that don't get enough attention. So I'm going to walk through this and you walk through it with me. I'm changing the name of BPH to a bad bum prostate needs some help. Get that? Bad bum prostate needs help. So feel free to pass that on. Look at these and I want you to comment even briefly or not at all, whatever you want. Some of these men experience symptoms day and night. It's not just, people talk about getting up at night, but they literally have to go all during the day. And that completely changes your quality of life.
Yeah, I think when you typically ask about urinary symptoms, the most bothersome one, and we've studied this, if you ask guys to choose one symptom and you say, well, what's the one that disrupts your life the most people refer to the nighttime voiding. But we fail to recognize that during the day, because we're up and about and we typically have access to washrooms, but that we go more frequently or we go urgently or certainly if you start leaking urine, that's when it really gets bothersome. So all of that is all associated or can be associated with an enlarged prostate.
What about bladder muscle injury? It's really sort of a scary issue. I mean, the bladder muscle itself can become damaged, and I know you've probably dealt with that. And then there's bladder stones, little pouches can appear in the bladder infections, and then we'll talk about acute urinary retention in a minute. But I don't know if you wanted to comment on some of these. These are serious potential consequences of having BPH.
Yeah, I think recognizing the bladder is a muscle. And so certainly that with any muscle, if you stress it, it's going to respond and it's going to get stronger, or we think, before it kind of poops out. And so certainly, if you block the bladder from emptying and because you have a prostate enlargement, or it could be other causes, but that certainly that the muscles of that bladder initially respond and they get stronger and stronger, and you get more muscle than you actually need. And at some point, the bladder really just becomes really angry and really annoyed that it can't do any more muscle, and it kind of just poops out. And that's where it becomes kind of what atonic, or it doesn't really function. And that's really when it's kind of late stage, or it's not as reversible as during that process. And we don't always recognize it because unfortunately the symptoms that you have as we progress, they get worse, but at some point you kind of just a lot of men just kind of accept it for like, this is the way I'm supposed to live, or this is the way it's always been. And so because of that, that's the big issue here, is recognizing early on that if we intervene. I think early intervention, kind of first signs that we have worsening of urinary symptoms, that's when the discussion should start about saying, hey, how bad are we? And how can we make sure that your bladder maintains its health, its happiness, so that you can function and not have all these other things that, that you get, urine that builds up, so that urine, the chemicals kind of precipitate out and form stones, or the muscles actually out pooch from the bladder, causing diverticula there, or that urine is just sitting in your bladder because it's not emptying and you get infection. All of this stuff is really, all related to the fact that the bladder is unhappy and it can't empty appropriately.
These are seriously damaging moments when you reach some of these, right? I mean, you can equate some of these to just other organs in the body, whether it's the bladder muscle injury or hypertrophy, like you might see for example, in the heart muscle, which has such extreme consequences. Or possibly, you mentioned the diverticula. When people think diverticula, they think of the large intestine. They think, oh, I'm going to get diverticulitis. They don't realize it happens in other places like the bladder and can be a problem. But the one that gets a lot of the attention, and if you can comment on this, and I put down here, it's a medical emergency. The one that scares me, besides the kidney damage, as I'm at the age of BPH, is acute urinary retention. Can you comment on that, and why every time a patient reads a website, it says acute urinary retention can happen with BPH, and then there's an asterisk that says medical emergency? But is it explained? Can you explain that, and do you see it?
Yeah, we see it all the time. In fact, there are several, if not many, cases that show up to our emergency room on a daily basis. And it can happen for many reasons, but usually the most common reason is that your bladder has not been emptying well for many, many years. And there's something that kind of is the tipping point that pushes that patient over, whether that's constipation, whether that's stress, whether that's a drug that they take. There's something that just acts as that additional little push that really stops the bladder from totally emptying. And that urine continues to build up and build up and build up in the bladder. And just like a balloon, you get the sensation it's about to pop. Now, it typically doesn't pop, but in that process, as it's building up that pressure, the patient feels that they are so uncomfortable. They feel like they just had a big 7-Eleven gulp Slurpee, and they just can't get it out. And they rush, and it is an emergency because that patient is so, so uncomfortable, and they need to have relief. And the way that we relieve it is by inserting a catheter. The catheter itself is, again, they're needed. We use them all the time in urology. But when you talk to patients about experiences that they typically would like to avoid, it is having a catheter, something that passively drains their urine. Often patients will describe that as humiliating. It's an uncomfortable experience. It's not severely painful per se, certainly better than not being able to pee, but it is something that most men would like to avoid.
Yeah, no, I appreciate that. I mean, these are just some of the reasons that I wish maybe we should put it on our website. These are some of the reasons when it gets very serious. And We like to kind of joke up getting how many times I get up at night, but some of the consequences that you see, I just wanted to list them and have you comment on them. So I appreciate that. Thank you. The next thing I want you to comment on that everybody needs to discuss before they embark on any BPH treatment is what is the slide that you showed. And hopefully this gives it justice, because even when you break down guidelines from AUA or other places, they do it by prostate size. They mention prostate size. And so here's the 4 categories that you hear all the time. You hear about the small, that's the walnut or the grape. So you got me thinking about fruit. Average, kiwi size, maybe golf ball. Large, orange, tennis ball. And then you got super large. You have avocado picture. I have a pickleball. I don't play pickleball. I just thought that'd be interesting to put a pickleball in there, but that's not exactly right because there's a lot of holes in a pickleball.
A lot of holes in.
Yeah. And then, so I don't know if you want to comment on, people need to know the size of their prostate going into the potential treatment, right?
Correct. And so that's really where we can personalize or cater a surgical treatment or even medical treatment, sometimes based on your prostate volume or size. But I also like to bring up prostate size is that just because you have a big prostate, it doesn't mean that you have urinary symptoms. And just because you have a small one doesn't mean you have no symptoms. And so that correlation between size and symptoms or severity is really loose. But you are certainly more likely to have urinary symptoms if you have a bigger prostate. It's just not a guarantee. So it's not doom and gloom if you find out that you're just genetically blessed that you have a big prostate. Does not mean that you will have urinary symptoms.
Don't you think if some doctor says, look, I want to do this X procedure on your average size or small prostate or large or very large, don't you want to ask specifically, hey, what's the data with people with that kind of prostate size specifically, right? Because that's what guidelines does. It breaks down treatment according to prostate size.
It does, but I think the decision to intervene or do stuff, it depends on your size and certainly the indications, but it also depends on so many other variables on what's going on. So again, I always caution, be wary if someone you just look at a size or an image and you suggest a treatment or anything like that.
Yeah. Okay. We're moving at a nice clip. The other thing I think people have to know besides their prostate size, and by the way, let me preface that, and you can comment if you want. I always thought it was comical that you can guess a prostate size you have to tell me if there's new data, by DRE. I mean, the DRE doesn't really tell you prostate size like an imaging test would, like an ultrasound or an MRI. I think one of the greatest beauties of an MRI, ultrasound, PET CT is they can tell you with good accuracy what your prostate size is. The idea that a finger tells you that, it's just, I mean, tell me if I'm wrong. I haven't looked at the data, but it was almost like a flip of the coin.
It is very much like a flip of the coin. And the truth is that we're really bad. Even with ultrasounds, even with MRIs, we still don't truly know what the best way to get a true estimate of the volume is. Because with an ultrasound, it depends on how much compression you give. It depends if there's swelling. For the MRI, it depends on the blood flow, and that even can change in size and shape. And so certainly somewhere probably between ultrasound and MRI is most correlated with the prostate size at the time of a prostatectomy. But the digital exam is a little bit like trying to estimate the size of an iceberg by just looking at the tip.
Interesting.
So you just don't really get a great example. I mean, we all know if you have a huge prostate, we kind of know what that feels like sometimes, but not always. And certainly, sometimes with a small prostate, there's a lot that can be hidden under that surface because all you're feeling is the backside of the prostate through the rectum.
The other thing I thought patients need to know is you referred to it too as a symptom score, but people don't realize this. Here's one of them. The AUA has one too, but they basically say the same thing. It's called IPSS, and it's a symptom score. You fill it out, and then you give it to your doctor, and you can fill it out before your first appointment. You can fill it out after your treatment. There's all different types. And if you want to comment on it, basically what these symptom scores do when you fill them out and you talk about your symptoms is that if your score the lower is better, and lower is better after your treatment too. So 0 to 7 means you have mildly symptomatic. You could call it mild BPH. 8 to 19 is moderate, and then the 20 to 35 is severe. The reason these symptom scores are great is, like I say, you can do them at home. You can bring them in when you go see Dr. Helfand. And, the area where you're talking about, where the treatments that you're suggesting, if you're a candidate, these are the people that have moderate or really severe symptoms, right? I mean, we're not talking about mild. So what's your, this is kind of, I know, a softball question, but what's your feeling on patients filling this out before they see you, or do you just give this to everybody anyway?
I give it to everyone because I'm a data person, but I think it's a starting point or conversation. But certainly, I think the questionnaires are largely in suffice. There's problems with them. They don't capture a lot of things that are bothersome for patients. I think symptoms like even dribbling after you urinate or leaking urine or pain aren't captured in those symptoms. And certainly, to give a little kudos to the group I'm part of and helped develop. There's a different questionnaire called the Learn Symptom Index. It's developed as part of an NIH government initiative where we now include a lot of those other symptoms in there. So I encourage people to use them because I do think it's a little bit more accurate. On the other hand is we still have a discordance. Some people will report mild urinary symptoms, like maybe get up, 2 times a night, but the
Yes.
bother associated with that is tremendous. And so that's really what we have to distinguish is that I don't care so much about what that symptom score says, although a lot of insurance companies do. But I don't really care. I just it gives us a starting point for a conversation to identify do you have symptoms or not, and are you bothered by it? Because if you're bothered by it, there are certainly things that we can do. And identifying the cause of your urinary symptoms and is, helpful when you have a questionnaire like that to say, are you only getting up in the middle of the night or do you have daytime symptoms? And so a lot of that factors in to help us come up and come to the conclusion that your problem originates in your prostate, not because of all these other factors.
This Learn questionnaire, is that something on loan? Can we have it on the website, or do we have to link it? I mean,
It is free. It is linked. I think you can find it on through the NIH website. It's certainly online as well. And it is truly, there are 2 forms of it. There's what's called the Learn SI10 or Learn Symptom Index 10, which is meant for everyday use in the clinic. And then there's a longer form of it, the Learn SI29, which is really meant more for research. So it is one of those where that really allows us to better characterize or subtype, kind of a lot of the symptoms that men are having, and women for that matter, and allows us to treat you that much more.
Can you send us the SI10 after this Q&A?
Definitely can.
I mean, you know why? Because I remember last time we were doing, for those of you who haven't seen us before, we've done a couple different topics together. We did one on genetics, and we did he did a long lecture on genetics and prostate cancer. And I don't know, we started talking about BPH. This may be a year and a half, 2 years ago. I remember you brought up Learn then, and I didn't chase it down. And so now it's time to chase it down.
It's time to chase it down. I think it's a much improved form. And that's
Okay, I like that. But I also find with this IPSS that everybody uses in clinical trial, I find it very interesting that the last question is always on number 7 is always getting up at night, nocturia. Okay. Here's the problem I have with this question. You tell me true or false. Is this the biggest fib ever told? I hardly ever wake up at night to go to the bathroom. In other words, should it be a requirement that the final question that asks you about how many times you get up in the past month, for example, should that be one that's also commented on by the partner that you're with?
100%.
Because how many times has the person said this small number and the partner goes, what? It's much greater than that. I know because you wake me up. What say you?
I mean, as a stereotype, the male gender is we're just as a stereotype, tend to understate a lot of what we experience. And half of it is just because I don't know if we're being stoic, but the other half is that it generally is a very slow process. So typically people don't, have these events happen just overnight, but it's just a slow kind of thing that happens over the course of months and years, et cetera. And so because it's so slow, we often don't realize or recognize, we just kind of accept like, hey, this is just kind of what's become of, what I expect out of urination. And so because of that, a lot of men are just like, this is the way it's supposed to be. I knew my grandfather had similar issues or my father, so I just kind of go forth there. And so it's a recognition that things aren't like the way when I was 20. If that's
Yeah.
typically what men will, when you ask them about it, they will typically say, well, I'm fine, but I don't pee like I was when I was 20. And so that's really the opportunity to say like, hey, there are changes here, and these are physiological changes that happen in almost every single man. We can do better.
Well put. All right, so let me ask you about some other things that people should at least have some kind of minimal knowledge on when they're talking BPH treatments of any kind. There's this thing you're going to hear about a lot. Look, I don't ask you to comment, but I don't know, when you were doing the lecture and I was writing, my slides, I thought the IPSS, it sounds a lot like IPISS. I don't know. It's just
Oh,
strange
for sure. You can call it the IPIS score. I think it's the best.
It is, right? I mean, it's really so this thing comes up a lot, PVR, post void residual. Can you tell me about that? Obviously, you want a lower number, but tell me why I want a lower number as opposed to a higher number, and how do you actually get that number before your procedure?
So the way that it works is that a man would typically void,
Yeah.
go to the bathroom, and then we come and we do an ultrasound measurement so it's not invasive, it's just not you typically on the abdomen, on the belly, and you image the how much urine is actually left in the bladder. And so it's a non-invasive way where we can see how well your bladder is actually functioning. And ideally, if there's such a thing, that a normal value is really any post-void residual less than 50 mils. Certainly, that's in the ideal world, and there are many men who have much higher values than that, and they can function and do extremely well. But why we care about it is that the higher your value is somewhat predictive of the chances of you going into urine retention. So
Mm.
you have higher residual volumes, typically have bladders that have been, over muscularized, if you will, or not as functioning as well. And so they are at higher risk of having issues related to a blockage of their bladder.
Do you like to pull a post void residual on anyone that comes into your office and says, I think I have bad BPH?
My clinic is very focused on what I do because this is all related to BPH and prostate cancer. So almost everyone who walks in the door typically will get a uroflow and a post-void residual. They will be
Uh-huh.
filling out more questionnaires than they'd ever
Give
want
out the
to.
questionnaires. Hopefully not the
Just
questionnaire
trying to,
that's got the 20-some question. It's the 10 questions.
right.
So when you say, so that means we've covered just about everything you cover, except that's my next question. Flow rates. They call it a QMAX. Flow rates. Can you explain how you get that? Because flow rates are very much tied to BPH and how you're doing in terms of objectively, in terms of the severity of your BPH or not. Because when you were young, you had great flow. Everybody had great flow, right? It was impressive. If you stood up to use the restroom, there was wonderful flow rates. And then as you get older, it seems to slow down. So tell me why you go after flow rates and how you do them.
So it's actually kind of fun, actually. And
Really?
there's a lot of people who can turn it into a game or a competition because what the point of a Euro flow or a flow rate is to have you void to pee and to actually assess how fast you empty your bladder. So the actual speed or rate at which you empty your bladder. And we call that a Q max, the maximum force that you or rate that you generate as you empty your bladder. And so you can envision when you're young and you have no obstructing prostate that your flow is very fast because
Yes.
there's nothing blocking you. But as that prostate enlarges and they kind of strangulate, if you will, the bladder opening, that flow rate will actually slow down. And so certainly any flow rate that is less than 15 milliliters per second is the start of saying, hey, it's obstructed. And the slower and slower that flow gets, when you get to 2 to 3 mils per second, is dribbling out. And we can actually measure that. And you can actually, as you pee into a funnel, it'll actually record that speed in real time, and you can see the pattern and the flow by which you empty your bladder. And so it's something that we actually routinely get and study, and you can tell to some degree if a patient is blocked or not blocked by their prostate based on that. I say it's fun because again, there are a lot of people can compete, and I always say if you put that in a sports arena and you put that in the bathroom, you will actually get saying like, well, I peed this fast and I peed this. So it can be kind of fun. The other cool thing about flow rates is that these days we've involved a lot of technology. So it is possible, and there are apps that are available that you can go online and download onto your phone that you can actually just set your phone in the bathroom. It's not recording anything visually.
Yeah.
It's truly just listening to the sound by which your urine hits the water, and it actually can estimate a flow rate there. So
Really?
things like that are certainly evolving, and potentially those are more accurate than the ones you do in the office because it represents more real world and can kind of pick up on the patterns that you do versus sometimes when you come to the urologist's office, you've already peed, even though we tell you not to pee, you pee ahead of time, and we're forcing you in many ways to void, and that kind of sets up an artificial setting. So there's a lot of studies investigating that as we go on.
I had no idea there's an app for flow rate, and well, it doesn't surprise me. There's an app for everything, right? But it surprises me that you think the app might be accurate. So obviously, I thought, what does he mean by competition? I got to go look at some of these apps now. That's
I
unbelievable.
feel like I may get an invite from you to
Yeah.
compete. This is great. This is great.
Well, because I really I think it's interesting because if you really pay attention to flow rate and you pay attention to when it's slow versus when it's fast, it all sort of makes sense to me. I know this is really strange, and I'm going off topic for a brief moment. I'm going to pull you back. When I was training for the marathon and I was doing really nice long runs, my flow rate was completely different. The number had to have been higher. Let me just put it that way. And I would always think, that actually makes sense in terms of blood pressure reduction, in terms of the heart healthy effect of just coming off a run. But if I didn't run for about 6 or 7 rates, I felt like the flow rate wasn't as good. Bottom line of what I'm saying is everything we want to learn ourselves. So I might pick up one of these apps and see if that's true. So,
try it out. Try it out.
All right, maybe you and I might have to compete. You're younger than me, but still, I'm willing to compete on flow rate with anyone. I don't know why, because it's a competition. All right. Last but not least, here's a word that's thrown out there all the time. My dad used to mention it, and it sounds so invasive, and a lot of people don't like to do it, or they don't want to go to this level. But can you just explain briefly? Urodynamic testing is a whole series of testing. So you'll hear this sometimes from a lot of videos. I've watched a lot of videos before you came on, and people go, well, we'll do urodynamics once in a while, just sometimes. We'll do this. And I'm going, but you're not defining what urodynamics is. What is it, and why do people only use it occasionally?
So urodynamics is a more sophisticated, if you will, way where we can look at pressures that are generated by your bladder. We can see how well it's actually squeezing and the type of pressures that it generates. We can see if you're obstructed because you've an enlarged prostate, the pressures in the bladder, as an example, would be greater. We can also pick up how fast it's going out, etc. It's a somewhat invasive test, meaning that you would come to the office. We would put little tiny electrodes, little wires that we insert through the penis into the bladder. We put other probe pads around you to kind of get the pressures that are generated in your belly and rectum, etc. And so it is useful sometimes, and sometimes because of its artificial nature, where we're putting little electrodes there, people
Yeah.
don't, perform as well. But it can give additional insight into, the overall pressures generated as well as the rates at which the flow of urine is happening. They're good for sorting out really complex patients, meaning
Okay.
if you have like neurologic disease and you said, well, you're not emptying, is that really because you have Parkinson's or is that because you have an enlarged prostate? So sometimes when you have, kind of a lot of medical comorbidities that all contribute to urinary symptoms, you can use that to sort it out. I don't use urodynamics as much as some other urologists, just based on my preference. I don't. I think sometimes it's too artificial, where I'm not so comfortable with the results. In particular, a lot of people will even use it if men can't pee because they've gone into urine retention and they want to see, does your bladder have any capacity to generate, a stream, or what is the pressures generated? And so if people fail that test, then they kind of say, well, your bladder doesn't work, and so you should have a catheter forever. And I
Yeah.
don't subscribe to that. I actually think that even men who don't do well on that test, if you alleviate their prostate, that most of those patients will actually improve and be able to void to some capacity. So it is one of those where, people have varying opinions. It's actually in urology still somewhat
Yes.
controversial about how people use it, when to use it. But I think that everyone has to become comfortable with the information that they generate. And if you generate a certain amount of information, what are you going to do differently, or how is that going to change the management of that patient? And so, in my opinion, for my practice, urodynamic results typically don't change that much more than just obtaining a simple uroflow, which is non-invasive, period.
Oh, that's awesome. That's awesome because so you obviously don't do urodynamics on everybody you're going to take for a procedure or like aquablation. You
Absolutely.
rely because I go to meetings where half the people talk. It's like the piñata of urology, and the other people say it's the greatest thing since sliced bread. And I'm going, what am I missing here? Some people love it, but I think you summarize that interesting. So it goes back to flow rate, right? It goes back to the app.
And
You
again,
you need to start your own app called the Health Fan Flow Rate,
but
and you got me in on half
I
the
love
half
it.
the money.
And my middle name is Todd, so people
Oh,
like to say instead of BPH, it's BTH. I mean, there's a lot of cool things that we can do there. So, but I do think that BPH, just like prostate cancer, it's not just a single test that will tell you this is what has to happen, but it's
yeah.
really kind of a collective data set that you gather that will really kind of help conclude that this is you can't pee well because of an enlarged prostate. And whether that's the IPSS score, whether that's the PSA, whether that's your Euroflow, it's your PVR. There's so many things that can add to that picture that really kind of push you to say, hey, you would benefit from a surgical intervention.
The next part I'm going to go on to, again, I apologize to the audience, but this is stuff I don't see covered a lot. And one thing I don't see covered a lot, and I've learned a lot in the past few months as I was preparing for this, is lifestyle behavioral changes need love before pill and with pills. Now, I'll tell you why I decided to ask, I decided to ask Google what doctor came up with heart healthy is prostate healthy, and my name came up. I should have patented that. I
You
would have
should
made a
have.
fortune. And they referred to my 2003 article in a journal and that I used it in talks. I'm thinking, that should have been my app. Anyway, enough about me and more about what I'm peed off about. No pun intended. This is so interesting to me. So in AUA guidelines, for those of you who don't know, they just updated the guidelines, and there's some pretty dramatic statements. And one actually to me was for patients with BPH, clinicians should provide lifestyle interventions prior to initiating pharmacologic treatment. That's now a moderate recommendation. So here's some of the things that are recommended in all these different societies, and then I want you to comment on it in a moment. But fluid control. So you don't drink as much fluid, especially a few hours before bed. Everybody picks on caffeine and alcohol. That's a bummer, right? I love my espresso. I love my caffeine. I can sometimes go without alcohol. That's perfectly fine. And then a double void, bladder retaining, pelvic floor exercises, kind of like Kegels, but also maybe meeting with a physical therapist. And before I talk about constipation, do you want to comment on any of these, like this double void thing? The double void thing is you go, right? And then you wait 30 seconds or so, and then you go again.
And you try to empty better. If you first don't succeed, try and try again. So, I think a lot of these we have to understand how we live, and everyone has to be comfortable with their life and what you do in that during your daytime out and nighttime hours, to say. And what I mean by that is that a lot of what we do, especially as men, are avoidance behaviors, right? We recognize that there's a problem, and we're all admitting that there's a problem. We're not addressing the cause of that problem, but what we're doing is to say, well, if this is bothersome for you, then we can put Band-Aids on it. You can stop drinking those fluids. You can stop drinking caffeine. And they do work. They do modify, your urination. And certainly there are men who come in and say, Brian, I have 10 cups of coffee a day. And I said, well, that's a lot of coffee. Do you need so much coffee? And I said, for those guys, it would be appropriate to limit or to change around, the consistency about what they're drinking during the day. But that's not sufficient for everyone. And certainly when you identify factors that need to be modified, lifestyle issues, you should modify them. But how can we prevent that even earlier on, which is probably the subject of a different conversation.
That's a different conversation, but yeah.
But it's to say, like, hey, you know that you are predisposed. Your father had an enlarged prostate, even prostate cancer for that matter, or your grandfather, and you say, well, what can you do to help prevent it? And certainly the things that you can do, speaking of heart healthy, are stay active early on. Don't become overweight. Don't become diabetic. These are all factors that we know that contribute to the development ultimately of urinary symptoms and perhaps an enlarged prostate. So act early on. If you know it's a thing, I mean, again, this is for overall health, but certainly it does speak to urinary symptoms as well, as be proactive in that regard. Avoidance behaviors, once you have the problem, aren't wrong. It's just, again, it's not necessarily correcting the issue. You've already created the issue, and so how can we better fix it at that point? But if we can prevent it, that's really what we'd like to do.
But I'll tell you where this made me fall off my chair. You ready for this? If you look at the changes in some of the things that we just talked about that you should look for, that you're seeing improvement, whether it's flow rate, whether it's the IPSS questionnaire, if you look at the changes, they're not dramatic, but in some clinical trials, they were enough to compete with prescription therapy in some cases, and they were enough, in my opinion, to compete with a lot of the over-the-counters. And so I decided to go look in chat rooms where people say, I started this new over-the-counter, or I started this new prescription med, and it's working great. And a lot of them will say, but I also reduced my caffeine. Oh, I also reduced my fluid. So what I'm saying is, this would be the greatest thing ever that drug companies and supplement companies would have to compete against, because then it would tell me whether or not I truly need a pill. Am I wrong? This is what I took away and makes me wacky.
No, none of that is wrong. None of that is wrong. And again, you're already at the point where you're intervening. And certainly it's a lot of this kind of intervention, it's free. Right?
Exactly.
And it's just changing your lifestyle around to accommodate that. And most people, when you say, like, listen, you could do this, or I could give you a pill and that you're going to have potential side effects, and what most people should choose lifestyle. But it doesn't even mean that even if you decide to give a medicine or surgery, we believe, and unfortunately, there's just not a lot of controlled trials on this, that if you modify your lifestyle at the
Yes.
same time that you do these other therapies, you're going to be double or if not triple the effect. And so it is one of those where these are low-hanging fruit again because you don't have to do anything other than just don't have that extra drink before bed or try to empty your bladder better. So I do think that they can be effective at the same time.
I'm not going to say most. I don't think that many people know about all these little things they can do, including what you mentioned. And I highlighted this, avoiding constipation. People need to understand that constipation pushes on the bladder. It's right there, hanging out right behind the bladder. And it can make you have that urge that sometimes you feel with overactive bladder. It can make you just want to go. And so it makes healthy sense, heart healthy sense to avoid constipation. And so, but people don't necessarily tie that into their BPH symptoms. But I guess I'm going to move on because I could be on this for 3 hours. Why isn't everybody in every clinic given these minimally and say, I want you to do these with or without over the counter. I want you to do these with or without the prescription. I want you to do these with or without aquablation or resume. Why don't we do that, or do we do that?
We do a bad job of it. We do a
Okay,
bad job
that
of
makes
it.
me feel
And
better.
as a whole, right, is that we make the assumption that it's easier and that people will comply potentially more if you give them a medicine or intervention. That's unfortunately the nature of so much of medicine. And that's a whole different conspiracy theory. But it is one of those where, yes, there are natural ways to at least improve some of it.
When I was getting older, there was a very famous BPH doctor that wrote an article. You would know this person's name. Several could be attributed to this, so I won't give the exact name. They basically said, we have so many patients taking over the counters and prescriptions that really are sort of watchful waiting patients, behavioral. They're the ones who are least likely to benefit. In other words, they're not the ones who need it. And I don't know if you concur with that. I'll never forget that line. Never forget that. And it's nothing against the prescriptions over the counters, but I just wish this was given equal time because it helps men. And I wonder if I get aquablation and I do these things. For example, if I get aquablation and I don't gain weight, is my procedure going to last longer? If I don't have metabolic syndrome, like, in other words, if I'm obese or heavy set and I get aquablation from Dr. Healthfan and I go on a GLP-1 or I don't gain any more weight, is that procedure going to be more successful over 10 years, the same or less?
That's again, I am 100% on board, and I believe the answer would be yes, because we do know that people have better controlled, sugars, less metabolic syndrome, are theoretically have better outcomes in every single aspect. So it is one of those where sometimes using urination as a starting point to kind of improve your overall lifestyle habits, make you healthier, it
Yeah.
has a lot of bang for the buck. I mean, the other low-hanging fruit that I always harp on, if patients have sleep apnea or they have diabetes, is like getting those under control or treating them improves their urinary symptoms. Even though, again, they're so far away and then people don't typically associate with them, we do know that sleep apnea increases your risk of irritative symptoms, urgency, getting up in the middle of the night, frequency. And by getting that under control can help and even alleviate a lot of the other, need for interventions for your urination. So it is one of those where same thing kind of concept with diabetes, extra sugars irritate the bladder, if you will.
Yeah.
And so, getting that under control helps people with their irritative symptoms as well. So understanding this in the scheme of stuff, it's not just prostate. We have to look at the whole person and the other, kind of medical issues that they have. Because whether we're talking about BPH or prostate cancer, getting that under control will improve your overall outcomes.
Exactly. It was 2012. Here's the actual abstract. Dr. Parsons, we know these names. Dr. Parsons did a paper on men on finasteride who were obese or the implication was as they gained weight, the drug was less effective. Same thing with dutasteride, published in 2013 in European Urology. This has been sitting out here for over a decade. And it's like, what are we doing with it? Anyway, I thought you'd find it interesting if I did a quick literature search on statin as a meta-analysis in BPH. And if you look at that on PubMed, for example, the only meta-analysis done with statins suggested that men on a statin drug, a cholesterol-lowering drug, the hint was overall in the meta-analysis that it slowed the progression of BPH. I don't know how you feel about that. I don't know if you think that low cholesterol doesn't make your prostate get as big, or if you've looked into that, but I find that fascinating.
I mean, the hope or potential for statins, and again, it hasn't really fallen out one way or the other, is that it may not just be the cholesterol, but maybe their anti-inflammatory properties. And so sometimes anti-inflammatories, inflammation of the prostate, can lead to an enlargement by various mechanisms. So getting that under control, whether that's through statins or other type of anti-inflammatories, is still possible.
I find the whole pill game with BPH, I just find it incredibly fascinating. All right. There's the new pill. I don't know anyone. I've mentioned this to residents. There's a new pill trying to get approved for nocturia, getting up at night. And I'm sure they're going to target BPH patients, where it's a combination of ibuprofen, we've heard of that, and acetaminophen. And it's kind of fascinating because it reduces your filtration rate, so you make less urine. And so the idea of taking something like that it's got its own controversies, but everybody's trying to develop a pill in the BPH game, coming at it from a variety of angles. So you gave me the idea for this, and we're going to talk about pills now, and then we're just going to talk about treatments and spend the rest of the time on it. And we're doing quite well in terms of time. I appreciate your pithy, curt responses. You use the word wild, wild west when it comes to interventions. I use wild, wild west, east, north, south when it comes to pills. This whole pill game is making me wacky. I'm not just talking about pharmaceuticals. I'm talking about, in the area I love so much, over the counters, right? So let's talk prescriptions first, and then let's play the game. Here's my favorite game. I even made a sign for you because you're going to love this. It's called Let's Play My Favorite Game. You can't handle the truth, like that's from the movie. But no bogus science allowed. So I decided that when it comes to interviewing you and all my good buddies, I want them to stay objective. So I should have reversed it. I'm no longer going to call it the pros and cons. I'm going to call it the cons and the pros, about the cons first before they know about the pros. Let's talk about alpha blockers. We still hear the name Flomax. We hear the name Rapaflow, alpha blockers to help relax the prostate. Tell me what you think, just off the top of your head, the cons are at first and the pros. Just any, doesn't have to be the whole list. People can go Google that. But in your opinion, in a clinical situation, when you think of Flomax and you think of Alfuzacin and Rapaflow and all these, tell me what you think the con that comes up in your brain, and then the pro.
So the cons is that how many people don't have side effects and are compliant with it. So meaning that I think the evidence kind of speaks for itself of how many people, if you give a drug, stay on the drug for long term. And the overall compliance rate for alpha blockers is that anywhere within 1 year, 50 to 87% of men will stop taking that drug. So is it really that good? And the real reason, when you start asking patients, why did you stop that drug, comes down to three bins. Is it, number one, it didn't really change any of my urinary symptoms. I took it for a while. I didn't notice a change. So ineffective. Why did I take the pill? And they stopped taking it. Two, is that patients get, and what they complain most about is what we call retrograde ejaculation. And that's what I was referring to in the talk a little bit, is to say when patients orgasm, that there's fluid that comes out. And typically, we didn't have a lot of treatment options. So we recognized that it occurred, but we didn't tell patients or even care if that happened, because it doesn't hurt or harm your health. But if patients are not expecting, that this is a known side effect of an alpha blocker, and then they go and they have an orgasm and nothing comes out, they think that something is wrong. And so they immediately will stop that medication.
Yeah.
Even if you tell them about it, there are some men who just say, "Hey, I'm taking this. I'm experiencing retrograde ejaculation. I don't like the feel of it. I'm stopping that medication." And even if you take men, and we did the survey, who are not sexually active, and you say, "Well, we're going to do a treatment that that has the ability to preserve that," most people, even if you're not sexually active, want to preserve that sexual function. So the concept of an alpha blocker that knowingly gets rid of it anywhere between 15 to 85% of the time, well, actually is a turnoff for a lot of guys. And again, depends on which alpha blocker is being utilized. Some
Yeah.
are, the frequency of retrograde ejaculation is variable. The last thing that people typically will complain about is either lightheadedness. I took the pill and I felt like I either passed out or I got lightheadedness, so I stopped it. And finally, nasal congestion, which is another known side effect. So those are all cons to it when you know that if you do something more, like surgery, you'll get a bigger bang for your buck in terms of symptom improvement.
And that lightheadedness, well, let me just go through those. I mean, some people don't notice their flow rate changes. Or some men do the behavioral changes with that, and then they give credit to the drug sometimes, and it's actually the behavioral. I know it can be vice versa. The REJ, the dreaded REJ, retrograde ejaculation, it's a dry orgasm. Let's call it what it is. It's a dry orgasm. It freaks people out. It can freak people out, but it doesn't mean there's a dysfunction. It just means you have a dry orgasm, right? Like happens with the radical prostatectomy. And then they have options there. They can switch the drug, like you said. Some people do every other day. So they have all these options, but still, that's a scary thing. The third thing you mentioned was orthostatic hypotension. You get up and you're dizzy, right? And that's scary because you get older. That can create a fall.
And it's not infrequent. It's not that not like a one-time thing that I've heard that some guy started that medicine and they fell down. You hear about it. It definitely happens. And if you look at the insert, that it can occur anywhere between 1% to 15% of patients taking those medicines. So it's important to understand that that can happen.
That was a really good con. Those are really good cons. Now you scared me more than I should be. What's the pro? What's the pro?
The pro is that for some men, that it can improve urinary symptoms to a degree that they're happy with, and it can keep you happy in terms of the symptom severity and or bother. So again, it doesn't mean that your prostate won't continue to grow if you're an alpha blocker, and at some point you needed some other therapy, but it can serve to be a non-interventional band-aid that you can use for some, if not sometime, if not forever, to treat your urinary symptoms.
What you might find, you probably know this, because you got the PhD and I didn't get it. So that's going to keep coming
You're
up.
handing them out for me. Don't worry.
I wanted those letters, man. I earned them. What's interesting in the preventive medicine public health world, my world, is that someone that's got really bad blood pressure issues, this will change with the newer blood pressure medicines. They got some pretty serious BPH issues who don't want a procedure. Sometimes they go back on the old BPH drugs because it gives them good blood pressure reduction as well as some symptom improvement. You probably remember the days. I mean, I'm not that much older than you, for Cardura and Terazacin. And so I have found that interesting, how some of the cardiologists will lean on that. If someone's got BPH and needs blood pressure reduction, they might go to one of those older meds. So these are interesting pros. Any other pros that you can think of? I mean, I feel like we did a lot of cons, but I didn't expect that many cons. Or should we move on to 5-alpha reductase inhibitors?
We can move on to the 5-alpha reductase inhibitors. So these are the dutasteride and the finasteride. They shrink your prostate because they can inhibit the local action of testosterone or dihydrotestosterone in the prostate. And so they are used often for men with larger prostates. They have been shown in several trials that they can help prevent the progression of BPH, meaning that the chances of you having subsequent urine retention or bladder stones or infections is significantly decreased if you use these medicines, either alone or certainly in combination with alpha blockers. But they themselves are not free, and certainly there are, potentials for side effects. The desired side effect is that they can help hair growth, so that's a good thing. But more importantly, the more frequently you'll hear is that they can be associated with erectile dysfunction or sexual dysfunction. And so again, it's one of those where we always caution patients, if you started and you notice any change in erections, stop those drugs. Certainly, there are groups around that are devoted to exposing all of the downsides to those. They're online. You can see
Yeah,
them.
I mean, but this is a very, this is an interesting group that I'm watching that they're not happy
They're
with
they're because
and
sometimes it can even be permanent, and sometimes.
exactly. And I, they've got an argument to whatever degree. I mean, these drugs and they take a long time to work. I mean, I think the guidelines say, give it 6 months or whatnot, and you have to have a prostate larger than 30 cc's. We go back to the size. And the cool thing about alpha blockers is don't you see when they work for a patient, they work within a week or two, right? But these side effects, the cons of these dutasteride and finasteride, and I know it can grow hair at 1 milligram. It's called Propecia, and it can reduce your PSA by half, which you have to account for. But do you use many in your actual clinic anymore?
I don't, largely because I don't think from a symptom standpoint they really change symptoms all that much. They take
Yeah.
about 6 months before they actually kick in. Certainly, there are some patients who swear by them, but I am always a little bit cautious of them. It
Yeah.
has been shown, and it hasn't been many studies, but in kind of one study that there is a longer term risk of dementia with the long term use of them. So again, I just don't like to manipulate hormones if I can avoid it.
Unless you have to. Yeah.
And the other part about that is when you look at their use is that since that, it did not get FDA approval for prostate cancer prevention, the overall use, at least in our healthcare system, has declined significantly. So they are still used, and it's not wrong to use, but I think at least having that conversation with your provider is important to say like, hey, do we want to use this or not? What are the risks and benefits? And is this really changing, kind of my progression in terms of urinary symptoms, or are there other alternatives which may be either better or just as equivalent?
Along those lines, Cialis got this indication to Tadalafil, the ED drug, erectile dysfunction drug, got an indication that it might help relax the prostate. You can use it for people at BPH and erectile dysfunction. Yay, you can take this drug. What are the cons of that? First, let me ask you this first. Before you tell me your personal cons, do you believe it works that well?
I personally don't think it works to the same degree as alpha blockers.
Okay.
But on the
Yeah.
other hand, I certainly think it's not wrong to do. And some people, when you talk about the potential cons of alpha blockers and you compare that to Cialis, mini dose daily, people would rather try the Cialis first. So I've been using it a lot more, not only because it helps potentially the urination and objectively patients will come in and say that they have significant improvements, and if you look at their uroflow, it's faster. But I think it works nicely in conjunction with alpha blockers, and certainly there are studies which show that they work really nicely together as well. And you get the added benefit of having erectile, dysfunction therapy simultaneously. So because I'm not a huge medicine person, time we can simplify meds and get a 2-for-1, kind of different than the 2-for-1 we were talking about in the talk today.
Yeah.
I'm always for that.
Do you have people that want to come off of it because of side effects, Cialis? for BPH, or is that a very small number?
I have more men who will come in and say they have side effects from Cialis at higher doses.
Okay.
But certainly there are still that risk where you're going to have nasal congestion, potentially muscle aches, and or having, reflux, GERD, when they eat foods, et cetera, when they're on that. So it is something that we always caution patients to say, if you have that, that's because of this drug, and we can talk about, kind of treatments or changing that if you experience them.
Quick word on the cons and pros of the overactive bladder drugs that are pushed on urologists to give to their patients who might have overactive bladder. Do you use
A
these?
lot. Yeah, I do try to avoid them, because when you look at certainly even the overactive bladder guidelines, there is certainly caution there. They're still widely used, but really the risk and the long-term risk of having dementia and other type of side effects has been well established. Even the ones that are specific for just the bladder, mirabegron, varibegron, those are still in that same type of class there. So it is one of those where, we have to always caution because there are side effects there. A lot of the true anticholinergics, whether they're in the, kind of even tertiary or quaternary amine, kind of more advanced design therapy, they still
Yeah.
have the risk of dry eyes, dry mouth, constipation. And so it is one of those where the use of it, we have to be selective, especially in older men, who are at risk of having dementia or kind of mental or cognitive changes anyways. So use if needed, but use them sparingly. Do explore other alternatives, whether that's behavioral to start with, physical therapy, certainly even things like Botox, InterStim, et cetera, when indicated. But if your primary cause of having an overactive bladder, your bladder is going either, and you're having a lot more urgency, frequency, getting up in the middle of the night, if the primary causes can be addressed in other ways, you should certainly address them before. And if it's the prostate, again, I'm more apt to do a different type of intervention, prostate, kind of outlet procedure versus any anticholinergic or medication in that way.
You know that I've done teaching on this. You know that I talk about the pros and cons of it. I don't. Do you want to talk about whether or not you have people do this? The cons, these are some of the leading selling type products for BPH that are supplements over the counter. Do you use them, or do you have people take them, or what are the cons and pros in your mind? Or do you want to cover?
There are very little cons. I think that, when it comes to most type of natural supplements that you can get over the counter, most of them, they're not going to do harm. With some caution is that it's not a regulated industry, and some of them, whether the active ingredient or the supplements that they put into those, may be associated with other bad things. Some may thin your blood, etc. So have some caution there. But as terms of a treatment for BPH, there generally is very little con. Most people don't come in with side effects or problems because of those natural supplements. The
Yeah.
question ultimately is the efficacy. And because they're not regulated in the same way that, kind of the traditional pharmaceuticals are, that we have the alpha blockers, et cetera, they haven't been formulated in a standard way, or certainly studied in a standard way. And so
Yeah.
we don't really know if the saw palmetto that one man takes is the same as the saw palmetto the other, and it makes it hard to actually compare, is that effective or not. Certainly, it was part of the Camus trial, and when we look at that, is that this was a randomized trial of 2 different doses of saw palmetto versus placebo, that we didn't see any difference there. But on the other hand, is if patients come in and they say, you know what, Brian, like I've started taking saw palmetto, it's effective, I'm not going to stop them. And so
Right.
certainly, I do think that if something is effective and it has no harm, continue on with it. And it's not wrong to explore and see if something is effective there. So again, have no problem with any of those. It's just the caveat that they're not necessarily, even in our study, the saw palmetto we use isn't the same that you may get elsewhere. So it is one of those where look at them and evaluate if it's effective or not. And if it's not effective, stop it, because I don't think you should waste your money on something that doesn't work. But I don't think that there's a lot of harm to it.
As a fan of supplements for specific conditions that have data where the pros exceed the cons, I would still like to see prescriptions or a supplement go up against behavioral. I want to see what the difference is, because when I look at the meta-analyses, you see slight differences, but I would like that would be the true test, right? Because the side effect that I have to deal with a lot if I'm talking to someone is sometimes the side effect's your wallet. Because the price range, I mean, people will argue that mine should cost X amount. I still tell residents that if it costs more than Costco, you have to ask why it does. And what that means is that a lot of Costco products I have no relationship with Costco, except I have a membership with Costco and other clubs. I do mega shopping. They do have quality control seals, many of them do. And now there's some salt palmettos that have a USP seal. There's one in particular. I don't want to give too much. So great. If you try that, you try that. But I do want to mention the trial that you did mention against placebo. This is the Camus trial. Isn't it incredible? This was 2011. This was published. This massive trial using 3 times the average dosage. It started at 360, doubled it, then went another, then went to another. I mean, 320, I'm sorry, and then doubled it, and then went up one more actual dosage. And this was done over a year and a half. And then there was Stephen Bent's trial. I can't believe, as I was looking, it was 2006. But the problem we deal with is in Europe, they have a prescription saw palmetto that gets a lot of love and a lot of attention because they say it's different from the American type. But I think the take home for me, and I think you gave a good answer, is, and this is what I've learned through my career and through life, is that I hate to say this, but the more invasive on a procedure, the more dramatic the effect. I mean, the reason I like to bring up flow rates and all these other things, IPSS, because when they see any of these procedures that we're about to talk about in a minute, you see these results when they work well. They're like this. Wow. And then with the pills, they're like this. People don't understand that you can take a severe BPH person and make them a mild BPH person from a procedure that's gone well. Whereas you're lucky with a pill, prescription-wise and otherwise, if you take someone with severe and you just move that needle just a little bit, right?
Right. And not only are you not moving it that much, so the degree of improvement is not ever going to be as great as surgery, but you got to do something every day. Every day you got to take a pill. And so for me, this again, everyone's different. I don't like pills. I would rather find something else, whether it's lifestyle. But if I'm gonna do something, I would rather have a one and done, big improvement, reset the clock to the time when I'm 20, and move on with my life.
Well, that's a great segue, because we're going to talk about the cons, because you don't get a free pass, right? If we're going to talk about the cons of pills, but I agree with you. I think you take a pill when you need a pill. And this idea that you just pop pills, I mean, to figure out whether or not you need a pill takes some analysis. So this is our last section. You title it actually the Wild Wild West. This is a Wild Wild West. I just wrote down 10 or 11 of the latest treatments that gets attention on the websites. You talked about essentially 3 of them. And we're going to start. We do it alphabetically, not because you're good at this. It's because I do everything alphabetically.
Alphabet soup of BPH treatments.
Alphabet soup. So we have aquablation, whole lip. We're going to go through all these PVP, Optilume. I want to talk about this. So all we're going to do for the rest of the time is, for anybody watching, this is almost its own segment. I just want to talk the same way we talked about pills, behavior. I want people to know the cons up front and some of the advantages. And I want to share with you some of the ones I found too. And I want you to comment on them, because I don't know how accurate I am, because I don't do these. So we're going to start, if you don't mind, with aqua ablation. It sounds like a movie. It sounds like Aquaman. I don't know if you've seen Aquaman. I have not seen
it. I'm a big superhero fan. So
okay, you have seen Aquaman?
It's good. It's good. Yeah.
It's good?
Yeah,
I did not expect that as an answer. That's sort of a stunning answer from you.
There we go.
Okay. But I got cons. I got cons, hell fan, and
I
I
like it.
got
I like
pros.
it.
And why don't you let me comment on the cons? Because this is what I've seen other websites who don't like you. I'm not saying you. They don't like what you offer because they're selling what they sell. That's why we call it the Wild Wild West. This is so confusing. If you thought over the counter and pills were confusing, just immerse yourself in this mess. So now I'm going to tell you some of the cons I've read in multiple places, and then you can comment on them, then we'll talk pros. Okay, I don't want general anesthesia. I don't want to stay in the hospital overnight. This is aquablation. I don't want a catheter sticking in my penis for days. There's a bleeding risk, something sexual, and I'm going to get a UTI. So I decided to mention the ones on the website. I don't want anesthesia. I don't want this. I don't want that. Do you have any comment on that before we talk about the pros?
Right. So in general, aquablation itself can be done under spinal anesthetic, where you just have a numbing medicine that's delivered, so you can't move the bottom half of you, but you're awake and breathing on your own. And so that can be done if you have a fear there. Otherwise, it's still most commonly done under general anesthetic because as you make your precise plan during the aquablation procedure, that you just can't move. And certainly if you're awake, it's quite stimulating. So that's the reason why you need the general anesthetic. Does that limit people? In general, no. Most guys that, as they think about a procedure on their prostate are like, I don't want to be aware of anything happening during the procedure. And so for most guys that I see, that's not a turnoff, but certainly that would be a con there if you are stuck on it and you don't want a spinal and you don't want general and you're looking for an office-based procedure, aquablation would not be that type of procedure you'd want to undergo.
Interesting. This whole idea with the spinal, though, that's where it's moving toward. What's
No, again, it just depends on preference and things like that.
Yeah.
Some people love it under spinal, just like they did TERPs under spinal. I am someone that thinks that general, if I was going to have it, general is the way I would do it. Not like a full intubated tube, just kind of a tube at the back of your mouth, what we call an LMA.
But how long am I knocked out for?
For a BPH procedure, the average wheels in, wheels out time, at least in my series, is about 40 minutes. So it's one of those where it's not a typically long procedure, and again, that's one of the beauties of that compared to a lot of the other resective procedures that get rid of prostate tissue. It's actually pretty quick to do and perform.
Okay, you want to hear the pros I found and tell me which ones are wrong or right? There's a new guideline telling urologists that now you can get aquablation not just with a medium-sized prostate, but with a very large prostate. Now they're recognizing that aquablation can be done with large prostates. And then they're also saying with or without a median lobe obstruction, which I'm going to have you mention in a moment. What that means, you get very impressive. I mean, very impressive response in terms of the IPSS and your flow rates that we talked about, minimal risk of incontinence ED, minimal risk of retrograde ejaculation. And now you're studying it to treat prostate cancer. I don't know if you want to comment on this. Can you comment on why you need to find out if you've got a problem with your median lobe and your prostate? Is it true that aquablation can treat men that have very large median lobes? Is that true?
Yeah, so a lot of the data that was limiting first of all, the size of prostates was because when they did the first two trials, they only went up to 150 grams, which still is very impressive. But they did everything by the books, and so the limit in the first two trials was up to 150, even though they've had data for a long time that you can do any size. In fact, I think the largest prostate that was ever done was about 1,200 grams. So you can handle any size or shape. Again, the beauty of aquablation is it truly allows you, because it's all under ultrasound visualization, you can handle any size or shape prostate and design a treatment plan for that prostate. So it's personalized in that way. And again, if you have a median lobe, there's actually a separate setting on the device that actually plans and precisely cuts that median lobe and treats that median lobe. Again, the median lobe is just that protrusion that about 30% of men will have a significant degree of that extends into the bladder. I always think it acts as a ball valve and inhibits from really emptying their bladder appropriately. It's very easy to treat, but aquablation is actually designed for that. And in that design, and again, because everything is under direct visualization, you can kind of see where those ejaculatory ducts come in, or at least approximate that when you look at the prostate. So when you do a treatment plan, you plan for that, meaning that there's a protection zone at the top part of your prostate where those ejaculatory ducts come in. And that really permits that at least 90% or more of the time that you can actually save someone from having that retrograde or anejaculation. When the orgasm, it's not dry, they actually will have some fluid that comes out. Now, admittedly, it's usually a decreased amount of fluid that comes out. And even though we do plan, there's still about 10% of guys who it's not perfect, or it's maybe perhaps are still lack of understanding that they still will have that. So there's no guarantees in this world, but most men, 90%, when I look at our series, will actually have and maintain that ability to have fluid and not have a dry ejaculate.
And is the data suggesting one and done?
So
you get one procedure and you're done, or is there a lot of retreatment going on?
So when we look at the durability, it's one of the most durable procedures. Of course, there's been a learning curve, and this is a newer procedure, meaning that it's only been out now just shy of 10 years, which seems like a long time, but it's still pretty short when we want to look at the 20-year outcomes, and that's going to be a lot more informative. But certainly in the 5-year data, and this is when the procedure wasn't even perfected, the retreatment rate was actually extraordinarily low, less than 1%, which when you compare it to TERP in that same series, that was actually much higher at 2+%. So it is one of those where it is still a low retreatment rate, about 1% a year. When you look at the national average and over 100,000 patients, the retreatment rate is about 0.4 to 0.7% a year. When you compare that to other modalities, it's certainly beating most other modalities based on what it is. We don't yet know how it's going to compare to things like hold up, which we'll talk about soon. But it's one of those where certainly it's at least equivalent, if not better than TERP, which is really still considered for many people the gold standard.
What if I'm on active surveillance? I've got a Gleason 3+3, maybe a little bit of 4, and I want this procedure. You'll do it?
So it's a little tricky, and it depends on the indication. So the FDA currently views aquablation as you can do it among men who have urinary symptoms, who have or don't have prostate cancer, and use it as a treatment for BPH. Specifically, as a prostate cancer treatment itself, it's not indicated for. That's why these trials are existing, kind of currently. Now, the only caveat there is that Medicare, inappropriately, and I'll say that very boldly, hasn't updated their guidelines, unfortunately. And it's a government agency, and I truly think that they're dragging their feet because they unfairly selected aquablation because they didn't include prostate cancer patients in their original BPH trials. And so if you have prostate cancer and urinary symptoms and you're Medicare, they currently, as of today, June 5th, 2026, do not permit you to get aquablation.
Interesting.
It is a injustice that hopefully they will continue to reevaluate, but I continue to call them out because there is no other technology that they really have singled out in that way.
But when you take all this tissue out, do you test this tissue?
Yeah, so typically you do the aquablation procedure, and then it will go and do kind of a hemostatic step, meaning you'll take a resectoscope, whether bipolar or monopolar, and then kind of just clean up at the bladder or neck. And so you do get tissue that is sent for pathology. Typically, it's usually only a few grams of tissue, so not large amounts. Based on the location by which you're doing this, and based on the fact that most of my patients are well-screened prostate cancer cohort, that the incidence of incidental prostate cancer, what we call T1A or T1B prostate cancer, is in my series about 1.7%. So it's very rare.
Yeah.
And certainly the tissue is viable and able to be processed in that way. So I send it out because I'm a data guy and I like to know, but it is pretty rare. But certainly using a standard BPH technique, it's not one of those where we get a lot. Most of that tissue is actually destroyed from the aquablation.
How many procedures have you done to date? Roughly.
Roughly over 800 something procedures.
So you're coming close to 1,000.
Correct.
I have watched you, we attend some of the same meetings, and I have watched you say, this is where you and I have a different path, and you're still going to disagree with me today, and I'm okay with it. You say one of the advantages of aquablation, one of the pros is the learning curve is not too steep. You can learn this easily. And what I said to you last time, and I'll continue to say it, my rebuttal to that is I would rather have the guy or gal that's done 1,000 or close to 1,000 than the guy who's done 10 or a gal who's done 10. Well, because I'm just saying, now that you're dealing with prostates that are very large, and prostates aren't just about size, they're also about shape, they're also about complications, anticoagulants, you name all these different variables. I want the experienced person, be that you or someone else that's done hundreds. What do you disagree with me on that still?
Well, I agree and I disagree. Well, so what I agree upon is that I'm a believer, for good or bad, and I don't say this in a selfish way, I truly don't, but I think the data speaks for itself, is that no matter what you do in this world, someone who specializes in any area is going to have better outcomes because they do it repeatedly, time and time again. So do I think that there is a difference between a high volume center and a low volume center? 100%. And I don't care if you're talking about BPH procedures. I don't care if you're talking about prostate cancer procedures, kidney stones, heart disease, whatever it is.
Right.
Specialists are going to, have better outcomes if they do something over and over again. On the other hand, is when you look at this country, it's impossible to have specialists everywhere. And when you take a technology like aquablation, it truly democratizes that BPH procedure because everyone's still looking at an ultrasound and you're using visualization that most urologists can recognize, what should be accomplished and not accomplished during that procedure. So in that way, the learning curve is actually pretty easy because it's using technologies and techniques that we all do every day, whether it's ultrasounds or cystoscopes or things like that. So that's helped out a lot. And when you compare that to the learning curve of HoLEP, which is really involved, it's night and day. And I bring that one up in particular because that is in my opinion a very niche type surgery, is that you really need to spend a lot of time, perhaps even a fellowship, and really learn that technique. Even urologists who have done 250 of those cases still are learning. Even 500, it's shown that the learning curve kind of persists. So it's not one of those that you can kind of dabble in, some of these techniques. Versus aquablation, you need between 10 to 20 and you're pretty good at it. So again, I still think that there's a difference between someone who does a procedure all the time, but if you're going to have a procedure, aquablation does represent a much more consistent outcome because the learning curve is great.
I mean, I appreciate that, but I'm still asking how many, whoever it is, I'm still asking how many they've done.
As you should.
Patient advocacy till the very end. I got to know the number. And if someone goes, I do them all the time, but I've done 25, I'm going, get me out of here. But that's a whole other thing. And you talked about HoLEP. That's next. That's next on our, and here's what I have briefly. Retrograde ejaculation is common with HoLEP. We know overnight hospital stay, post-procedure catheter, but I also put learning curve. Learning curve is incredibly steep. Here's a classic case where you want someone who's done a lot of them. And then I put pros. It's size independent. You can take big prostate, small prostate, right? Impressive numbers in the experienced person. I know men who have been on AS, for example, active surveillance that have been treated. And so I just gave this. Any comments on your specific cons and pros? You definitely honed in on the learning curve. So anything else?
I think the learning curve important part of it. I think that there's not a standard technique that is used. And so, people, no matter, everyone who's theoretically an expert in this will have their own variation on what should or shouldn't happen. Earlier release, if they're going to nucleate in pieces, the whole thing, do they start at the top or the bottom part of there's so many variations of it, and it's
Yeah.
hard to kind of compare. And because of that, even the randomized trials, you still are getting, various chefs, if you will, and techniques in there. And so they're trying to now modify the technique a little bit to decrease the amount of sexual dysfunction. But most men will have retrograde ejaculation or anejaculation with it, even with modified techniques. Again, if you look at Europe, they will still say it's not important, although it is mentioned no less. The importance of retrograde or sexual dysfunction should be discussed with patients at least 34 times in the European guidelines, but certain Europeans still insist it's not an important thing that they talk about with their patients. I do think that other parts of the HOLEP are the chances of you having, whether temporary or permanent, stress incontinence is a big con. My prostate cancer patients don't want to leak. I always look and say, well, my BPH patients are doing this for lifestyle alone. Why would they want to leak? So if you cough or you sneeze after having a HOLEP procedure, at 3 months, whether it's between 15 to 30% of patients will still have some degree of stress incontinence. And so that's a tough thing for me to sell to a patient personally, because again, historically, my patients didn't really enjoy that kind of recovery curve. So I think between the sexual dysfunction and the stress incontinence, it's really kind of a harder sell for me or my patients. It's a very good procedure. It's associated with the max amount of symptom relief because you're truly getting and enucleating all of the parts of the prostate, the transition zone that has to go. But I think that, it's very durable. I think it competes against, kind of true open enucleation or robotic enucleation, simple prostatectomy. But on the other hand, I think that does come at a compromise. And so when you talk to a patient and you talk about risk benefits, and when you talk about durability, certainly it wins. Symptom relief, I think it wins. But I think when you look at the possibility of side effects, whether that's sexual or whether that's incontinence, I think it, in my opinion, still comes short.
I mean, that's fair enough, I think. But I think what all these procedures have in common that we're talking about, including yours, is that the goal is to get men off of all meds,
100%. And I
all
think
over the counters. And that's your experience, right? That when it's successfully done in your case or HOLEP, they're off
get off of those meds and don't ever restart them.
and they don't restart them. And that should be advertised more, honestly. This is one that's getting a lot of attention. Optilume. Do you want to explain Optilume? We're just going to do a couple of these, the cons and the pros of Optilume. And what I put is, if you got an obstruction medium low, we can't have a really large prostate, no long-term data. But the pros are an in-office procedure. So can you explain Optilume? It's a balloon that expands
Well,
the
it's
area,
not,
right?
it's still not routinely done in office. It's more commonly still done in the operating room. It has the potential to be done in the office. It's
point.
done where you take a camera, you go and you see the prostate on the inside. You then extend out a deflated balloon that you kind of secure in place, and then you basically use that balloon to basically stretch out the prostate itself so much so that it causes what's called an anterior commissurotomy, where it basically rips the top part of the prostate open. You then exchange, at the same time, it then releases a chemotherapy, a Taxol, which then prevents kind of scar tissue, if you will, from forming and kind of keeps that prostate theoretically more open. In itself, even though it takes a lot longer to describe the procedure, it's a pretty quick procedure.
Yeah.
takes, 10 minutes to do in the operating room. You do have a catheter in for, several days afterwards. But, patients, do well. The initial shorter term data look very promising, but it's really not for all sizes and shape. And certainly, as you mentioned, limited by prostate volume or median lobe. Although those are being, kind of investigated, in real time as we speak. But it is one of those, has some potential. I don't think it's for everyone. And again, my caution is that lessons learned from past is that because it doesn't remove tissue, we don't know how durable it will actually be.
Prostatic artery embolization. All right, let me help here with the cons. When I looked at retreatment rates, they weren't super low. Okay, first of all, then you needed the interventional radiologist that does a ton of these, and then it depends on your blood supply. And look, I'm saying this because I'm always wary of anything when it comes to this. There reimbursement clouding? I do think before you talk about your cons and pros, I'm not trying to make a statement. I do think that people should know that there's a very large reimbursement for it. I do think people should know that. If a procedure has a large reimbursement, is it possible that sometimes clouds your thinking and you want to do a ton of them and you turn into a factory versus something that you get reimbursed a couple $100s for? I think patients should know that part of the hype in this is not just, it could be fiscal, it could be not, but to certainly not discuss it is not fair. I think that's the piece. However, I am excited about the data on very large prostates in terms of minimal toxicity, impressive improvements in flow rates and IPSS. And right now, they're looking at it to treat prostate cancer one day, and they might look at it for chronic prostatitis one day. So it is exciting on that side, but there are some cons and pros. What do you think?
Number one is I do think, just to start off and jump on that bandwagon, is that most BPH procedures, the surgeon will get several $100s, $400, $500 to do a procedure, because they're generally quick and the way that reimbursement has gone. This, in comparison, is on the order of $14,000. So again, when you look at reimbursements in today's world, it's hard to ignore that maybe not be a motivating factor there. I think the data is very mixed when it comes to PAE. I think that ultimately a lot of factors, as you brought up, confound it, and it's difficult to interpret. And a lot of the studies that have been performed don't utilize the validated questionnaires, the IPSS, the AUA scores, et cetera, that we're kind of used to. Of the available data we have, again, it kind of looks promising, although again, there's been a lot of call to attention about, whether those really reflect the real world or not, or whether that's actually a true, kind of treatment for BPH. Again, the theory is that you go and disrupt the blood supply to the prostate, and that ultimately by disrupting that blood supply, it shrinks the prostate and alleviates some of that obstruction. Of course, if you have a median lobe or other components, it really wouldn't impact that at all. So certainly it's limited based on prostate anatomy. It's limited based on the vascular supply to the prostate, and certainly limited based on the interventional radiology experience in selectively embolizing or cutting off that blood supply to the prostate. So because of that, I do have some caution in terms of outcomes. And when you look at the retreatment rates, they're anywhere between 50 to 80% within the first year after having done it. A lot of men, are attracted to it because it's touted as a minimally invasive, even though you still have to go and access those arteries. But there's no incisions, if you will, proper into the prostate. And so some people are, kind of falsely or attracted to it. But I do put caution out there, or at least have that conversation with that provider about the sole effectiveness of PAE for the alleviation of men with urinary symptoms because of their prostate. And certainly if you're in retention, how many men has it actually gotten out of retention and stayed out of retention permanently? So again, the use of it is increasing. I can't comment on whether it's right or wrong or the true motivations for it. But again, I think that some caution or discussion should be had based on the available data that's available today. HoLEP, aquablation, Optilume are all have been studied in randomized trials in very controlled settings. And so because of that, I'm more confident and comfortable with the data and offering it to patients and seeing how they, kind of and being confident that they will result in the desired outcomes. So it's just a PAE. I just doesn't have that same comfort level as of today, based on what we know.
I think that's a fair assessment. And I think that we would agree on one thing. I think we'd agree that what I've learned, like with HoLEP, is that if you're going to do PAE, prostatic artery embolization, and you got to find an interventional radiologist. If it's me and I'm excited about PAE, I'm finding the interventional radiologist that does it 24/7 and has done a ton of the procedures. And I think the top ones out there, whether they're from New York or other places, would agree with that statement. You better find someone that's doing these all the time because this is not a simple procedure. You got to know the anatomy. You got to know how to the pluses and minuses of the different collaterals and the anatomical changes with the different sized prostate. So I think we agree on that, right? You better find someone who is the top dog or dogette. I'm not going to have you go anymore on unless you want to just do your one minute on each. I think you covered Resume well. It's fascinating. I've got my own pros and cons. Do you want to give a few? Can we finish up with just 2 or 3 more and just give 1 minute cons and pros, and we'll cover more in our course when we do this later. Resume water vapor thermal therapy. You covered it. It's a potential option they're looking at in prostate treatment. It's not for really large prostates. But it's an in-office procedure, right?
Correct, and certainly median lobes. There are some, and the data support that it does have good outcomes. The caution I have is that the recovery sometimes is a con because of the steam and the convection energy. There's a lot of tissue sloughing. So
Yeah.
sometimes for several months, patients will have tissue clumps that come out, and that it can be a negative factor there. So again, it's not wrong to do, but certainly some caution and explanation of that before you engage and explain that to patients.
Hey, by the way, this is what we'll cover later on. What do you do with guys with penile prosthesis, for example, or artificial urinary sphincters? I mean, in other words, people have things inserted in these areas down there. I mean, can you do these more invasive procedures with people that have these implants?
So for most of these, it's not contraindicated and you can simply do it.
Okay.
Anything that you don't have full control of, and I'm sure it has been done. I personally am not as familiar with the literature on it or the experience on it, but like Resume, you may not have control of where that steam goes. So maybe there's some caution there that you just don't want to have a problem or erosion or destruction of that balloon. But most of the other resective procedures, whether that's HoLEP, whether it's aquablation, TURP, you can certainly do with a penile prosthetic.
Prostatic urethral lift, right?
The UroLift, right.
The UroLift. So the UroLift.
Reimbursement story.
Yeah. Oh, really? Tell me about this because the UroLift, one concern that doesn't come out enough is that when you put this is a permanent piece. So sometimes when you're getting an MRI, it can distort the MRI. So people should be told ahead of time that when you have a permanent piece implanted, it could impact your future MRI or future BPH treatment. Stop me whenever I'm wrong. The upside is it's an office procedure. The initial improvements in some of the outcomes are good and minimal risk of side effects. But what's your take on the quick cons and pros of the UroLift?
For the right size and shape prostate, in my opinion, that's really between 30 to 60 grams. I don't even know if 80 grams, but I think that it can have some effective results. Again, putting in the clips opens up that channel. I think variations of median lobe, I don't really think, even though there is some data, it's not very reproducible. And in my probably bias experience that, a lot of those patients fail. Ultimately, the retreatment rate is about 7% a year that accumulates. So it's a high retreatment rate. And even though it's an office procedure or even done in the operating room, is that just by putting in those minimal clips, there is some degree of dysuria or pain that can happen temporarily. So the recovery, even though it sounds so easy, is not always as enjoyable as people think, or as minimally invasive as people think. So I do think that for some patients, it still can work, but certainly for most patients, I think it is not as effective as we think or originally thought. But the benefit is that what it did highlight was the importance of sexual function, and I think that that changed the field, and it really said we care and pay attention to this, because I do think that it is important for most men.
You said reimbursement. Is reimbursement high?
Oh, reimbursement was high.
It was high.
It was being used then, and again, when you look at the frequency of UroLift use, it went skyrocket high. That directly corresponded with reimbursement. The reimbursement has gone down, and as well as the use of UroLift.
Again, I want to preface the audience by saying I just think reimbursement should be there should be transparency. I'm not saying that doctors are going to immediately go toward that and they're evil and they do that. No, we all know the majority of them are fantastic, but I just want to know which one's the hot one that's making the money right now. I think that for patients to know that is just basic. I don't know. Basic ethics 101. I don't know. That's my thought.
As you said, I'm not saying that people who do these procedures
we're not
bad. It's just one of those where I think it has to be disclosed.
This is the last one. I'm not talking about TURP. I'm not talking about TUIP. Those are all you can all get online. You're not going to get anything new from me today. I'm just saying this new one where you put an implantable device and it's temporary, and then you leave it in there, and then it's pretty interesting, right? I mean, they have impressive results. You have to leave it for 5 or 7 days, then you come back and it gets removed. It's called the temporary implantable nitinol prostate device. It's you have any comment on that at all? Because these are getting some attention.
So I think the space for these are all nitinol is a type of inert I don't want to say metal, nickel-based material that is used because it doesn't interact with most things. And so it's used in this case, it's what's called the iTind, which is a device. It's like a basket that's opened up and left in place for a while that kind of slowly remodels or causes theoretically a incision into the bladder neck that can help some men. But I think that it's part of an overall movement of more minimally invasive nitinol therapies, whether they are left in place or they're only temporary. And we don't really know, number one, their durability. We don't know how well they compete against medications. But I think they offer opportunity for most patients, or if they're going to have a space, that they should be more consistent, better than a medication, but probably not as effective as a resective type procedure. And again, some of this will depend on size, shape, but overall, I think we're going to start seeing a lot more of these nitinol devices, and their space in BPH therapy will be defined.
Interesting. We got through a lot of stuff. I'm exhausted. Did I miss anything? I mean, we'll cover more the next time, but I think for the audience, that some of the take-home messages are, behavioral changes make a difference, especially if they're heart healthy. They should be used with or without any pill or any procedure, first and foremost. Second of all, if you want to do something minimally, the results won't be maximum, but that's fine. Some people don't want to go all the way with intervention. However, if you need maximal help, that's where you've got to start going through all these interventions we talked about, because for some of those people, they can have issues that we talked about at the very beginning, risk factors for things that can be medical emergencies if they don't get treated, right? And so some of these treatments really change lives for the better, but as you saw here today, we just went through a whole handful. You've got to really go through the cons and pros to see which one fits your personality. That's kind of my take home. What's your take home before I give you your gift?
No, I actually totally 100% believe in everything you just said. I do think that we do have to personalize and cater to that patient and what their and meet their expectations. And again, that's going to be different based on every patient. And again, I think the other potential is the other factor is that, if you're going to also use these potentially for treatments for prostate cancer, that may be an additional thing that to take into account. But I think it's an exciting field. I mean, that's why I love it. But I think it is really taking into that multifactorial and information to really make the best decisions for that patient. Some of them are personality driven, some of them are, medical and comorbidity driven. But I think there's just a lot of excitement and movement in the field right now.
I think it's an incredible area. And for, again, people watching this, the goal was to make you start thinking about all the things you need to think about before you give treatment. In fact, I'm going to leave you with the one last question. I know you have to go, which is, I'm assuming that with all this excitement on people on testosterone replacement, now that's a whole other option, the pros and cons of that. It's okay for guys to go back on their testosterone replacement, for example, after they get aquablation or on one of these procedures? You worry about tissue growing.
Yeah, I mean, the testosterone, in my opinion, sets the prostate replacement to where it was supposed to be. And so does it stimulate additional growth? I don't think so. I just think it grows to the area where it is. So after you open it up, even if it regrows a little, it's generally fine.
You're okay. Okay. Can you show him his gift? Can you bring that up, Peter? We got you an official Aquaman.
I said I like Aquaman.
I know, and I didn't know that. We didn't know that. That's how smart we are. We think we are at PCRI. We got you an official, not an unofficial, an official Aquaman coffee tumbler, 20-ouncer. We didn't get to the 30-ouncer because we would thought that would be essentially pushing a bad habit. That's too much. That's too much caffeine.
I love it.
There's your Aquaman. That's coming to your house. And so that should be there in the next few days. Look, I can't tell you enough. This was a monstrous task. So for the audience, please be kind, because he had to give a lecture that has never been given that I've ever come across in the history of YouTube or anywhere. And then second of all, the moderator had to cover with the lecturer more treatment options for BPH than has ever been covered that I've ever come across in a video. So I hope you get something from it. Thanks you. I really appreciate your time. I appreciate your honesty, and I think your objectivity. And I really appreciate you doing this. And I'm excited to do that extra sort of master course that we're going to do in the next year. So thank you. Thanks, Dr. Helf. And in all seriousness, I know we joke around a lot, but I really appreciate how much time you've put into this.
I love this. So thank you. And certainly, hopefully it'll help some people. And that's really the goal here. So.
Thank you, my man. Thank you. I know, I can tell you kind of love it. I'm scared to think that you probably dream about this. It's kind of weird. I feel bad for your partner. All right. I'll talk to you later.
All right. I will talk to you soon.
Thank you, Dr. Helfand, and thank you, Dr. Moyad. We really appreciate it. Now, for those of you who haven't already visited our website, please do so at pcri.org/men's health. You can check out the resources there that we have for men's health, but also the sponsors have created awesome exhibit booths there. We'd like to thank our sponsors, Bayer, Pfizer, and Dendreon, for supporting us, and we really appreciate your time. We also appreciate the fact that you're helping make this conference free for all of you. And so, again, visit our website at pcri.org/men's health. Our next speaker is Dr. Jeffrey Alba. Now, he is an advanced clinical urology care nurse specialist and researcher. He's a PhD, and he's also an author. He has podcasts on sexual health for men, and he has just done a great job working in urology and talking about sexual health. He's been an incredible advocate. He's spoken for other advocacy groups, but he's done a huge breadth of work, and he's worked with Dr. Moyad for years. Dr. Moyad is always so great at getting us these incredible speakers, careers, and we're very excited because we're going to be talking about a topic that's near and dear to my heart. We're talking about sexual intimacy after treatment. Now, this has been a requested topic from so many men, but also from caregivers. So he's going to talk about the ins and outs of how do you talk about it? What are the practical treatments, but what does the conversation look like? And what can you do in order to promote sexual health in the, context of you've had treatment? What do you do? How do you have those conversations? How do you talk to your doctor? How do you talk to your partner? What does this look like now? So Dr. Moyad and Dr. Alba do a great job with this presentation, but also with the discussion afterwards. We really appreciate him coming for the first time. We really appreciate, without further ado, Dr. Alba.
Hello. Welcome. I am so glad you have taken time out of your busy, miraculous life to be with us right here, right now, to learn more about intimacy and relationships so that you can love better and live better with your life. My name is Dr. Jeff Alba, and I am here for one simple reason, you. To help you get the information you need to make informed choices and to have a better relationship and improve your sexual health. No hidden agendas. That's why I'm here. So I am excited to share this information with you, and let's get going. All right. Well, first off, I have definitely worked with patients for many, many years. I've had the pleasure and the honor of helping many patients at Northwestern Memorial, North Shore, Endeavor Healthcare, and at the Jesse Brown VA for over 3 decades. So I've worked with lots of patients who have shared the most intimate details of their life so that we could help them have better sexual health, live and love better. That is really my only goal. So I'm just here to share that expertise with you as well. My patients are amazing, and I really feel it is an honor and a privilege to help them. And so they've come up with quite a few nicknames for me. A lot of people who come to hear me speak, like when I talk about the different things they call me. But of course, this one's not too big of a shock. They've come back to me and say, Dr. Alba, you know what we call you? We call you Dr. Love. That's a good one. They call me Dr. Love. I can go with that. Sometimes one group came to me, and I love this one. It was interesting, and they said, because of the work I do, they said, you know what they call you out in the field, Dr. Alba? They call you the penis whisperer. And I said, okay, I can claim that. I can understand that. That makes sense. Basically, it's like trying to get things moving back in the direction they really need to move. So, without further ado, why are we even here to talk today about any of this? Well, we are here for several reasons, and that is because we all need connection with others. Do you think that's true? Can you just isolate yourself and live in your own little bubble? Yes, that is totally, totally possible, but you are hardwired for connection with other people. You might know Daniel Goleman from if you've ever heard of emotional intelligence. Daniel Goleman literally wrote the book on that. He wrote a second book, and he pulled all the research together on it. He followed it with another book called Social Intelligence. And what he found with that research was that every single one of us, you, me, Dr. Moyad, all of us, we are all hardwired for connection to others. It's not optional. What happens to babies if they don't connect to another human being? They literally die. It's called failure to thrive. Make no mistake, we are hardwired for deep connection with other human beings. If you remember back in school, Maslow's hierarchy of needs, Abraham Maslow, amazing work. And when we look at that, love and belonging, so we have basic needs, food, oxygen, basic needs. Love and belonging is another basic need. It's not like self-actualization. It's a very basic human need. So all of us need to feel love and belonging, and we're hardwired for connection with others. So we all crave and need deep, meaningful connection. We all. And when they've done research, Brene Brown's done a lot of research around this, and she said, what people want more than anything else is deep, meaningful connection with others. But she also says from her research, what people are most afraid of is deep, meaningful connection with others. So we're most fearful of what we most need and want. So we shield ourselves because vulnerability, as Dr. Brene Brown says, is the only path to love, to belonging, to creativity. We shield ourselves because vulnerability is the path to sadness and hurt and other emotions that are harder to sit in. But it is literally the only path, vulnerability is the only path to love and creativity and relationship. Well, I have to share with you, you all know everywhere you look out there, sex is everywhere. It's on billboards, it's on TV, it's all over the place. So is that true? Yes. And when I was up in Michigan visiting, Dr. Mark Moyad gave me these two bottles of wine. One is called Safe Sex and one is called Sex. Even the wine bottles have this information there. But my point is here, even though sex is everywhere you look, you see things with sexual content all over the place. Oftentimes, sexual dysfunction is not spoken about, is not talked about, is not dealt with. So that's why we're here today to talk about intimacy, relationships, and sexual function. Those are things that are often not talked about, and there's many misconceptions about what's real and what's not real. I don't share with you information that's my opinion. I share with you information that's researched or evidence-based, scientific-based. That's my goal, is to give you what you need to make informed, empowered choices about your intimacy and sex life, whether that's after prostate cancer treatment or for whatever reason you have sexual dysfunction, you or your partner. So let's start with some definitions. What is sexuality? Okay, first off, there's a certain part of sexuality you're born with, the chromosomes that give that sense of more male or female. It's multidimensional. There's lots of different dimensions to it, but it changes as we move along. That's really important. So what you believe sexuality is as a 5-year-old or understand it to be is very different than what you believe or understand it to be as a 25-year-old or a 55-year-old or an 85-year-old. So it changes. It's dynamic. And it's culturally derived. People use the average year that a person loses their virginity in China is completely different than the average year that a person loses their virginity in the United States. Religion, culture, everything out there influences sex and sexuality and intimacy. I tell my patients, we're going to go through a lot of questions. Please bear with me, but everything can affect sex and sexual health. And so many things affect that. Some people think of sexuality as the collective characteristics relating to sex and love. So that's sexuality. But when we talk about sex in this talk, we're speaking of genital and body stimulation for pleasure. It may include oral stimulation. That means using your mouth, manual stimulation, using hands, or vibratory stimulation, and or it may also include penetration, like intercourse. So it may include penetrative things. But we say sex is any kind of genital stimulation that involves pleasuring each other, and is the real purpose of that is pleasure. So that's what we call genital stimulation. It doesn't have to be penetrative to be called sex in what we're talking about. Everybody's different. So everyone's needs are different, and every person is responsible for their own orgasms. We all believe, oh, it's my job. We get performance anxiety around, it's my job to make sure that you have pleasure and orgasm. But here's the truth. It's my job as an individual in the world to make sure that I can get my needs met, that I get to where I need to go with pleasure and orgasms. We're all responsible for ourselves. That removes some of the pleasure, saying, you need to make me climax. You need to give me pleasure. You need to rock my world. I need to ask for and work with you, and we co-create this beautiful space where we can have wonderful pleasure. So it's a group effort, but ultimately we're all responsible for our own sexual health and our own orgasms. Now, intimacy is really important too. Intimacy refers to a deep and meaningful connection, and that's characterized by emotional closeness, trust, really important, and mutual understanding. And this is where you feel truly known, truly accepted, and truly valued. That's really important. You feel known, you feel accepted, you're seen, and you're valued. That's connection. That's intimacy. Hatfield says intimacy is a process by which two people attempt to move towards complete and total communication on every level. That's really important because that means verbal communication, nonverbal communication. On all levels, we feel deeply connected and we have complete communication using all those avenues. So a couple's fighting. I want you to think about this for a minute. When that couple's fighting, they're not speaking to each other. Can they have sex? Yeah. You don't have to speak to each other to have the act of sex. Can they have intimacy? No. These are two distinct concepts that work together, and they're both really important to think about when we think about our sexual goals and our sexual health. Intimacy cannot be done if you're not speaking to each other on a basic level. You can't have communication on all levels and on a meaningful, profound level where you feel known, accepted, and valued. Intimacy is just as important as the sex piece of it. And we'll talk more about that. And when patients come see me, what they're seeking is more connectedness, more meaning in the relationship. And that's the intimacy part. So we're going to talk just a little bit about couples relationship. There's so much to say about it. I was trained by the Gottman Institute as for couples therapy, and then I also trained with Andrew Christensen, who does integrative behavioral couple therapy, IBCT. So you'll hear some of that research. Everything I tell you is research-based, coming through with what I'm saying. John and Julie Gottman studied over 3,000 couples. For over 30 years, they have done amazing research looking at what do couples do, what works, what doesn't work, what leads to divorce, what leads to staying together. And they found this house model that I think you'll find really helpful. The foundation of your relationship house, this is your relationship, your sound relationship house, that great relationship, the foundation, what it's all built on is a friendship. It's built on a deep, meaningful relationship. And that's a friendship. That means a lot of things to a lot of people. I know my wife and I, before we got to dating, we were really good friends. We were dating other people. So definitely our marriage of 40 years is built on a solid friendship. Love maps are just exploring and looking curiously at who your partner is, what they're doing. Even though you may think you know everything about your partner, you can never know everything. So the Gottman Institute created these love maps to ask questions of each other, that you may or may not know the answers to. Who today do you really admire and want to be more like, for example? But there's so many different questions. So building love maps and then sharing fondness and admiration. You should be deeply fond and admirable of your partner. So we do exercises to work on and build that in couple therapy to enhance that foundation, that friendship. Turning towards means what happens when your partner tells you something or walks in the room or wants your attention for some reason. Do you turn towards them or do you turn away from them? Do you look out of your phone or your screens and towards your partner? Do you respond to them? Do you engage with them? That's turning towards. And that's very helpful in a relationship. Turning away is being engrossed in something else or ignoring that person. That can lead to problems. And so turning towards is another thing that builds up that friendship. And then that overall positive perspective that no matter how much my wife and I disagree, I believe she is one of the most amazing, beautiful human beings in the world. And I believe our marriage is incredibly important, that there's overall positivity. Because what Gottman found was it's not the negativity that destroys a marriage. It's the lack of positivity that destroys a marriage. There's nothing there to fight for because the positivity isn't there. So building that foundation of positive perspective and a solid friendship is what your whole relationship with your partner is built upon. The house, so that's the foundation, the friendship. The house is conflict is inevitable. Make no mistake about it. Conflict is inevitable. And conflict, so what are you going to do? You didn't marry yourself. I wouldn't want to be married to myself. You married someone different. And that makes you deeper, richer because it gives you two really distinct perspectives or paradigms that makes you stronger and better. My wife is incredibly detail oriented and I'm a big picture person. But now we get the benefits of because of our relationship. Sometimes the detail is what saves us in a circumstance, and sometimes the big picture. We get both perspectives because we're different and we see the whole world through these different lenses that make us stronger and better. So learning how to manage conflict is what we spend a lot of time on in couple therapy. And that is a Gottman technique. And it's really important to manage that conflict as it arises and deal with it. And don't just let it fester and sit. So that's the house. The foundation was the friendship. The house is managing conflict. The walls, super important, are trust and commitment. Trust that I believe in you and I trust our relationship and I trust you. Sometimes that can be challenged and difficult. People come in with fidelity and lack of trust issues, and that's a certain thing you work on in couple therapy. But trust is the walls that hold up the roof to your sound house relationship. Commitment is the other thing. If you're always dangling, now, of course, there are reasons you should leave a relationship, like if you're being abused, especially there's domestic violence or interpersonal violence is never okay. It doesn't matter who it comes from, male, female, non-gender, binary, it is never okay. But so commitment is really important too. I'm not going anywhere, but I'm also not going to continue to tolerate this situation. We will have to work this out. So commitment and trust are the walls. And last, the higher level thing is creating meaning. Meaning is a huge deal. Viktor Frankl, literally, he had hidden in his coats his research about how important meaning was when he was thrown into Auschwitz in Nazi Germany. And he kept of course they took everything away from him, but he continued that research after he came out of the most horrific circumstance to say, hey, even under horrific circumstances like I went through, meaning is everything in life. So creating shared meaning is a really big deal. And that's the upper level, sort of the attic of our sound house. So the foundation is friendship. The house is managing conflict and learning how to navigate disagreements and differences. The walls are trust and commitment, and the attic is creating shared meaning. Okay. So Masters and Johnson did this incredible research way, way back in the 1960s. We would never be able to replicate it because it's very sensitive. And it starts with excitement. It's like a desire and excitement is where it begins. And that builds. We have tactile sensation where I feel more on the skin level. We have increased blood pressure. We have increased pulse. Increases in all these things that build towards excitement. Now, we don't want that to go on forever because we want it to plateau. We don't want our pulse to keep going up, our sensation to keep going up. We want it to plateau, which feels really good. Now we're in this space where everything feels so fabulous and so good. And then orgasm occurs, which is sort of like orgasm leads to that feeling of satiation or resolution. Now, you see a little problem here? When they timed it for men, start to finish was about 2.8 minutes without delaying it in any way. And for women, 4 times longer, 13 minutes. So when males and females are partnered together and in those type of relationships, a man has to be very cognizant that foreplay focuses on a female. These are generalizations, and this is most people, not everybody. Everybody's different. Know who your partner is. But so it takes a woman 4 times longer. So foreplay should focus on that partner more, who's going to take longer. So they're on the brink of orgasm or close to it before we even start other things on the other side. So we can time that a little bit together in terms of timing those orgasms simultaneously or close together. So, but you see a little problem there. Why? Because the clitoris and the penis internally are very similar organs. So the structures inside the clitoris, the erectile cylinders in there, The blood flow into there. The smooth muscle are almost identical in the clitoris and the penis. DNA turns one into a clitoris and one into the penis. But the clitoris is more internal. So you can imagine it's going to take more work to cause a climax on something that's mostly buried underneath versus something like the penis that is more external and easier to get to and stimulate in ways. So that's part of why we believe that there's a disparity between how quickly and how slowly males versus females climax. Okay, so here's what it looks like in the model. It starts with desire, then I'm really being aroused by your touch, by what we're doing together, by stimulation of genitals and breasts and wherever feels good. We hit plateau, orgasm. This second line is the female who can be more multi-orgasmic, and then resolution. So that's what we're talking about here. That is the sexual excitement response cycle. This is for men and women both, but this is primarily, even though the slide says it here, this will keep you on your toes. This is more of a male-driven model because it really has to do a little bit more with the men, and I'll tell you why on this next slide that's so important. Okay. Rosemary Bassan, this is a researcher's nightmare. When she went to do her research, you're supposed to use a model. She used this model from and applied it to females. That's why I put female on top of it. She tried to apply that to women. And over a third of the women that she started interviewing said, it doesn't start with desire. See how it starts here with this model? It doesn't start with that for me. So Rosemary Bassan, this is a researcher's nightmare. She's like, are you kidding? Okay. So she said, I need to see what's going on with these women. And this can happen with men too. But she created a really incredible model that she found because that's over a third, going towards half of people, especially women, and these were in her study, it was women, said it doesn't start with desire for me. That's not how it starts. What they said was it starts with emotional intimacy. It starts with, remember how I talked about connection? It starts with connection. Engage with me. Get my attention. Cause emotional intimacy, which is I feel seen, heard, and valued. And then that motivates that sexually neutral woman to be like, okay, I'm into this. You start to kiss. We start to embrace. We start sexual stimulation. And then that leads to I'm becoming aroused. The vagina starts to moisten and widen. This is what happens during arousal. The clitoris becomes engorged. The penis becomes engorged. This is what's happening. And then way over here, after arousal, we have arousal and desire. This is called responsive desire. Now I'm like, yes, now I want to continue. This feels so good. I want to continue on with it. And then we have more emotional and physical satisfaction. I feel connected to you and more emotional intimate. And now it goes round and round and round. So it's about connection. And I really find this model valuable when I'm working with my patients because where did it fall apart? And for some of us, it's not this hormonal desire that we see here, that desire, that hormonal, oh my gosh, this need, I feel a need for sex. I feel strongly driven for sex. Of course, that can be present in men and women, definitely. And remember, women have 1/10 of the testosterone men do, 1/10, and that's before menopause. But both can have very strong, that lustful desire. But responsive desire is something that comes about from interaction, engagement, and connection. That's important. So as we get older, responsive desire becomes more and more prevalent in men and women. And so it is an important concept to understand. So when we're talking with our prostate cancer patients in particular, with the PCRI, why is it so important to talk about sex, intimacy, and all of this stuff? This is why. Radical prostatectomy outcomes, and these are studies. Now remember, studies are expensive, so they're not going to keep doing them over and over, but these are some landmark studies that were done. And you see in this first one, which was Penson et al., and that was 2008, it was a 5-year study. They found that 78%, about 8 out of 10 men at 2 years, after treatment reported difficulty getting and keeping erections. That's what erectile dysfunction is. Difficulty getting or keeping erections for sexual stimulation or sexual activity. And then now we look 5 years later, 72% were still struggling with erectile dysfunction, difficulty getting and keeping erections. This is when they ask patients directly, and that's the only studies I will quote you, not studies from providers or anybody else, studies that are patient-based and patient-focused. When they asked you, the men with prostate cancer, this is what they found. That's astounding. Because when you look in the research, if you look it up on AI or wherever you want to look it up, you'll see how prevalent is erectile dysfunction with prostate cancer, and you will see 0 to 100%. That's why, depending on how you define it, depending on who reports it, but all I care about is the men who experience erectile dysfunction. What do they report? And that's what these studies are for. Anyway, that's a big study with like 1,300 men from all over, and that's what they found. So then this other study was done, Resnick, and this was 2013. So that's like 5 years later. These are some landmark studies, and they found that erectile dysfunction in men after radical prostatectomy, almost the same numbers, 78 to 87% at 2 to 15 years after their prostate cancer treatment. Here's another study. It's the prostate test for cancer and treatment trial in the UK. So looking at in London, greater than 95% of the men were struggling with erections right after surgery. Because right after surgery is when it's the worst, because they had to pull the nerves off the prostate to get it out. There's no other way to get it out. They have to peel the nerves off the prostate. They dissect them off, and even when they preserve them perfectly, they were never meant to be touched. They become traumatized, and they're not usually working well in most men right after surgery. And you see 95% of those men said that. And then 85% 6 years after the radical prostatectomy said that too. So, and this is a study that you see from 2022 when robotic prostatectomy did not change the fact that they have to dissect your nerves off the prostate to get it out. There's no other way to get it out if they remove it. So radical prostatectomy involves dissecting the nerves off. And this is why this is so important for these men in particular, and you if you're one of those men. What if you do radiation therapy? Well, here's again that study from the UK showed 74%. That's still most of the men had erectile dysfunction. And you look at that way out after surgery. So radiation therapy also, when you look immediately, radiation therapy causes a slow erosion of the nerves and the problems with erectile dysfunction. It's not going to be immediate, whereas radical prostatectomy is immediate. So remember that. That's really important to understand. So we want to compare 2 or more years out when in both cases you're going to see problems. So they usually compare in studies 2 or more years out because that's where we've kind of evened. What's really going to happen long-term from radical prostatectomy where it's terrible right away and gets better over the first year or two, and radiation therapy where it's okay right as you finish radiation therapy and it gets worse over time. So we like to look 2 years out at what's happening in erectile dysfunction to know long-term what are the effects. And the number one complaint after surgery is erectile dysfunction, difficulty getting and keeping erections. What if you do androgen deprivation? Lots of things. Not only does it affect your libido, but it can also affect erections. It can affect testosterone. Works all over your body. It can affect your mood. It can affect your energy. It can affect your concentration, your muscle mass, many, many things. So all that to say that the most common side effects of prostate removal, prostate radiation, or hormone ablation is erectile dysfunction. So the number one issue is sexual side effects when you have prostate cancer treatment with radical prostatectomy in particular. That's different from focal therapy, but removing the full prostate radiation, full gland radiation, because there's also focal radiation, or hormone ablation. Any of those things cause erectile dysfunction in the majority of men. Ejaculation doesn't typically occur when your prostate's been removed or fully radiated because the ejaculate comes together in the prostate and is expelled stored and then expelled from the prostate when you ejaculate. So there's another little gland in there, but when your prostate's gone, that other little gland is the only thing producing anything remotely like what you ejaculate. So mostly ejaculation doesn't really occur after you've had your prostate removed. Certainly, completely removed, it doesn't occur. There's one little gland that may cause a little bit of fluid to come out like that. You may leak urine. That's called climacturia. But the ejaculate that used to be there doesn't happen when the prostate's been completely removed. And neither when it's been really radiated, the whole prostate. You don't usually ejaculate much, or you may not ejaculate at all. The tiny Copper's gland may put a little ejaculate, and it can even hypertrophy. That means enlarge, and you may ejaculate some from that. But in general, ejaculation changes. So fluid doesn't come out. The penis may seem to kind of disappear up into the body. It's like the turtle's head. It sort of retracts, which is a really weird, scary phenomenon for most men. And so if that's happening to you, it's not unusual. It's because of increased muscle tone right after surgery. The muscles sort of tighten up and the penis sort of pulls in. It does relax and resolve somewhat in men sometimes as they start getting erections back, if they start getting erections back, because that causes muscle activity and blood flow. And muscle activity and blood flow means exercise inside your penis. And when it doesn't happen, muscles can atrophy or shrink. That means shrink. Muscles and the blood flow and stuff, it will change things. So blood flow is affected, nervous conduction's affected, and muscle structures are affected within the penis. So these factors impact how a man feels about himself and how he interacts in his intimate relationship, and it really can affect quality of life. Now, some men may not be sexually active anymore and not care about it anymore. That's perfectly fine. If it's not a problem for you, that's not a problem. And that's okay. If sex is not the highest priority or even a priority at all, that is okay. If that works for you and your partner, there's nothing wrong with that. But if it is for you or your partner, that's when it becomes really challenging. So we have lots of different therapies out there. I'm just going to briefly touch on these because we could talk about them forever. But I wrote a book on it called Reclaiming Sex and Intimacy, and the second edition is completely available for free to download. And I'll tell you how to do that as we finish up when I get to resources. But that will tell you the good, bad, and ugly of all these therapies. But I'm just going to hit on a few things with them for now. And so, first of all, I think what's really important for you is to for most couples that I work with, and most men, or with or without a partner, and it's a very different landscape to navigate when you have no partner versus when you're in a long-term relationship or a relationship. A lot of times, and if you're listening partners, you're living every step of this with that your partner with prostate cancer. You are living it. And kudos to you because you go through each piece of it. We always say in the group that I run at Gilda's Club, the Zero Prostate Cancer group that I run at Gilda's Club, we always say, I don't know who it's harder on, the patient or their partner or the people who loves them. It's hard on everybody. But so what are your goals? Intimacy is about communication on all levels. So a lot of times we don't know how to communicate about sex. The extent of our vocabulary are grunts or yeah. That's not a conversation. And usually the conversations don't happen in the throngs of intimacy or during sex, but they can happen and should happen outside of there where you talk about, oh gosh, I am so enjoying our sex life. I just was thinking to myself, wouldn't it be fun? Conversations around it. You'll never get comfortable communicating about it unless you start communicating about it. So communication on all levels and connectedness is what intimacy is about. Do you want intimacy? It means you have to be able to communicate on all levels. Do you want connectedness? Brene Brown says connectedness is feeling seen, heard, and valued and not judged by the other person. That's connection. Seen, heard, and valued. You can see my thoughts on intimacy mirror very closely with her thoughts on connectedness. So I give her a lot of credit because I love that definition, that you feel seen, heard, and valued, then you're connected and not judged. If sex is about pleasure and connectedness, there's a myriad of ways of getting there. Trust me, there are so many ways to get there. Men and women can go can both climax or orgasm with or without intercourse or penetration, with or without a hard penis. They're wired separately. The pudendal nerve system is more important to orgasm, whereas the cavernosal nerve system is what's important to erections. So if it's a blood flow problem mostly, and remember, the cavernosal nerves are the ones that they dissect or pull off the prostate to get it out, not the pudendal nerves. So most men can still have a good sensation and enjoy that climax orgasm feeling, but they, even without any erection, because the pudendal nerves are intact, they don't touch those when they do your surgery typically. They may be slightly affected or altered because they're nearby, but they don't have to be peeled off to get your prostate out in a radical prostatectomy. They're not right there that they would be radiated with radiation therapy. Sometimes they are adjunctly affected, gently, along with things, but not directly usually affected. That doesn't mean that people don't sense orgasm different. When you look at the researches, how orgasm feels afterwards, men say, the most common thing men say is it feels different, but it still feels good. The second most common thing they say is it feels similar to what it did before, even though I don't ejaculate. This is after prostatectomy, removal of the prostate. The third most common thing, and this is a small percentage, only about an average of 6 to 10% will say, I have a more intense climax or orgasm after surgery than I did before. That's a very small percent. Some people say it doesn't feel the same and it's not as enjoyable as it was. It's diminished. That's not the majority of people, but some people say that. Most men I worked with and most men in the study said, I'm still glad I get the sensation even though nothing comes out, and I'm still really glad I enjoy it, and I do enjoy it. But you could be any of those men. It may feel different. You may be upset about climax. You may be thrilled that it's still there. But anyway, so that's important. There's many ways to enjoy affection, connection, and pleasure. All kinds of ways to do that. Don't let that suffer because of the problems you're having with sexual dysfunction. First off, it's nobody's fault that you have this problem. It's nobody's fault that you have prostate cancer. It's not your fault. It's not your partner's fault or anyone's fault. How can you live your best wholehearted life given these circumstances? That's really what we try to look at. So communication is really key, and you don't get better at communicating about sex unless you start communicating about sex and talking about it. And when something's wrong, it's monumentally important to communicate. Communication is such a important piece of marriage, relationship, connectedness. Communication is everything. So it's a really big deal. So we try to help people expand their thinking about sex. It's not just about penetration and erections and hardness. It's about so much more than that. There are many, many ways to experience sexual pleasure. Manual stimulation, stroking of the penis, stroking of the clitoris, rubbing the clitoris and penis together, oral stimulation of the genitals or the breast or wherever it feels good. I would just had a female patient talking to me in my sexual health clinic. This is weird, but she says to me, this is what she was telling me. This is weird, but I feel like I climax, but it's not from clitoral stimulation or genital stimulation. It's from breast stimulation and kissing and hugging and nothing's going on the genitals at that time. And that's sometimes how I reach orgasm. And that is absolutely true and possible. It doesn't always have to involve, but it mostly involves pleasuring and genital stimulation on the penis and the clitoris. But that's not the only way. And every person's different. That's really important. And intimacy, that deep connection, is very, very important. And some of the excitement comes from, what will it be this time? This time we took intercourse and penetration off the table and we're just doing other things to enjoy other ways. What will we do this time? Do we both want to have an orgasm this time? Or is this time focused more on you or focused on me? That anticipation and mystery and curiosity is so important. And play, having fun. Fun is highly underrated, very important. Okay, so there's 4 major problems according to Gottman when it comes to a relationship that you want to avoid. Who wants to be criticized? Criticism. So when we're talking about therapy and treatment and couple therapy, these are the 4 things we try to avoid. No one wants to be criticized. It really irked me when you moved that check off my desk. You always touch that stuff on my desk. Criticism. So criticism, and then expletives like always and never. So contempt, making it personal. Oh my gosh, I can't believe you did that again. That's something that it's just all the time I deal with this. Contempt, rather than really treasuring and admiring and believing your partner's the best thing, that contempt comes out. It comes out easily. It's hard to avoid criticism. It's hard to avoid contempt, but these are the things that are really destructive to a relationship. Defensiveness. So then what happens is while you're talking, I'm not even hearing what you're upset about because I'm thinking, I don't do that. I can't believe you think I do that. I'm really not hearing, I love this other person and they're trying to tell me what they're upset about. How can I tune in and be curious about what are they so upset about? If I as desperately want to understand them as I want to be understood, we'll get there. That curiosity and that listening, really, really listening and not becoming defensive is really important. But we get defensive when somebody criticizes us or we feel like we're being attacked in any way, shape, or form. Sometimes even when they're putting it perfectly, we can become defensive. All of us. So then we say, I won't say anything. That's called stonewalling. That's another problem. So criticism, being critical, contempt, making it personal, making it mean, defensiveness, trying to, I don't do that. What are you talking about? Instead of listening to what's wrong or just listening, which is my wife's taught me over and over. Just listen. Don't fix it. Just listen. Defensiveness is really destructive. And then I won't say anything at all. That's stonewalling. So this is from the Gottman Institute, and I share with you where you can go on the Gottman website and learn more. So communication is critical, but did I tell you how to communicate better? Avoid criticism, contempt, defensiveness, and stonewalling. So how do you do that? You be specific. Forget about fault, shame, or blame. We live in a culture that looks for somebody to blame. Forget about it and figure out what can we do to make it right or better. Is it really going to help us to find fault, to figure out everybody's faults? And that's just criticism. So be specific, forget about fault, and work on fixing problems. Move from fault to fixing, really important. And then accept, so also accept some of the blame yourself and fix it. Find a way to fix it. But anytime that my wife and I disagree, I always have something that I did wrong in it. I can guarantee you that. And I can tell you, my wife could list them out for you, but I could list them as well, what I did wrong. And I always try to look at what did I do wrong? Can I own it? And how can I do it differently? But we remove shame and blame and we look at how can we fix it most importantly and find something to be positive about, something genuine to be positive. You may need to take a time out. A time out means, you know what? I'm feeling flooded. I'm feeling triggered with this conversation that's getting so heated. Let's step away from it. Let's come back to it in an hour or two. Let's both step away from it, or let's take a rest from it. Sometimes people will be overnight or a day. Let's process it. Think about how we both could come back and be better in this. So a timeout can be an essential thing, but always have a plan to come back. Don't leave it sitting and festering. Use I statements instead of you. You took that check. You always do that. Your mother used to do that. Are you on your medication? You statements get us nowhere. Remember, when you point one finger, all the rest of these fingers are pointing back at me. I. And so you can't say, I'm really disgusted with you. I feel frustrated when I can't find the check on my desk and I don't know what happened. And I really need you to respect that space on my desk and let me know if you move anything. So I statements, I feel this. And you can't say, I feel you're nasty. That's not a feeling. I feel frustrating. I feel hurt. I statements. The goal of the listener is to reiterate what your partner says. So you better be listening. If you're not listening, we got a lot of problems. We could do a whole session on this. So I'm going to kind of briefly move through the rest of this. Be concise. Don't use expletives. Oh my gosh, you did it again. And I can cite the other 23 times that you did it. This time, when I felt this, when this very specific thing happened on this circumstance, and I need this from you. Be concise. They don't need a dissertation because you can't reiterate back as the listener. You cannot reiterate back. It shouldn't be more than a few sentences when you're trying to tell your partner or loved one something really important. So be succinct and concise. Watch your body posture. When you start tightening up and stuff, it builds tension in the room. Use positive bids. That means be more gentle. I know you're upset and you want to tell this to your partner, but if you desperately want to tell it to them, we tell you soften it up. Nobody wants that hardball when you're sending that message. You do this, you do that. It's not going to get you anywhere. I feel this when this in particular happened, and it was upsetting to me, and I need this from you. So be gentle. If you can, start with something loving. I so appreciate all you do to keep things in order. This is a lead into the discussion about the check, but you don't want to say, I so appreciate how orderly you keep the house, but don't say that. And I really want to recognize you for that. I felt really upset when the check, okay? So positive, gentle, supportive efforts so that you can really send your message in a way that can be caught or heard by your partner in a really productive manner. Restate your feelings as softer emotions, like instead of anger, what's under the anger, the sadness or anxiety. I feel castrated by what you did. Those are strong words. Can you soften it up? And then create and use an eject button. That's the timeout button. And then taking time out when it's needed and always coming back to it. So those are just a few. We could spend a lot of time on this, and I don't want to do that today. I just want to give you some insights. We improve intimacy through connection, through emotional connection, taking time. The greatest gift you can give your partner is your time and full attention. We've all been in restaurants where people were buried in their phones. That is not quality time. Prolonged eye gazing, looking into each other's eyes as you speak, increases dopamine, which makes you more attracted and more want to be in relationship with that person. So taking time, giving them your time and full attention, and genuinely showing interest and communicating that in loving ways to your partner. Increasing physical touch. Physical touch increases dopamine and neurotransmitters that cause you to want to be more connected and loving with your partner. So physical touch, actually a 15 to 20-second hug will increase dopamine and neurotransmitters in your brain that make you want to be with that person more. Increasing intimate communication, resolving conflict and figuring out how can we make it better. Talking about that. Showing appreciation. What am I grateful? Gratitude is such a powerful thing. What am I grateful for with my partner? Acknowledging your partner for something true and real that you're grateful for. And you're going to have to be vulnerable. I said earlier, it's the only path. Try something new. That increases neurotransmitters in your brain and increases excitement. Something new or different. That can help too. And then making sex a priority. People are like, I don't want to schedule sex. Well, the only way it happens sometimes in our busy life is to be scheduled into your life. It doesn't mean you have to do it at this exact time on that day or in this exact way. You can put all kinds of spontaneity in there, but make sure it happens. I have couples who tell me every Sunday morning it happens, whether it should or not, we make sure it happens. And I'm like, that's great. And a lot of people don't think about morning when erections are sometimes a little better, when energy's a little better, when we're not exhausted from the day. So my patients give me all kinds of amazing, amazing suggestions over these decades that I've worked with countless patients on all these things. The 5 love languages really is Gary Chapman's work, and you may not have heard of it, and it's not deeply entrenched in research, but a lot of my couples find it helpful. So you can look that up. And it'll talk about like words of affirmation or acts of service. Those are 2 of the love languages. What is your partner's primary love language and how can you speak that into that relationship with them? So there are different love languages. Most people have a primary one, but all 5 can be important to many people. But what's the primary language and how do I speak love in? Sometimes your love language is different. So you speak love back into that relationship with your primary language, but it's not your partner's. So you do these acts of service for them, but their primary one is not acts of service, it's words of affirmation or quality time together. So those can be important. Have fun together. Fun and play are highly underrated, and they are incredibly important in relationships and in life. Definitely in life. So have fun and play. Play is just doing things. The only purpose is to enjoy and have fun. So have fun and play. And I'm going to talk later about the podcast, but we've done podcasts specifically on how to infuse fun and play into your relationship and into intimacy. So then we have several treatments that I'm going to briefly go through. And again, you can download my free book. You can find out more about these. I try to lay out the good, bad, and ugly of them because they all have good and bad. In the perfect world, you thought it, and with very little provocation, there it was, your erection. But in terms of erectile dysfunction treatments, the oral agents by a landslide are the most popular. By a landslide, because they're easy, they're simple, and we're used to pills. Millions, if not billions of people have used them across the country since they were introduced in the 1990s. And they were actually introduced as a cardiac drug to lower blood pressure and help the heart. But they didn't work that well. They slightly lower the blood pressure, and they can help with pulmonary edema in terms of heart, but they didn't work that well as a cardiac drug or an antihypertensive, but they do have a little bit of those traits. But after the study was finished and they went to collect the drugs back to see were they taking them, how many are left, and what was left, the men didn't want to give the pills back, and they started talking about their erections. And that's how these drugs came to be, literally, was they were discovered because these drugs were being used for other purposes to help the heart and blood pressure, and they found that they actually help erections. So there's several of them: sildenafil, vardenafil, tadalafil, avanafil. And my most important thing I would say to you is timing can be important. So most of them, the first three, all increase and start getting in your bloodstream in about 30 to 60 minutes, but they don't peak for about 60 to 90 minutes in your blood, in your body. These are generalizations. And so you need to take it about an hour to an hour and a half before sex if you want everything it's going to give you. Another thing about these pills is when you've had a surgery, right after surgery, or you've had, you're really struggling with erections right after surgery especially, they may not work because the communication between your brain and penis is not quite there at that point and may not completely come back. And that's why they may not work, especially right after surgery. But they may. But how they work right after surgery may be completely different than how they work 3 months, 6 months, or a year later. Don't forget, you may need to try them at various times or throughout your course of recovery as you start recovering erectile function and the nerves start recovering, rejuvenating, whatever those nerves are doing to recreate that creation, that connection between your brain and your penis back and forth. Super important, because that's how, so when men get excited, it's all put together in the brain, in the frontal lobe, all put together here. The message goes from the central nervous system down the autonomic nervous system or the spine to the peripheral nerves. That's where the cavernosal nerves surround the prostate, bundle on the right, bundle on the left, and go to your penis. When the signal hits your penis, it causes the chemicals in your penis like nitric oxide and cyclic GMP to be activated because of that stimulation that you're feeling when you're stimulated with sexual thoughts or stimulation directly on the penis. That causes those neurotransmitters inside your penis, those important chemicals like nitric oxide and cyclic GMP to be activated so that they cause smooth muscle relaxation and vasodilatation. The muscles open up, the blood fills your penis, and you become hard. So to put that together, you need nervous conduction between your brain and penis, back and forth communication, and blood flow into your penis to become engorged. When it fills quite a bit, it pushes against the veins and locks the blood in your penis, and you got an erection. Nervous conduction and blood flow. It's a neurovascular event. These pills work on you by blocking this. There's an enzyme called phosphodiesterase type 5. And if we block the PDE5, now That keeps nitric oxide cyclic GMP, this cascade of things that causes the muscles to relax and the blood flow, that keeps that in check. So it's like math with a double negative. If we inhibit the inhibitor of the chemicals in your penis that make you hard, so let me say that again, we inhibit the inhibitor of the chemicals that make you hard, now we have more chemicals in your penis, so that when you get excited, and only when you get excited from sexual thoughts or stimulation on your penis, or even better, both, you could get harder. That's how the drugs work. But remember, they peeled the nerves off your prostate. So the drugs don't work a lot of times, especially in the beginning, because the nerves are traumatized. They're there, they're present, but they're not working right. And that's why the pills aren't working, especially in the beginning, but they may start working as things start working again down there with the communication between your brain and penis. So don't forget that. Doses go as you see, and they're dosed differently. And most people, sometimes for penile rehab, people will take them every day. There's lots of things we could talk about with those, but my most important thing is that to know, especially after prostate and after radiation too, give them a chance regularly to see if they're doing more or less at different junctures in your healing process, okay? And work with your provider or prescriber on how you should use them. Should you use them daily, even when you're not having sex, for a little bit of potential rehab? And that's very controversial because they didn't help everybody. When you look at the research on does it help to take a pill every day, really the research pretty clearly shows not necessarily. And that's because are you a pill responder or not? But if you are a pill responder, in other words, when you use it, you see more activity in your penis than when you don't, then it may be helping you because it's causing more blood flow, more things to happen within your penis. So lots of things to think about with oral agents. But let's move on, because then we also have a vacuum pump. You put your penis inside that cylinder you see there, and then you pump manually with that pump you see attached, or there's a button, and that's a battery-operated pump. They do the exact same thing. Most people like the manual one because you can control the pumping really well, and if you don't have dexterity problems with your hand, that works just as good, if not better, than the battery operated. Most people just use the manual pump. And then, great, when you pump that pump, it creates a suction inside of that cylinder that forces the penis. So the penis is inside the cylinder, and it's not completely erect or partially erect. And you always want to start with, this is a really important key. If you get a partial erection, if you get some fullness or thickness, always put that in there as hard or full or thick as you can, because the more you start with, the more your penis is ready for even more blood with the vacuum pump, and it will work really easily and simply if you start with a partial erection. The more you start with, the better. So you put that in there, but it's not completely hard. And then it's in the cylinder, and you start to pump, and the suction creates physics. It basically pulls more blood in your penis, so you're harder inside the cylinder. Great, but you can't have sex inside the cylinder. That ring you see there goes on the edge of that device right next to your penis. And when you transfer the ring to your penis, you can get it out of there and into your partner. So the vacuum forces the blood in. And this device, we did an excellent podcast on this. This device takes good teaching, practice, and patience. And so you have to practice with it every day till you learn to get a painless, even lift-off erection. That's a big deal. Practice with it every single day till you learn to use it. Your provider or their nurse or PA, their physician assistant, or your advanced practice nurse, those people should be able to give you tips and show you how to use it. We also did an excellent podcast, Kathy Marchese and I, on this that shows how to use the vacuum pump. But that one-on-one training with your provider or prescriber or someone who is trained with that vacuum pump is really valuable. And then practice every day till you learn how to use it without the rings. And then how do you use the rings? You may want to use it for stretching. Lots of things to think about with a vacuum pump. But practice and patience and guidance is essential. If you have that, I've only met a few people out of all the over 1,000 men I've worked with that we couldn't get it to work in some way, shape, or form for those men. Finding the right ring, there's lots of tricky nuances. It's messy, it's not perfect, but the good thing is it's completely non-invasive and it does work. Research shows in 90% of patients, and in my own practice, I've found very few patients who we couldn't get it to work right. It's still messy, it's still cumbersome, you still may hate it, but It's non-invasive and it works. Everything is good and bad. And the more invasive we get, the more risks or downsides and the less people that will do these things. Almost everybody will try a pill, but not everybody should try a pill. It's prescription and you need to see if it's right for you. When pills don't work, some people are like, I don't want to deal with the pump or anything else. We'll just have non-penetrative outer course. We'll have manual stimulation, all those things we talked about earlier, because I don't want to deal with that. And that's okay. You don't ever have to use a vacuum pump. You don't ever have to give yourself a shot in the penis. You don't ever have to have penile implant surgery. You decide what happens in your body. But if you're willing to try it, this, again, we're going from least invasive pills. Now we have the vacuum pump, which is totally non-invasive, but you still have to be careful and be trained right. And it has a 90% efficacy. Pills have, in general, about a 70% efficacy rate, around a 70% efficacy rate. They all have good and bad. Pills, you can get side effects. Most people don't, but some people do. Some people feel like crap on the pills. Some people the pills don't work for. Everything has good and bad. So we got pills, we got a vacuum pump. I want to stop right here and say one thing. There's tons of stuff out there. There's all kinds of herbal concoctions that are not governed by the FDA, all kinds of things that'll make you harder, longer, bigger, wider, all kinds of things. Many of them have no research to support them. What I'm telling you is what the Sexual Medicine Society says are the true 5 treatments: the pills, the vacuum pump, the Eroxin, the penile injections, and the implant surgery. That doesn't mean there are no herbal things that work, but there are many things that are out there that say they're going to help you, especially after prostate surgery or radiation, and most men will tell you they do not help. So you need to look at the research behind them and see how they use them and is it right for you. But I'm talking about things that have really good, solid research to support them. They're still not perfect. They all have good and bad. Make no doubt about it. And they may or may not be right for you. And none of these one things are right for any one person. Okay, so that's the vacuum pump. Lots of practice, lots of patience, and learn how to use it properly. And then it works in most people, but it can be messy. It can be cumbersome. You have to wear a ring during sex. Some people hate all those parts of it. But what people like is it's non-invasive and it works. Good and bad with everything. You decide, is it right for you? Eroxin is the newest thing. In 2023, it was FDA cleared. It is over the counter. It is a topical that you work into the glands or head of the penis. So you work it into the glands or head of the penis and see if that is helpful for you. You put it on. It usually works in most men within 10 to 15 minutes. You can wash it off to try and make sure it doesn't transfer to a partner, or you can wear a condom to make sure, because there's very few side effects, but the number one side effect can be irritation to the skin or rash or something like that. So always try it somewhere where a rash, like on your wrist, to make sure you're not allergic or have a weird reaction before you try it on the glands or head of your penis. 60% of the men had an erection within 10 minutes. 60% of the patients had a significant erection and were able to have sex. So we're excited that it's there and that it was found, because it's a totally different way. How it works is it sort of cools and then warms the skin, which stimulates that nitric oxide, which is one of those chemical mediators in the penis that helps the blood, smooth muscle relax and the blood flow in. That's how it works. And so, again, it doesn't work for everybody. And it's got like that maybe 60% success rate. So again, is it right for you? It's a topical. Be careful. You don't need a prescription. It is over the counter. Try it somewhere that is less sensitive than the head of your penis first to make sure you don't have a weird reaction, and then try it on your penis. Injections. People used to call me the injection king because I did so many injections with patients over the years, and that's true. But I will tell you from the beginning, injections are not for everybody. There are patients who will never do injections and never should do injections because they aren't right for everybody. But why do people like them versus, and the dropout rates are higher than the vacuum pump. But why might somebody like it over the vacuum pump? Because you don't have to wear a ring during sex. You don't have to use all that gel and lubricant all over the place. You get a fairly strong erection that even when you climax may not go away. Now, the downside is you better make sure it goes away before you go to sleep, because one of the risks is an erection that will not go away. You've heard about it in the commercials, that 4-hour erection. That is not a good thing, people. It is not good. Your penis is, you don't want to have no blood flow in and out of your penis for long periods of time. When you have an erection, blood is not flowing freely back and forth. It is trapped in your penis, so you have that erection. You don't want that for hours on end. And it is a medical emergency, and you have to go to the emergency room. I have never in my practice seen someone get that from pills, even though they talk about it, and it may occur very rarely. But I have seen it in up to 10 to 15% of men who do shots. So you have to know what to do to go to the emergency room and get it resolved. So there are some very serious things you have to know how to deal with this. Now, remember, 85 to 90% of men will never have a priapism and do fine with the injections in terms of that. You also could get scarring in your penis. Those are the rare things that are more serious. The most common complaint with injections is pain. Of course, you could have needle pain, but more uncommon is one of the drugs can cause a throbby, headachy pain in your penis, and that's not conducive to sex. About a third of men get that. But you can get other things like bleeding and bruising, different things. You always need to learn to do injections under the guidance of a prescriber. You should always do your first injection in the office. You do it not your first, but one of your injections in the office, either your first or subsequent one, under supervision to make sure you're comfortable doing it, to make sure you didn't have any adverse reactions, and to know the reaction that you had. And then they'll do more teaching from there. We did an excellent podcast on this, but nothing replaces one-on-one training that has to happen with penile injections with a expert healthcare professional like a nurse or doctor or assistant, someone who can teach you and supervise you to do your first injection and make sure you're okay. That's super important, because as we get more invasive, we get more potential, not that they happen that often, for things like permanent scarring in the penis that causes curvature or deformity or other things that can occur. I've had people who did injections for a decade and never had problems and loved them. But the dropout rates are more than 50%, because remember, they don't work for everybody. Efficacy is about 80%, about 75 to 85% in the studies. So it doesn't work for everybody. That leaves like 15 to 25 or so percent that it doesn't work for. So it could be up to a quarter. And then also side effects and other things. So dropout rates can be high on injections. But if you're trained properly and you get comfortable with it, I've had people who, again, really like it. I have people who hate. I'm so glad we have all these treatments, but make no mistake, they have good, bad, and ugly. I try to tell you as much as I can in the book and different things so you can make your own informed decision. I don't try to talk you in or out of any treatment. You should never be talked in or out of any treatment. You decide what happens in your body. You look at the facts and make your own decision. Then we have surgery. Now again, only 1 to 2% of men with erectile dysfunction will do surgery, but of the men who do, 80% or more of them are happy. And in my clinics, all the clinics I've worked in, many of the men are very happy, and so are their partners, because this goes where you go. You can use it as much or little as you want, but it's totally permanent. Once you put all this in your body, like a new knee or a new hip replacement, when you put these cylinders and pieces all in your body, even if you take it out, you'll never be the same. This is a permanent solution that some people do. It's permanent. It goes in your body. It may have to be replaced if it malfunctions or becomes infected. And eventually, if you have it long enough, it will have to probably be replaced. But the most common side effects are pain. It's a sensitive place to have surgery. So it's going to hurt. It gets better. It really does over time. But even a month or two later, just like a new knee, you go to use your penis or you go to walk on your new knee and it hurts a little bit. So there's things, don't walk on your penis. All kidding aside, this can be life-changing for some men, but most men do not opt for this because it is a surgical procedure. It's an elective surgery, and there's inherent risks in that. But the men who do and their partners, if you're well informed and you weren't talked into it, the huge majority of them are very happy with it. And I've had many come back and say, I don't know what I waited for. I really liked it. But so I would say, again, that leaves about maybe 10 to 20% who aren't happy, and they're usually unhappy about pain. They're usually unhappy about shortening because they have to set it back a little. If they don't set it back a little and leave some of your tissue, it can come through the end of your penis. So there's size differences. They try to work around that as much as they can, but I would go in thinking, I won't be quite as large as I was. It's not a lot. when I'm fully inflated with the penile implant as I was when I was fully inflated with my own erections. Okay. That's a good way to go in and understand it. And then I think you'll have realistic expectations. So size changes is the second biggest complaint. Some people say sensation changes, but most people say it feels good and I'm able to now have intercourse, and that's really wonderful. But some people have difficulty orgasming or diminished sensation. That is not common. But again, that's something that's brought people back afterwards, especially with reimplantations where they had to go in and take one out and put in a new. The more surgery they do, the more scar tissue, the more potential complications to your penis. So, and they can last just like anything mechanical, 5 years, 10 years, 15. I've even seen them last 20 years. But like a refrigerator, it may go out in 2 years. It may go out in 15 years. So if you have one long enough, you may need to replace it. Lots of things to think about. I lay it all out in the book. Make sure you know each of these treatments fully before you make your own informed decision on, is it right for me? And that's all that matters. You and your partner's opinions are the only ones that matter. What about women? Real quickly, I just like to touch on this because a lot of, especially with prostate cancer, that doesn't occur in young patients in their 20s and 30s typically. So this is going to happen most commonly in your 60s, 70s, things like that. So, but women are also struggling with their own issues. Remember, they have a 10th of the testosterone we do, a 10th. If we had half, we'd be like, ugh. They have a 10th before menopause, and then it decreases just like ours does with aging and menopause. Most people's decreases over time. So that's where the drive's not as much, but they also get, because of lack of estrogen, shrinkage and dryness of the vagina. This is the number one complaint of women that brings them to the gynecologist or to healthcare providers is vaginal dryness and atrophy. It's called genital urinary symptoms of menopause. It can also cause urinary tract problems and bladder problems. So we use things to normalize and estrogenize locally, not systemically, the vagina. And there is a cream, there is a ring, and there is a tablet, and they all work equally well. The creams and tablets initially are taken every day for 1 or 2 weeks, and then only twice a week typically, sometimes 3 times a week, but often just twice a week. A little goes a long way. But when we re-estrogenize that area that's so estrogen dependent, it makes a world of difference in these women. They even sometimes, and it's prescription, check with your prescriber, but even with breast cancer and cancer dependent and hormone dependent cancers, some people are able to safely use these. There are also non-hormonal moisturizers that keep things moist and supple. But I can tell you, these local estradiol therapies work very well for vaginal dryness and atrophy. And most women in their lifetime after menopause at some point will need something to help with this. And also a lubricant for during sex. A water-soluble or a silicone lubricant just helps with friction during sex too. Lubricants are different than moisturizers. Moisturizers keep the tissue supple and moist in the way it's supposed to be. Lubricants are for friction during sex. These are some non-hormonal moisturizers. Neogen was developed by an Asian gynecologist. Neogen Vulvar Soothing Cream. It's non-medicated cosmetic. Nueve is the one that was developed by the Asian gynecologist. But Neogen is a vulvar soothing cream. That's very different than a moisturizer or a lotion. But I wanted to mention it because it's something that some people find helpful. Hyaluronic acid, it sounds terrible, but it's in these vaginal moisturizers because it brings like 200 times more water into that area. And that's in different products that you'll see, but you need the guidance of someone to help you with a moisturizer. Vitamin E vaginal suppositories can be helpful for some women too, for soothing and especially when you have pain like vulvodynia and things. Replens has been around for years, and it's a vaginal moisturizer. Luvena KY liquids, all these different things that are vaginal moisturizers, and these are non-hormonal. And then Nueve, as I said earlier, was developed for both odor and moisture, and that was developed by an Asian gynecologist, and you can find that online as well. So there are non-hormonal ones if you're just scared to death of the word estrogen because of cancers and things like that. Here are some resources for patients. My podcast is called Dr. Jeff Talks About Sex and Intimacy, and that website at the top of that is my podcast. You can find my book on there, Reclaiming Sex and Intimacy After Prostate Cancer, and download it free. And that's all thanks to the generosity of my amazing patients who gave to the foundation that supports educating my patients and all the research that I've done with patients that you'll see in the book too. So drjeffsextalk.com is where you can find 75 podcasts with relationship experts, with urologist experts, prostate. Brian Helfand, who's also part of this program, did one of the podcasts on prostate cancer. One of his associates did one on BPH. Lots of good segments on sexual health and relationships on Dr. Jeff Sex Talk, and my book's there too. You can download it for free. You can also get to a link to buy a hard copy of it if you like that. For you with cancer, NCCN has some wonderful websites of some resources for patients as well. drjeffalbaugh.com is the book website. You can go there too, and it has a link to the podcast website. You'll get to me either way. Cancer.org, that's the Cancer Society. They have some wonderful resources for cancer patients specifically as well. And cancer.gov too. And then lastly, Sexual Health Matters is the Sexual Medicine Society's website with information for patients. And also you can find providers there like urologists and gynecologists, sexual health expert providers, advanced practice nurses like myself, physician assistants. A lot of times we're the ones, because the urologists are surgeons and they like to do surgery, and we do some of the medical things like manage sexual health for, in the clinics. So sexualhealthmatters.org, or the SMSNA, which is the Sexual Medicine Society of North America, smsna.org. Hit on Find a Provider and you will find providers that are experienced in sexual health. ASECT, which is the American Association of Sexuality Educators, Counselors, Therapists. I'm a certified sexuality counselor. You will find us on that site. Hit on Find a Provider, and then you'll put in information on what area you're in, and that will help you find a therapist, a sex therapist, couple therapist type person. There's been so much to unpack and talk about. It is the greatest honor and privilege of my life to work with patients. And so I truly appreciate this opportunity to share my expertise with you, listener. I hope you know that you are so much more than the prostate cancer. You are so much more than the erectile dysfunction. You are so much more than that, and you are enough. That is just the truth. So how do you navigate your way through sexual dysfunction after all these issues? I hope that's been helpful, what I provided for you. There's some great resources out there, and I'm sure Dr. Moyad and I will talk more about that. But my hope and prayer and wish for you is that you have better sexual health, that you can't necessarily recreate what was, but you can recreate and co-create spectacular and have wonderful, loving relationships, intimacy, and sex after prostate cancer, after erectile dysfunction, whatever you're struggling with. You are not defined by disease in any way, shape, or form. I hope all that has been helpful. It's never my goal to persuade you or dissuade you what you should do. It's to help you get information and explore options, real options, with research to support them. So thank you so much for your attention, and I hope it's all been helpful. Oh, I had one more slide. Let me share with you one more slide. Dr. Moyad said I should add one. So my key points were really that sexual dysfunction occurs after prostate cancer. What did I say? 8 out of 10, 2 years, 72% 5 years after is what the research shows. So very common after prostate cancer treatment with surgery, radiation, androgen deprivation. Sex, and also 1 out of 5 men in their lifetime will have erectile dysfunction. It is so, so common. Sex and intimacy issues can be addressed successfully. There is hope. I hope, if nothing else, we've given you incredible hope, because there are treatments out there. You and your partner can find your way to incredible connection, intimacy, and sex. Communication is critical. So start talking about it, especially when things are wrong. And no, if I don't leave you with any other message, it is possible to have an incredible, enjoyable sex and intimate life after cancer treatments, after erectile dysfunction.
Yeah.
Thank you so
You
much.
know, I know you were introduced by Alex, but I have to just say something and you have to basically agree to whatever I say. I have known you for probably 30 years, 25 to 30 years. You've
Yep.
probably invited me to about a dozen conferences, all of which I said yes to. I've only invited you to a couple of things because I always felt sorry for you. Everybody wants you to speak for everyone else. And before you gave your talk, you agreed to be at our fall conference September 18th and 19th. Dr. Alba is going to do his own breakout session with couples, his own seminar September 18th, Friday at the LAX Marriott in the room there. It's just him answering questions and giving a lecture. I am so excited about this for two reasons. One, I don't have to ask him that many questions today because he's going to cover all of it on September 18th, and that's his niche. This is not mine. But number two is, again, I can't help but emphasize he's coming to our largest conference in the world. He's agreed. We talked him into it. We twisted his arm. And so, breaking news. September 18th, afternoon session with couples, or come by yourself, but couples would be ideal if you can. Bring your partner. He's going to give a lecture and answer all these questions. So I'm so excited. Thank you very much.
I am too. Looking forward to it, Mark.
Yeah, me too. All right. Thank you for the great talk. Hour and 15 minutes. It was a pure gem. It's like, okay, I've got 30 minutes with you. What do I cover? I decided I know what I'm going to cover. All right, I'm not going to show you the book. I was 29 years old when I did my first book. 29 years old. So this is the 1990s, right? I want you to I want you to hear a passage. Is prostate cancer a partner's disease? A recent study, this is the 1990s. A recent study out of New York City's Memorial Sloan Kettering Cancer Center looked at the effect of prostate cancer on the man and his spouse. Most of the patients, blah, 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 average age, blah, blah, blah. And anyway, the partner had greater overall trauma than the actual patient. In almost all the comparable categories, a larger percentage of the partners were affected just as much as the patients. Here's my first sign. This is the quote that I used, and I used it again recently. Prostate cancer is a couple's condition, a couple's disease. You have been saying that ever since I first started listening to you. Can you once again just talk about that a second? We have to keep in mind this is a couple's problem. It's not you going through it by yourself. It's not fair. Can I say that? It's not fair not to bring in your partner, and I'll let you speak.
I totally agree. If you have a partner, they are part of your journey. They probably have been there since diagnosis and they're living every single step of it with you. So I always encourage all my patients in my sexual health clinic to bring their partner if they have a partner, or their partners. If everybody gets along, bring whoever you're partnered with, bring them in and engage them. And like I said during the talk, we always think, wow, who's it harder on? The person who feels like they can't do anything to help the partner, and it's not happening to them, but they're watching it happen to that person they love so much. It is definitely a partner. It's a partner disease. So if you have a partner, it's so important to engage and involve them in this. And they're struggling too. And here's the thing, Dr. Moyad, that I think is so funny about it all is that, so I started to talk a little bit about it in the presentation, but now we're like, couples get to a place where like, should I hold his hand because maybe he thinks that means that I'm interested in sex and I'm putting pressure on him. So then they're like, I'm not going to hold his hand anymore. I'm not going to hug him. So now even affection falls off. If you don't start communicating and talking about things, the changes, the couple is profoundly impacted by this. And it doesn't have to be that way. In my study, we found when we interviewed partners, they actually said it got better. It got deeper. It got richer because we had to work together on it, and we did. So it can get better. It can get better. It can get richer. It can get deeper. It can be more wonderful. But you got to start talking about it and working on it together and know that each of you is struggling. I love that Zero Prostate Cancer has a partner group that meets once a month and that they offer that for partners just to have their own space to talk about things. We always include partners in my group at Gilda's Club, which is also a Zero Prostate Cancer group. Every third Thursday of the month, Partners are welcome, and we encourage people to bring their partners along with them if you have a partner. So I think it's so important. And if you don't have a partner, now whole nother can of worms. How do I introduce this issue? How do I talk about it with a new partner? We'll talk about all that at the session in September, because those are all really challenging problems that you're facing. So whether you're with a partner or not, I think there's a lot to unpack and talk about. But if you've had that incredible someone to go through this journey with, make sure that they're being supported and that they're a part of all these learning experiences and discussions.
Do you find that when you do counseling, do you find that there's a continuation effect, meaning when someone is treated for prostate cancer and the couple's already close, they tend to do better on the other end after the treatment? And then the couples that don't get along very well going into treatment don't tend to do well after, but do you find that?
I think it is absolutely true that navigating your way through really hard things in life, the hardest things in life, teaches us the most, gives us the most meaning, and so can enrich and improve our relationship, especially if we started with a pretty good one. Absolutely. It could challenge our relationship too. So I think it could go either way, but there's absolutely no reason that it can't cause your relationship to deepen. When you're going through a cancer treatment, when you hear those words cancer, it feels like you're isolated and alone. So it's a wonderful thing to have someone there on that journey with you. And so I think letting them in and letting them be a part of it, how it could enrich your relationship.
Yeah.
Absolutely. But I do think sometimes when there's lots of problems, I don't think a cancer treatment a cancer diagnosis, these things are going to fix those problems, and they may make it worse. It may make it better. People may step up and realize their own immortality and realize how important it is to come together and then and really enjoy every moment of life. Mark, here's the truth. We could be gone in a second. I ride my bike everywhere. We could be gone in a second. That's the truth of our lives. So we have to take every moment and make it count.
Yeah, no, well said. So I went through a lot of different studies before. I tried to make myself a pseudo expert in your category, which is not going to work. I tried to look at what the latest studies are saying, and they all seem to be saying something similar. So I'm wondering if you can give people at least this part similar. Here's what I wrote out. Should all men and their partners receive some type of couples counseling? And if the answer is yes, or at least some men and their partners should, that's part one of my question. Part two of the question is, I'm sorry, but if you quizzed a bunch of us in urology and said, where do you go for therapy, post-treatment, pre-treatment, whatever, a lot of us would go, I don't know. Mm-hmm. So do you think this should be a mandatory discussion? And even if I want therapy as a couple, besides going to your event on September 18th, where do you send these folks?
That is an awesome question, Mark. Definitely. And here's the thing. First off, I think I don't ever say everybody should do anything because, as you know, first off, then there's people who are going to hate me because I even have trouble getting some of my people who I'm a sexuality counselor to go see another therapist or a couple therapists or whatever. So I do couples therapy. I was trained in that, as I said, but I also am a certified sexuality counselor. But I think sometimes people are reticent. There's stigma around going to a therapist or a counselor, but I think it can be so helpful for so many couples. I love the different clinics like Sloan Kettering who have counselors right there with the prostate cancer patient from day one. I think that's so smart, and that you can tap into that. At Gilda's Club, you can talk to counselors, you can work with people like that. Many of the cancer wellness houses offer free counselors and people that can work with you, but you can also, so where to look to find them? If you're looking for a sexuality counselor, as I said earlier, the American Association of Sexuality Educators, Counselors, and Therapists, so www. Like everything starts, right?
Okay.
AASECT, www.asect.org. When you go on there, you will see right in the middle of the page, find a provider button. Click on it, and then it'll guide you through steps to find a provider in your area. The internet is amazing. You can find couples therapists, you can find ratings, you can find reviews, you can find a lot of things out there when you're looking for a therapist as well. But ASECT is a place you can specifically find sex therapists, sex counselors, sex educators, and most of them are couple therapists too.
ASECT, AASECT, American Association of Sexuality Educators, Counselors, and Therapists, right?
Yes. .org.
Okay. Does that includes in-person as well as Zoom therapists if I don't want to go in?
Yes. So, and you know, these days so much is by Zoom. So just know that sometimes it's hard to find an in-person therapist, believe it or not now. But many of the people do in-person, Zoom, and phone. The good news about that is you could find someone you love that's in a whole nother place and meet with them by Zoom potentially. So there's lots of resources for a good therapist, and you could do it from the comfort of your own home if that's more comfortable for you. So,
okay. And I don't want to say this, but if you don't want to do it with your partner right off the bat and you go to AASEC, then you can do a counseling session by yourself.
Absolutely. Individual sex therapy, individual counseling, you can do all that. Of course, we always encourage you to include your partner, but you can do individual work as well.
Why don't I ever see that site anywhere? Is it me? I'm serious. You're the first person. I mean, anyway, that's a whole
No,
lot.
I think that it's not always easy to find. We send a lot of people to it from the podcast and stuff because we have so many experts on from my colleagues and friends from ASECT. But that they're not the only great sex therapists and couple therapists out there because all this costs money. So like to get certified by ASECT and all that stuff, it costs money. It doesn't mean it's the only way to find a good therapist, as I said earlier. So don't think it's the only place that sex therapists and couples therapists are because they're not. It costs money to be certified as a sexuality counselor and to be a part of these organizations. They're great, but I have colleagues, Richard Carroll, who I've worked with for years at Northwestern, is phenomenal. He's not a ASECT certified sex counselor, and that's what he did for decades. So everybody's different. So yeah.
Well, you're going to really love this question, but I always think about this when I think of therapy because we used to always say this all the time. We used to say something to the effect of when you get a good therapist, it's like a really good marriage. When you get a bad therapist, it's like a really bad marriage. In other words, I hate to say this, but that's how we try to keep it real, the pros and cons. How do I even have, I think most people know if they're getting good therapy, they're feeling good, they're intuitive. How do I know that it's just not working out for me? Do you ever give anyone just kind of advice when you should cut and run and maybe find someone else, not leave therapy, but I know people don't like to talk about that downside, but do you ever talk about that downside? How do you know if it's not working and you need to move on?
I think what you said is absolutely true, that it is somewhat, you're co-creating together. It is like a marriage, it's different, but I mean, in that you have to have a good working relationship. And you have to be able to work on things. So I think that's really important. But I think number one is first give it a chance because sometimes the intake is not the place you're going to figure out exactly yet. So give it a couple sessions to determine. But when your gut, not your overthinking things, when your gut really tells you things are not right, they're really usually not right. And you're absolutely right. There are good nurse practitioners, clinical nurse specialists in urology. There are good urologists. There are good OB-GYNs. There are good therapists. There are bad ones. There are not so good ones. So finding the right person can be really important for you. Some people are more confrontational with therapy. Some people are more, really sit back. What works for you? Cognitive behavioral therapy, which type of therapy? You'll see. Today, you can, on the internet, they tell you all kinds of stuff about that. That therapist will give you a bio, their what their beliefs are, and then you can read reviews and things like that. So yeah, but you're right. And people don't always talk about it, but you need to find the right therapist, and that can be a little tricky. So don't think one therapist, it may take a couple, to find the right one.
Yeah, because I'm wondering, all these therapists and the ASECT, these are people who also work with couples that have dealt with prostate cancer, a number of
Mhm.
them. Is that the case?
Yes.
So you can actually go specify and find someone working in that, like, like someone can find you, right? So,
Yes, yes. And
okay.
again, I worked with another Dr. Linda Sizemore up on the North Shore of Chicago. I loved her. I sent so many patients to her. She wasn't ASEC certified, but she had decades of experience working with cancer and sexuality issues, prostate cancer in particular, different things. So look around. You'll find there's lots of different. It's I've heard somebody say in Chicago sometimes because LA is probably that way too. I don't know, but in Chicago they're like you can't shake a stick without hitting a therapist because everybody there's a lot of therapists. So there are a lot of therapists out there. Some are clinical social workers, some are a PhD psychologists. So
Right.
just find the right fit for you, what works for you.
And like I always like to say at the end of the meal, who's paying for this bill? So, I mean, in other words, in all seriousness, does insurance cover part of this? Is this an all cash business? What's your general advice when it comes to that?
Of course, you pay a lot for your insurance. So if your insurance covers mental health visits, and you can find all that out. My insurance has a very generous mental health benefits program. Um, so find out. Some of the therapists, many of the therapists accept insurance, but not all of them do. Some have a fee for service fee, so they keep it somewhat reasonable. What some people might think is reasonable, what some people like, oh my gosh. But you'll see up front a lot of times on their websites, this is how much it costs for a visit. I don't take insurance. Some of them have you do your own submitting to insurance, but a fair amount of them take insurance. And of course, those are all things you're going to try and figure out as you're figuring out, is this the right person for me? And some of them have sliding scales. Northwestern Family Institute will see people virtually for free for couple
Mm.
therapy if you qualify and have low income and things like that. So there are resources out there to get therapy. Like the one patient told me, and in my study too, said, people don't get it. They don't understand. And I didn't get it until I lived it. And then I realized, wow, this bothers me a lot more than I thought it would. It really is affecting every aspect of my life, not being able to be the sexual person that I was before.
Absolutely. So here's what I did. I went into the urology literature the past few years. I wanted to look for the largest study of partners' unmet needs. So I thought you might find this interesting. And here was the take-home point. Some of the largest study and one of the largest study of partners' unmet needs by Gupta in urology. Let me read these to you and tell me what you think. Some of the unmet needs, and this applies to anybody who's going through prostate cancer. More info on sexual health websites. We're not giving out enough info on health websites. I don't know if you agree on that or not, but where do I even go for that?
Well,
Do I go to your address for your? I'm serious. I'm serious. Do I go? I mean, that really caught me off guard. Like people aren't getting info on good sexual health websites. So is that an unmet need, and where do I go?
so I obviously think that's the biggest unmet need in the world because now, believe me, for completely free as a labor of love, I create a podcast every week to give people good resources and information on all kinds of sex, intimacy, and relationship things. So I think it is a complete unmet need. You can go on Zero and find a lot of good information. You can go on the cancer.org or cancer.gov. There's sexual health matters. But I think there's a huge need. That's the whole reason, honestly, that I created the podcast. Not because I need something to do on Tuesday night and have to corral people and experts and make all my friends come on my podcast because they're so amazing and have such great information, all my expert friends. But because I believe in the power of good scientific based information, good information to help people make their own informed decisions. Not persuading or dissuading anybody, but giving them what they need to make their own choice about what's best for them in terms of prostate cancer or sexual
Yeah.
issues.
What sexual health matters, by the way? You said that. What is that?
So that's SMSNA, Sexual Medicine Society of North America. That's their patient information site, excellent, lots of good things on there. So sexualhealthmatters.org is their info site where you can find things on what's erectile dysfunction, what's whatever, what's my prostate, why should I care, all
Yeah,
that.
great group. I didn't know that they had that as something you could go to.
Yep.
See, the other thing was the unmet need was they want more partners only support groups. You mentioned there's one at Zero. For those people who don't know, Zero is a major advocacy group in the United States. They're big time. All of us have worked with them on some capacity. So they have a partners only support group.
They sure do. It's
Just go to
excellent.
Zero.
Terry, our friend Terry has started that group. It is peer led by a caregiver partner. They have a LGBTQ plus group as well. Zero does.
That's
So
one of my questions.
whoever you are, whatever your needs are, what's great is, and honestly, I got to give Terry a lot of credit.
Terry Lukowski.
Yes,
Sorry, I mentioned her last name. We've been friends with her forever.
I
And
pushed for
she
her
did
to
Zero.
Yeah, I pushed for her to do that couples group, and and she agreed wholeheartedly. And then to that LGBTQ group. So yes, I do believe caregivers need a space and a place to talk freely. And that's a group too that like their partner's not there, the man with prostate cancer, so they can just talk about their frustrations, talk about their upsets without, causing distress in their partner. But that's a great group.
Okay.
And that space is totally needed.
So we'll put that up as a link after your lecture so people know how to get to that site. The other big unmet need was it says partners only support group, but support group for couples is somewhat similar in the sense you could go to these same places we're saying, right?
Yes. But I do think I think many of the individual groups, like my group is a hybrid group too. So on the third Thursday at 6:30 Central Time, anyone can come on my group, it's not just my group. It's co-facilitated by a survivor, Jim, who runs it with me, and Clint, who's from Gilda's Club. He's a social worker, a survivor, and then a healthcare person, myself, who's worked with prostate cancer patients. We run the group, but you can come online or you can come in person to Gilda's Club.
Oh.
And many of the groups, when you go to the support place to find a group locally or wherever, many of us are hybrid. So you don't have to come to Chicago to participate in our group. And partners are always welcome. Couples are always welcome. Me and Mark, I didn't think it was possible, but you came up with something I'm going to have to talk to Terry about because I don't know that there's a couples group. That's a really good idea to have a space for couples. See, that's why you're the man. You see?
No, I don't know if I'm the man, but I just went through the data and this was what people were clamoring about recently. And I don't know this stuff. And I'm going, okay, if they're clamoring about it and they think it's relevant, I got to bring it up to the person who can answer that question. I agree. I think the partners, I was on today with a family member of mine from overseas who is dealing with this. And I was trying to explain in my best way that you guys are in a boat together. Like my father used to say, don't ever get out of the boat when you're doing couples and you're together. Not one person can't get out of the boat. You're in the boat together. And but it's true. I tried to explain, look, this is not just your ordeal. And I try to show the research. So the idea of a partners only and support group for couples, that's awesome. You already mentioned this one, sexual medicine specialists. Here was another one that was mentioned that I found this to be true through my career, libido or other assistance for both. So,
yes.
Right. So what happens a lot is that you'll hear about some guy going on testosterone or something else. Who knows? They'll do something and the partner will say his libido is through the roof, but mine's not. So, why did this doctor put me through this? Why are they doing this to me? Because they're supercharging my partner, but I'm not supercharged at all. And, it's as I get older, now I get it. I really understand why so many people were complaining about that why, if you're going to talk about sexual enhancement in any manner, why aren't we addressing it for both individuals? Because just to enhance one and not to address it with the other, does that even make sense?
It doesn't. And it's so funny. Last week I did a podcast with Dr. Susan Kellogg-Spett, and we did a whole talk about low desire in couples. And what's amazing is, yes, we've had testosterone for decades with men. And even though testosterone's been strongly researched in women, it wasn't FDA approved because the FDA is a whole different animal now than when the men's was approved decades ago, right? So
Right.
now you have to do so much more. And even though they proved efficacy and safety for women, and the research is there to use it off label, it's not on label for women. But this is what's really cool. Women's sexuality and sexual health has taken off in the last years. We had nothing, and now we have two drugs. We have an oral pill you take every day, flibanserin, and a sub-Q injectable that you take on demand before sex for desire and only for women at this point. And they work centrally in the central nervous system, which is so flippin' cool. So
Yeah.
we have some new exciting things, but you're absolutely right. And that's why I want to talk even about the atrophy and dryness, because we have these guys who are working on all this stuff. And then the woman's like, nothing has been in there now for a year and it's not comfortable anymore. So we have to address both people's sexual issues, not just desire, but pain, comfort, dryness, all those things.
Exactly.
I think it's a really big deal. So, but
It,
what's really exciting is we've had moisturized, we've had estradiol for women. We have lots of different things for vaginal dryness and that now, thank God. And we've had those for a while, but now we have things specifically for desire and specifically for women. So we should be addressing it.
I think you should talk about the two drugs, the injectable and the oral from the female side, because like you said, it has been a desert out there. There's been nothing going on. And even this stuff that's interesting, it's still not catching up. And there's lots of reasons we could argue why it's not there. And now there's some men who are interested in off-label, maybe trying some of these for certain kind of issues, the women's drug. But that's another, I'm teeing up another ad that I hope when you have more time that you can just talk about those, the pros and the cons of it, because I will just never, I remember a few things in my career. I'll never forget one of the partners just being so livid, so upset that the other partner was, like I said, the word is supercharged, supercharged. And the partner wasn't feeling it, nor was it addressed that she was dealing with libido issues herself. And it was really unfair, that dichotomy. And it was one of those things that stuck with me through school that, God, that's a really critical point. Why are we just telling one partner how to change your sexuality and not telling the other? And anyway, you can
Totally.
get,
And not that I want to keep harping on it, but I create again the podcast, the second podcast that I ever did in the very beginning of the 75 is Dr. Susan Kellogg-Spatt. It's on female sexual health. She is so amazing. She's in Philly and she is my go-to person for any female sexual dysfunction things. She is one of the primary lecturers in ISHWISH, which is the female side of the Sexual Medicine Society for women specifically with sexual issues. And so that second episode, and you can go to that, listeners, but also if you want to learn more about female sexuality and all those drugs that we talked about, then she did a follow-up one later. So look for those. All of them you can watch on the website that we gave you, but they're on YouTube. You can stream them. But Dr. Susan Kellogg-Spatt's amazing. I also had people talking about menopause, perimenopause, all the things women struggle with constantly. We have the most amazing experts on there to talk about it and Susan comes on as my co-host. And anytime I'm out of town, I'm like, take over the show, you're hosting it. Because we want to always be looking at issues. I see men and women both, of course, in my clinic, but
yeah.
it's in couple, men, women, and couple issues. We have awesome relationship counselors about trauma, about all kinds of topics, authenticity in relationships, really good stuff. It's cool.
So if I want to get to Kellogg stuff, I just need to go to your site, right?
Yep. And if you go on there, she's when you look at episode 2, that's Susan Kellogg-Spatt, you'll be introduced to her, and she's been on a bunch. She co-hosts with me. She's on all the time. She's amazing.
I
So
love that. I love that. Moving through here. My gosh, I'm going to be running out of time. I got 15 minutes. Just remember, she's your co-host. So when you're out of town, she takes over, right? So let me just tell Dr. Kellogg, you'll be taking over on September 18th. He's going to be in LA for the conference.
That's true.
For people who, I've received so many nice comments about this through the years, and you can understand this. At least you can validate this. So many people go, Mark Moyad says he's known this person for 30 years and he's one of my best friends. How can he have this many best friends? And I always have to explain to people that we used to be on a circuit together. We used to have to travel the country and the world all year long giving courses and lectures. So we were this tightly banded group of people that, we would bond in LA, we'd go over here. It was just us, and then we'd go to our rooms, and it was a very quiet, but we had to do this every week, city after city. Remember all that?
Yes.
And so when we say I've known this person for 30 years and he's been one of my best friends and I've got like 20 of them, it's really true, right? So
It is true. It is
it's
true.
not like one of those late night shows where someone goes, he's my best friend, and they've never met. This is a reality. So
And
anyway,
then too, even our wives, like your wife Mia. I mean, I probably conversed with your wife Mia more trying to get you in your schedule and get you going. So it's like we really have over the years collaborated because we have such a passion for all this. So it's really
that's
good.
right. Where's the greatest problem in prostate with what you do? Is it before treatment that people don't start early enough? Is it right after treatment that people aren't given the information right after the event happens, the treatment? Or is it long term, way down the road, that people just aren't told they got to keep at this and keep educating themselves and maybe even get therapy a year or two later? Where's the problem?
I think the greatest problem, and I tell every urologist that I work with and every urologist that I talk to is don't undersell the issues of sexual problems with prostate cancer treatment. Don't undersell it because if you prepare them for what may happen and it's better than what happens, people are okay with that. In my study, the people who are really upset were the people who were told, you'll be fine. You're not going to have any trouble. Your erections are going to be good. Literally we're told that, and then they weren't. Those are the people who have treatment regret and are super unhappy. No one is served by not telling them up front these staggering statistics. Look, Mark, and you've written books, so you see all kinds of comments out there, and I know my books help people, and I wrote it only to help people. There was no hidden agenda. But I did see someone said, this is depressing because I'm giving them the facts, the truth that oftentimes they're not going to hear from the surgeons and the different people. Some surgeons will tell you, but I'm giving you the truth from the patients themselves so that you know what to expect, because managing expectations decreases treatment regret. You should never go into a treatment that you don't truly understand from all sides what may or may not. We can't predict what will happen with you, but you need to know what may happen and be prepared for it. That's why I think it helps to talk to a couple different providers getting opinions, a couple urologists and radiation oncologists before you make the decisions with prostate cancer, and to talk to peers, men with prostate cancer. That's why I think the peer groups are super important. So I think that one of the number one things is information is power. And so what we're doing right now, I think, is the most important thing for people with prostate cancer. An informed patient is someone who can make their own really good patient-centered decisions. And that's all you should ever be making is your own. But that's what's hard about prostate cancer. That's a really good point, Mark, right? Patients say to me all the time, this is what's so hard. No one can tell me what to do. And there's a couple good choices for me. And that's the truth. The great thing is there are multiple things that could cure you of prostate cancer, get you to an amazing place. But there's no definitive absolute path that someone can say is your path most of the time, like there are with some cancers. There are choices. So the great thing is there are choices. The horrible thing is you got to choose one, and that is really hard to navigate sometimes.
Wow, that's so good. Today when I talk, I call them friends. Everyone's trying. I have plenty of friends. Today, talking to a friend and his partner, I said, okay, if you're picking surgery, fine. He seemed well educated. I said, just make sure you ask him the basics, bum, bum, bum. Ask him about the neurovascular bundles. Is he going to preserve those? And he said, why would I ask that? And I said, because it's a whole different game in terms of rehab if they can't preserve them, or if you think there's a chance you can't preserve one or both. Why is that important? I said, because it changes your rehab. It's a night and day difference. And again, it's this idea. These are the people that have decision regret. These are the people who weren't told, and all of a sudden they have to climb a bigger mountain. But Just to get your point, European Urology Oncology 2023, one of the largest meta-analyses ever. I decided to pull it because I'm an evidence-based guy. So about 20% of patients had regret, and they looked at 14 studies, almost 18,000 patients. Similar regret with all different treatments. However, higher regret, here it is, higher regret in those who had decreased involvement in their decision-making process.
Wow. And how can you make a decision when they didn't give you all the accurate information
Bingo! Bingo.
about
Sorry,
sexual side
Mike.
effects?
I need
About
to
sexual side effects. Me too. I'm right. I'm on your bandwagon. But like if you're not brutally honest about sexual side effects, then you're not being fair to the patient. I went on I forget, I've been on lots of different things like you podcasts and calls, and there's a urologist who does a radio show, and he's like, it seems like the cost that men pay for prostate cancer is sexual function. And of course, we all know that is it. That's why we're here talking about all this, because, and if you're not that guy, hallelujah. That's wonderful. But we talked about the staggering statistics and stuff, and that doesn't mean you won't recover. Another thing, you talked about the nerve sparing, and men are like, I don't think he really spared them because look at all the problems I'm having.
Yeah.
Nerves don't respond well to be taken off, even when they spare them beautifully, dissect them awesomely. You still may have problems, but you still may recover. And this is where the hope comes. Remember, it can take an average of 2 years and up to 5 years for nerves to recover after radical prostatectomy. And now there's all those cool focal therapies where they do less with nerves and stuff for the right patient. And again, you got to figure out who you are and if you're a candidate for these things. Cancer control, I think most men will tell you, is their top priority. And then they don't want to leak urine, and they would like to have sexual function. So you got to look at all that when you're making those really difficult decisions and navigating.
I think it's so interesting that from head to toe, if there's a neurological insult or an accident, the doctor talking about rehab or the healthcare professional talking about rehab, the person goes, it makes sense. You had a neurological insult. Prostate cancer treatment is also a neurological insult.
Definitely.
It should have a rehab, and rehab should be accepted just as many other neurological insult or accident or injury or trauma. Okay, so you got me all fired up. I'm coming to your session. Like I said, I'm going to drop by. A common concern for couples. Here's another one, Journal of Sexual Medicine 2022. A lot of these people I know, some of them from our university. 2022, a common concern from couples was not receiving enough information from their healthcare providers regarding sexual side effects from prostate cancer and its treatment. Again, talking about regret. Okay, I'll get off that bandwagon because I don't have much time. Here's a couple other quick signs for you. I just decided I'm just going to jump all over. It's going to be grab bag. There's going to be no wrong it's like my life. It's total chaos. What do you do if you and your partner, there are partners completely uncomfortable talking about intimacy and sex? That's number one. Or what do you do if your medical team handles it the same way? They're not saying, I'm uncomfortable. It's very curt. It's not very pithy. It's very cursory. I know these are tough questions for you, but what do you do if your partner's just not that comfortable? You've known this person a long time, or you just don't feel your medical provider is? Does that go back to counseling, or what do you think?
So if couples, what helps is I'll say, so bring your partner in when you come so we can talk about this. And if we can get them to come together, that starts the conversation. Even if they just come into the urology office, into the couple therapy office, any of that will start the conversation. So that's one thing. And then if you're more comfortable, like I have lots of people with the podcast who watch it together. They cuddle up together, they watch the podcast, and it generates discussion. Wow, did you ever hear that term outer course before? I never even heard of that. That starts the conversation. But you're right, Mark. There are couples, and culturally, there are couples who are like, oh, she's never going to come here. She's not coming with me.
Yeah,
She will not talk about sex. And you know what? We have to meet people where they are and accept where they are. But I would say when you're looking for your provider doesn't necessarily, but can they give you some resources to point you in the right direction of where you can learn about sex and intimacy? And so I think that's really, really super important. And you've quoted a couple times from the Journal of Sexual Medicine. By the way, that's the SMSNA, Sexual Medicine Society of North America. That's their official journal for research. So that's when we tell you to go to their website for patients. That website we talked about earlier, the Sexual Health Matters.
Yeah.
That's why, because it's all based in research. But I do think, like you said, I've had people say, "Oh my gosh, my doctor almost ran out of the room when I told him I'm having sexual issues," So I get it. But you can always go to Sexual Medicine Society or ASEC to find someone who's very comfortable talking about it. If you're not comfortable, you can watch things like the podcast, look at things that help you learn, but you don't have to talk to anybody or tell anybody, or even you can watch it on YouTube and nobody even knows that you're watching it necessarily. Be a little careful because we all know when you go on the internet and do things, you get all kinds of things because it seems like sometimes people are watching. But you can do it in the privacy of your home in your own way. That's what's so great about what we're doing today, Mark, because it gives those people who don't feel comfortable asking the questions or doing whatever, you're asking them for them. The podcast answers it for them. These are labors of love that both of us are doing. Trust me, it does nothing but cost me money to have a podcast. Trust me. I guarantee you that. I have never gotten a single cent. My book, no, 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 no. These are labors of love that we do because luckily I'm paid to take care of patients in my clinics and sometimes to speak, but certainly not to do a podcast at this point at all, nor to write a book at this point at all.
Before we end tonight, I still have about 5 or 10 minutes, but before we end, I'm going to make sure people see your book because I've had this in my library since the day it came out. In fact, I found it today when we were on the phone. I said, I think I have it right there on my shelf, and I do. And it's no charge. That's right. I said it's no charge. It's not one of those things where people say no charge and then they charge you someplace else. What I'm saying is, we see this publications all the time. Someone will go, we see this in the financial world. Hey, just get my book. And then, I don't know, they charge it for a subscription for something. But anyway, I'll mention that.
Download it free. You can download it free. It is free. I promise you, it'll download free. Now it's long and printing it may cost you a fortune.
I think it's an easy read. I think
it is an easy read. It is
because, and I'll give this a little bit of hype in a second. I just want to make sure I go through all the questions I wrote down. All right, these are just questions from all over the place. I read an article by Daniels et al. It appeared in the International Journal of Environmental Research and Public Health. The quote is, it says, ultimately, you realize you're on your own. The impact of prostate cancer on gay and bisexual men couples. And I thought, wait, what? And so the article was about doing focus groups in gay and bisexual men and seeing that they're just not getting the resources. I don't know this. In this work, they're not getting the resources, especially in this category. Do you want to comment on that?
Absolutely. That's why Terry created that group for specifically a space and place for them to talk about issues that were specific to them. And I think it's absolutely true. And actually, a colleague of mine at Northwestern did a study, and they kind of had a group going for a while there. Because I do think it's an underserved population that they definitely don't always get the information they need in the ways that they need, or they're not represented well, or even some of the providers don't necessarily know their unique situation. So, like for example, most of those, certainly if we have like a gay couple, so one of them, you got to talk in their language. It was one of you a top or you a bottom. You have to talk to them about what their preference is and what they're doing, and then help. You have to know them. You have to be able to help them on their level. You have to meet them where they are. And I think that's really, really important. And that's where I think you really will find with a lot of those ASEC therapists in particular, they're very welcoming, they're inclusive. Many of them have exclusively, there's quite a few that have LGBTQ clientele exclusively or certainly, and you'll see all that on their bios on all, so you can
On there.
please look for a space and a place to be seen and heard because you matter. And yeah, and even like my transgender patients that are struggling with I had one with prostate cancer who was really struggling, and there's some unique things that come up. So I do think it's an underserved area, certainly. And yeah.
The resources are there, but you just got to go. That's why I'm glad you've given out some of these resources here today. All right, here's some other things that I just wrote down here, even though I know I'm. Do you ever talk about how am I going to introduce this in a fair way? Do you talk about in therapy and do you talk about with prostate cancer patients the idea of self-stimulation versus partner stimulation?
Oh, absolutely, Mark. We talk about, while you have we say every day your penis, remember I talked earlier about how an erection occurs. So while you sleep, your penis literally works out while you sleep to keep it in shape, which is the coolest thing. It goes up and down during deep REM sleep. So you have muscles moving, blood flowing, all this cool stuff. Wow. Well, I always say, Mark, God, if my body did that, I wouldn't have to work out. I'd be in good shape. My body does it while I sleep, but your
Right.
penis does it. It literally does it while you sleep. So what if it's not doing that? And it's not doing that after radical prostatectomy surgery, oftentimes, or after radiation therapy, a time after there, or whenever. So when you start having erectile dysfunction, you stop having those night erections oftentimes. So then I tell them, when you're in the shower, when you're in the bathroom, and you have privacy, self-stimulate. You're not trying to climax, because once a man climaxes, you're not going to get erections anymore. So think sexual thoughts, stimulate yourself and arouse yourself to get an erection, and then allow it to dissipate as you go on with your shower. Get it to come up again. Allow it to dissipate as you go on with what you're doing in the shower. If you can do that a couple times, it's not as good as, but you're mimicking as best you can muscle activity, blood flow activity in your penis. We call it regular sexual stimulation for blood flow. And so we say to them, this is part of your rehab. If they're using the vacuum pump to do some stretching along with it, we tell them it's like physical therapy. Stop thinking of it as something forbidden, because it's not. You're doing physical therapy by moving muscles and blood flow to try to get things moving again. If you're having night erections, I tell them, and when you start getting night erections, you don't have to do your physical therapy. Mission accomplished. You're good to go. Your penis is working out on its own again, and that's great. But when it's not, yes, we do encourage men, especially earlier on, again, not to climax, but to get a couple erections, let it go away. Erection, let it go away. To mimic a little what's happening when you used to get up to urinate at night, or when you noticed at night and woke up and were like, what's going on here? I wasn't thinking anything sexual. That's your penis working out while you sleep. And so we do have them do regular stimulation of the penis for blood flow. They need privacy. They need to feel comfortable doing it, but it's simply to let the muscles move and the blood flow. It settles down, do it again. That kind of thing. So yeah, we do some of that.
Fantastic. Where can I go? Where's there a website? If it's your place, great, but where do I go in terms of lubricants? So, for example, the water-based versus the silicone-based, like which one do I pick up for me and my partner? What's ideal for my situation? All the pros and cons. Do you know where I can, is there a place we can tell men who have gone through prostate cancer where to find the best lubricants, the different type of lubricants, and the pros and the cons to see which ones fit your personality and for the two of you as a couple? The reason I bring that up is because I was just kind of cruising through the internet looking, and I wasn't finding anything on after prostate cancer. They were saying, pick the right lube and do this. And I'm going, well, how do I know which one's the right one?
It's such a good question. And so what I would say is, number one, we have done several podcasts on lubricants. So look them up, and there's several of them on lubes, but not just a podcast, a couple things. Some of the places in your local places like Lover's Lane, you will be amazed at some of the knowledge of the people there that can help you find lubricants. But one place in particular that I think has really done a good job looking at lubricants and moisturizers with women, but men too, is called A Woman's Touch. And that is out of Wisconsin. And if you go to their website, it's called, just look up A Woman's Touch and go to their website. Um, they have some really good teaching things about what's a moisturizer, what's a lubricant, what are pH balanced, what's silicone versus water-based. But I think there's so many good places that you can go to learn about this. The internet is amazing, and you don't want to go to places that are trying to sell products. You want to go to unbiased sources, like that A Woman's Touch, who really, they do sell
Yeah.
things, but they're giving you that information. But we had some really good episodes on the podcast on what silicone bases versus lubricants versus moisturizers versus, and here's another thing too. I'm one of the cheapest people walking on the face of the planet, okay?
That's true, by the way.
That's absolutely true. So sometimes the generic water-soluble lubricant works perfectly fine.
Yeah.
So look at them, compare them. Sometimes those Walmart, Walgreens, Target version sitting right next to the whatever, the Astroglide, the KY, the whatever, can work equally well. You decide yourself. I always tell people, try it on your arm first. Make sure you don't have a weird reaction, because this is a lot more forgiving than down below. So I always tell them, do that. But you bring up a great point. But you don't have to spend a lot of money on a lubricant to get a good one. Some of the generics are very good as well. And but there are some, like if you're trying to conceive, there are two very specific ones for that. So look around and see, and you can find some really good information. But we've had a couple good episodes on there, and you're even making me think we should do yet another one and really tease it apart even more.
Yeah, you should. I should be your manager.
Yes, you should.
I should. I'm more than happy just to keep the education going and then just go hide. But it should be on lubricants, silicone-based, water-based, different kind of couples and their approach and what they want from whatever activity. It's incredible what's out there and the pros and cons of those different lubricants. The other thing that I don't think I haven't heard a podcast on, I don't know if you've done it, is there's a lot of bioidenticals. There's a lot of compounding pharmacies. There's a lot of TV commercials that say we do these drugs and we mix them and now you can use them under the tongue and do this. You know, there's all these sites where you can talk to a professional to get any sort of drug that you want to get from a TV commercial. And I'm not saying that they're bad. I just don't know who's addressing those. You know, who's addressing the fact that now on television you can go to a million different places to get a prescription from a person who's qualified. I don't know if you've ever surveyed some of those sites. I just was curious.
No, I think you bring up a great point. And so, like, even sometimes when we as prescribers prescribe for women,
Yeah.
so I have some wonderful compounding pharmacies, and there are things that I have to have compounded, and I have amazing compounding pharmacies. So I'm not against it in any way, but make sure it's an accredited compounding pharmacy. It should be these days, but make sure it's accredited and certified as, and so when outside people are looking at what they do. But you know, even for example, like I told you with women, when we think about testosterone, remember they use 1/10 of what a man uses, because so their dose is going to be 1/10. So you can go on GoodRx with a prescription, and if you can get the FDA approved version of these testosterone things with a prescription under a prescriber, and you're using 1/10. So maybe you'll be like, gosh, that's for 1 month, it's $500. It's 10 months for you. So it's $50 a month. So,
Yeah, good point.
so again, you want to look at your circumstance. First off, some compounding things can only be done that way. And then look at the bioidenticals. You got to do your research on all that stuff. And that's kind of tough. And boy, I think that's more your area than mine sometimes, because it is a whole world of things to look at. But people sometimes like bioidentical, like when you look at estradiol, they like a more bioidentical thing. Like, and again, I'm not promoting anything, but like estradiol, estrase versus Premarin, which comes more from horse. So it's your preference and your thoughts. Some people love the other products as well. So I think it's something to explore and think about. But it's probably and it's challenging.
That's a show. The pros and the cons. This bioidentical estrogen has the pros of this, this, and this. Maybe cost is not one of the pros. This is the
Yeah.
cheap-based estrogen, and maybe you don't like the source of where it comes from, or maybe it's perfectly fine.
Yes.
And but the cheaper ones were used in all these clinical trials, so at least it's got clinical data. I just find that someone's just got to keep weighing these pros and cons. What we did with HealthFan that you haven't seen yet is I almost felt uncomfortable. We don't talk about it enough. We did pros and cons of all these different prostate enlargement treatments, including talking about price, including what people make from them. And you got to
Yes.
cover those in order for people to make the right decision for themselves. But anyway, that's another advertisement for September 18th when you're at the Los Angeles Marriott. I have one more question, even though I was supposed to finish 5 minutes ago, and I really appreciate it. I went way over, and I apologize. But since you're going to be there to answer personal questions, which is 10 times better than me asking questions on this subject, I think the couples should be addressing this with you, not some pseudo person like me who doesn't know the data and hasn't been through it, but at least I'm there for advocacy. There's another chunk, and you actually taught me this when I went to a couple of your lectures, even going back a decade or two ago. You used to talk about this a lot. And I don't see you talk about it as much, maybe because I don't see you very often as much. What really I find can impact sexual health is exactly what you mentioned. It's the impact of incontinence after prostate cancer treatment. You talked about climacturia. There's foreplay incontinence. There's just a straight stress incontinence, the need for a pad. When you please tell me a little bit about this. You also mentioned one of the sites that you recommend in order to get more information on incontinence and pads and briefs and shields that have good counselors. So I know it's a loaded question, but you can tell we're toward the end. This doesn't get enough attention as to how, not just getting it fixed, but how it impacts sexual health. Do you want to say something about that and then talk about one of the companies that you think have good counselors on this?
Yeah, so I think a couple things to think about. Incontinence puts uh a whole nother set of issues into sex, right?
Right.
Climacturia is actually as you climax, you have and as you reach that climax, you leak urine. But people can leak urine before, during, and after sex, of course. Any of that can be possible. And so I think it is something that you want to kind of address with your provider, and it's a great topic. And we have talked about that. Diane Newman, who is an amazing person on incontinence, she has an incredible book. If you look up Dr. Diane Newman, she's a nurse practitioner out of Philly area. A lot of good people in Philly, but she wrote a book on continence products and things like that. It is
Okay.
phenomenal. So look for her book, Diane K. Newman. She's great. And back then, I think when she wrote the original book, she wasn't a doctor, but she's updated it. It's a really good book, and it's on incontinence products. It's got a million pictures. It's so cool. But I do think working with your prescriber to find the right people to get you the products and work with your insurance and everything can be really tricky. So in Chicago, we worked with, and you can work with them from anywhere, North Shore Care, which really kind of works on things. There's lots of companies out there like that, though. You don't have to use that one in particular, but these companies have dedicated their life to helping you find the right continence products, like external catheters, like clamps, like pads, like pull-ups,
Yeah. Yes.
washable pull-ups. And used to be this amazing person had something called the Simon Foundation, and they would have an innovative thing where I'd bring in all these products that I'd find out there, and we would show them and talk about them and ask them and say what should be created next and stuff. It was called Innovating for Continence that they used to do. But Diane Newman's book is excellent, and she is a phenomenal resource for that. And she did a podcast with me on incontinence and intimacy.
She did.
It's
Okay.
really, really good.
I know I'm showing this. I apologize, but I took this from
Yeah,
a program that you had over 10 years ago. It's such an unmet need. I'm not saying this is the only company around. I don't know this company. I don't work with any of them. This is how desperate to get attention out there. I saved this after I took a copy of your book, and I think it's okay to plug them or maybe use them as a paradigm.
yes.
What you should look for. They were called North Shore. They've got all these products in there. I've never met anyone at there. I only picked up this booklet at your talk.
And the reason I knew them so well was because for innovating for continence, I needed all these products and they provided all this stuff
Exactly.
that could show people. And I was like, wow, this is the coolest things. Like people who self-cath, Mark, you think they have urinary retention. Now they have self-cath things that look like a tube of lipstick that a woman can keep in her purse, and that little catheter, she can catheterize herself. There are some of the coolest products out there. So anyway, some of them are prescription, some are not. They have wearable things that you can wash for incontinence, so you don't have to dispose of stuff all the time. There's a lot of cool things. So we get excited about this crazy stuff, but it's good, you
No,
know.
but it's good because when I talk to my top colleagues who I've interviewed on this channel in this situation for PCRI, and they're the top reconstructive people dealing with side effects from prostate cancer treatment. I always say, where do you get all this stuff, in terms of incontinence and ED, some of the newest stuff that's late, the breaking news? He goes, I don't. He said the patients bring them to me.
It's
They,
absolutely
they
true.
they all say that. So anything that anyone hands me something like this, I save it.
And
So
then too, and here's another thing. You remember I am really cheap. So I've had patients come in and say, "Oh, you know what I do? I get the pads are expensive, so I get to use a lot of men use the women's pads." But somebody had this great idea. They're like, "I put a preemie diaper inside my underwear. It works like a champ, and I can like snuggle my penis down into it. It's cheaper than the pads for men." So there's ways to look at it and ways to deal with it. And so anyway, the Continence Society too has a lot of different things. But yeah, this could be a whole nother
that's
topic.
the whole other lecture. But I know that people can get some, but I can't tell you how many men have told me, look, it's the incontinence that's really interrupting the sexual health.
Yeah, yeah,
And,
for
and
sure.
I'm going, well, did you mention that to the surgeon? They're going, well, they don't have, they don't have all the resources, and I don't know. You know this story. Everyone who's watching me knows this story. I just want to know where the resources are. Let's end it with two things. This is the book that I have on my shelf. This is, I didn't know this until today. I didn't think about it. The foreword's written by Dr. Helfand, which I just interviewed for this men's health meeting. And I just want to tell you, for all you listening out there, this is a free book. So it's digital too. You can download the PDF, right? You don't have to have a hard
Yeah,
copy.
the PDF is free.
PDF's free, so you don't have to have a hard copy, but you can always print out the front page at the meeting and have him sign it if you don't want to print out the whole book. This is incredible, really, if you think about it. And I've underlined, I had enough questions underlined, but we don't have time. But we'll do this again after your session at some point. It talks about all the treatments on page 12 and what happens. It talks about orgasms, sex without erections, page 17, penile shrinkage issues, what to do there, page 24. Think about this, constriction devices, page 31. The oral products, page 41, penile prostheses, page 68, urinary incontinence, page 74. The mind is the most powerful sex organ in the body, page 80. I could go on. Be informed, page 96. Adjusting to changes and expanding to your thinking about sex and intimacy. I know this is the greatest ad for your book ever, but I'm sorry. The fact that it's not only from the guru out there, but it's free, and it's been the guide that so many people have gone to in my business. And I remember when I thought we were paying for it, but I can't believe you've made it free. If I'm your manager, I have to change your opinion on that. But
Well, for the
no,
hard
in all
copy,
seriousness,
it does cost for the hard copy,
I
but
know,
for
but I'm just
the
saying the fact
PDF,
you
it's free.
but you can pick any chapter you want. You don't
Yeah.
have to read it straight through like a novel. I mean, you can pick what interests you. And like I said, I know you're updating it, and I know there's a couple things to update, but overall, 99.9%, this is legitimate. I don't know if you want to say anything more about it. I mean, I've had this for a decade, just sitting in
Mhm.
myself.
Yeah. Yeah. And
So,
so the big thing is just I wrote it like you wrote your things. It was a labor of love that I did because my patients and the people that I lectured to said, we can't all get to someone like you. We can't all get to a lecture like this. Why don't you write a book? And that's exactly why I wrote the first and second edition of it. So my hope and prayer that it answers the questions that you have out there and that it helps you move forward and have better love and sex and intimacy in your life. That's all.
and I love these boxes. Key to success with a vacuum device. So it's very pithy when it needs to be. This is what I tried to do too when I was writing. I tried to make the font a little larger and easier. This is a very easy read But again, you can go to your website, right? Can you say that website again to get a free copy?
So they can go to one of two websites, www.drjeffalbaugh.com, drjeffalbaugh.com, or they can go to www.drjeffsextalk, drjeffsextalk.com. That's the podcast and the book. You can get, and then just hit download second edition. You can download the old first edition if you want, but I do the second edition because it includes quotes from men and partners, which we wanted their voice in that second edition. And you'll hear what they think about it, what they like, what they hate. It's all in there.
I love it. I love it. Again, I have no relationship with this. This is just the great stuff that we found. I have no relationship with this North Shore company. I've never met anybody there. We're just trying to get resources to you. I wish I had another hour. I don't, but now I've got to end it with giving you my gift. My first gift are 2 pictures that we recently took together. Peter, can you bring up those 2 pictures? So this is the gift that we're giving you. I love Puerto Rico.
I do love Puerto Rico.
I know you do.
I go every year. I love Puerto Rico.
I learned about this. Here's what didn't make the grade because I thought they might be a little insensitive, just to be candid. Are you ready? I was going to get you a cup that said, I might look like I'm listening to you, but in my head, I'm in Puerto Rico. So I didn't get you that cup because I thought that's insensitive. And this is the internet today where 1 out of 1,000 people you might offend. I don't know. But then I thought about this one. I'm not ignoring you. I'm thinking about Puerto Rico. So I apologize. These were 2 cups. These were 2 cups we were going to send to you for doing this and appreciate it. But this is the one that made the final grade, my man. This is love, right? Because I know how much you love Puerto Rico and today.
I do. I love Puerto Rico.
And I know Julie does too. And your wife was just delightful. That's a word my father used to use. It just means you guys were just wonderful to see at that coffee place. We took some great photos together. Oh, and there it is. So I showed my old Us Two t-shirt where I used to lecture to Us Two groups when they were there. That's Julie. That's you. I've never seen you in comfortable wear. Like, I don't think you've ever seen me either. And so I thought that was a great picture. And then we gave you a couple wines from up here. So
you did, which was so nice. Definitely.
Yeah, no, it's okay. But I'm so glad you came up to some of the areas that I love. And I'm glad I could meet you up there. And I just want to tell you, you've always been a gem. You've always been a great friend. I'm so happy you're doing the main conference on September 18th. For those people, again, who are going to say, Moyad didn't ask enough questions or get the question I wanted, part of that was on purpose. Part of that was to give you the time you needed. And the time you need is your own session. That gives respect and it gives deference to a topic that doesn't get the attention it deserves. So what we're going to do here at PCRI is we're going to give it the attention it deserves. So off camera, Alex invited him. He accepted. I'm the happiest man alive. And I'll see you on September 18th at the Los Angeles Airport Marriott at the conference. Thank you for doing this. I really appreciate you.
Thank you. Thank you for allowing me to share my passion and my expertise. And I really hope it's helped people. But gosh, Mark, it's always fun to work with you. We both share such a passion for enlightening and informing people. And so thank you for letting me do that.
Absolutely. And I'll see you soon. Thank you.
Thank you, Dr. Alba, and thank you, Dr. Moyad. We really appreciate your time today. Now, please remember to visit our exhibit hall at pcri.org/men's health. We have a wealth of resources there, and don't forget to click the subscribe button because it's just a great way to support our channel and get this type of education out to other men who need help in prostate cancer and men's health. Now, if you have specific questions, you can go ahead and contact our helpline at pcri.org/helpline, and you can talk to them via phone or email, but also leave your comments in the comment section below. It is a great way for us to read those and go ahead and create further content for this channel so that we can help you as much as possible. Also, please remember that if you would like to come to Los Angeles and visit us in September, it is a great way to get your questions answered in person by world-renowned experts and also meet other prostate cancer patients who who have been through these experiences and have a wealth of information themselves. Also, you should come and share your experience with the conference attendees and talk to other men about your experience with prostate cancer and help them learn from you. I think that that is such an amazing aspect of the prostate cancer community, and it needs to be talked about even more. You have something to give to them, so you can register at pcri.org/conference. For this next speaker, I'm actually not going to introduce them. Dr. Moyad has had a 30-year relationship with this individual, and he's going to go ahead and do the introduction because this is just a long-standing relationship, and he is just an incredible person, but he is somebody that we are very excited to have here because not only is a physician, but he's also a patient. So without further ado, here is Dr. Mark Moyad.
Hello, everyone. And for the first time, I have my mystery guest. We have a new segment for one of our meetings, our men's health meeting. I call it the mystery guest number one, and the mystery guest will be revealed. I call him Dr. Paul Schellhammer. Notice how I spelled your name correctly, Dr. Paul Schellhammer. And I call part one, Dr. Paul. I call him the world famous urologist fighting his own advanced CRPC, hormone refractory prostate cancer for almost 20 years. And we're going to talk about this in a minute. He has one of the most fascinating stories I've ever heard of in terms of a urologist, in terms of knowledge, and in terms of fighting his own condition, fighting prostate cancer, when he spent his whole career fighting prostate cancer. And our audience has mentioned over and over again how they would love to get the opinion of a urologist. We're not just getting the opinion of a urologist who's been fighting prostate cancer. I'm going to try to keep your introduction short, because there's an old saying, the shorter the introduction, the greater the deference. So for example, when I went to go see Frank Sinatra, they said, ladies and gentlemen, Frank Sinatra. There was no bio. Everybody knew who he was. But when I go to grand rounds and other things where people want to be famous, they make me read 3 pages of bio, which means they're desperate, obviously, for attention, right? So let me just kind of give you my take on why Dr. Schellhammer is arguably one of the most famous and well-known urologists or individuals who fought prostate cancer with patients for my whole career. To make a long story short, I can just give you his bio, which you can see all over the internet. The only mistake he made is his undergraduate. He went to the University of Notre Dame. He clearly, I know, wanted to go to Michigan, but we can talk about that later. Then he went to the University Hospitals of Cleveland, and I thought that was interesting that you were there in 1968. My father was there in 62, 63 under training. You almost bumped into him, actually. And then Memorial Sloan Kettering, you did a fellowship. But he also held all these prestigious moments. He was president of the American Urological Association. Do you remember that? I mean, being president, that must have come with its own interesting stories. He was chairman for, oh my gosh, it seems like forever, the Department of Urology at the Eastern Virginia Medical School. And it's not just his career spanning over decades and decades of treating prostate cancer patients. If I went anywhere in the world and I was teaching, if I was in Japan, South Africa, you name it, and Paul Schellhammer's name came up, everybody knew Dr. Paul Schellhammer and his research. We call him, he was a triple threat. His research, his education in training future doctors and healthcare professionals, and his patient care. He was one of those triple threats as a leader overall. And I think you're also a New York native, which is right. Is that right? So
Bronx.
All right. I ran through the Bronx during the New York Marathon about 4 or 5 months ago. That was a mistake, not the Bronx, my marathon. All right. But here's the thing that people don't understand. He's been one of the biggest patient advocates as a physician, maybe the biggest that I've ever known in my career. The reason Alex didn't introduce him officially is I didn't want anyone at PCRI to know who the mystery guest was, because I wanted this to be organic. And we've been friends, we determined, for about 26, 27 years. About 25 years ago, I did a lecture for him and his students. I went to his house. We had a great time. And I gave this nice lecture. And then during his retirement, I gave a lecture. But we can talk about that during the Q&A. The thing that's amazing is, I don't know if you know this, but I know you do know this, is there's also a Schellhammer Urological Research Foundation. And at the beginning, if you want, you could talk about that. But so he's got his own research foundation that is paying back, that's taking care of all these issues, trying to advance science, people in science, get them excited about finding cures for cancer. And I don't know how many people, unless they've donated $1 billion, I don't know how many people just by deference, because they've accomplished so much in their career, actually have a cancer center named after them. The Paul F. Shellhammer Cancer Center. And you can see that under the Urology of Virginia. He's here. And then I decided, let's just make it 2026. Let me put you into AI and see what it says. And it says, it came out right away. It tell me when you were born, which is interesting. I didn't know. Were you born on April 4th? Is that right? Is April?
No, June 1st.
Isn't that funny? I knew it was June 1st and it said April 4th. That's how much you can trust AI, Dr. Shellhammer. It's right here. It says you were born April 4th and you told me June 1st. Anyway, I'm not trusting AI, but it says internationally and nationally renowned urologist, author, former president of the AUA, bum, 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 everything I just said. And then last but not least, my favorite story about Dr. Paul Shellhammer, the greatest urology advocate for prostate cancer. We were on a group called the Early Expanded Access Committee. We weren't getting enough drugs approved for prostate cancer in early 2000. We asked for a meeting with the head of the FDA. We were granted that meeting along with many patient advocates. You remember the names, Tom Kirk, Tom Farrington, Jan Mannerite. You remember all these names, I'm sure. So we were the two doctors who went in with the patient advocates to meet the head of the FDA and all of his entourage and had a nice long about hour meeting about why we need to speed up more medications and breakthroughs for prostate cancer. And we walked out of that meeting. I think we became optimistic, but also we kind of understood a little bit about the bureaucracy. And after that, things started to change, but we will always share that moment where the two of us went to the FDA with the patient advocacy groups and had a private meeting. And I thought the meeting was a milestone and pretty important moment. So I know that's a long introduction. That's my fault, but that's your introduction, my friend. How did I do?
Well, it reminds me, Mark, of what Mark Twain said about a great introduction he received. And his comment was, when you go to the pearly gates, you are going to be praised for your generosity or scolded for your exaggeration. So there you go. Thanks for the introduction. I'll take the first line.
I think the first one works. So welcome being the first mystery guest. Dr. Shellhammer and I talked about for a year doing this. He doesn't do a whole lot of interviews, tell his story, but we're hoping he's going to change that from now on. Before we go into your story, you're 86 years old now. I knew you when you were younger than my age.
Yes.
That's unbelievable, isn't it?
Yeah.
Just briefly, what are you up to these days? You're still staying in the Norfolk, Virginia area, aren't you? And you still have your hand in all these things.
Yes.
Locally. Is that right?
Yes. So I'm quiet. I do a lot of advocacy now with SURF, and I keep in contact with my old partners, which is always fun to listen to the updates and speaking with you.
Oh, that's very sweet. But you're still active. It's incredible. But here's what makes the story from our standpoint so unusual. So I'm going to give a brief summary and you tell me where I'm wrong or you help fill in the blanks of your incredible story. You get diagnosed. This is your brief summary. You get diagnosed in 2000. You get surgery from a world-renowned surgeon who we both know. And, even though they might have removed 99.9%, there were still some there. So later on, you had to have radiation plus 6 months of ADT, right?
Correct.
Then it's still coming back. Is that correct? You're still dealing with it. So you decide to jump in 2004 and do a clinical trial of a drug that's well known in breast cancer. It's approved for metastatic breast cancer. Tell me why you went from surgery to ADT 6 months, but then you went into a trial at that point. Why did you do that? Why not find another drug, or was there nothing available really?
Well, yeah, in those days there wasn't much available, so there wasn't anything except more ADT. And I was in a clinical trial mindset from the standpoint of a physician, and Johns Hopkins and ECOG were running this trial, which sounded fairly reasonable, exciting in the sense of maybe making progress. And if I could delay ADT, because I'd had 6 months of experience with it, with the radiation, that was going to be a win-win.
How did you deal with that when you first got diagnosed? Because you were treating prostate cancer patients. You were in the heart of urology, and so how does that go about? Did you just have a PSA or a DRE, or we didn't have all these MRIs and this PSMA PET scan, and it wasn't that long ago. So did one of your colleagues diagnose you, and that's where it started, or how did that start?
1990s PSA came into the playing field, and I was in my mid 50s. I had a couple. They were 2.5, 3. I was happy because 4 was the magic upper limit of normal. Then I had a cardiac event, which put the PSAs on the back burner. I got another one when I was 60, and lo and behold, it was 6. I repeated it. It was 6. I was biopsied, and I looked through the microscope, and I didn't see 3, which I'd expected. I saw a field of fairly ugly looking 4. So I was immediately going from the sidelines as a coach to the playing field as a patient.
Wow. But what prompted you to be so diligent about just monitoring and following your PSA? Did you have a family history of cancer or prostate cancer, or not necessarily?
No. I mean, my interesting family history. My father and my 3 uncles all died before they were 60 of cardiac disease. And I'll just say that I've benefited from the interventional cardiologist because I now have 11 cardiac stents as a result of several subsequent cardiac events. So yeah, I'm lucky on 2 ends of the disease spectrum.
Did you have regular stents or drug-eluting stents?
Started out with bare metal way back in 2000, then went to drug-eluting, and most recently actually had a lithotripsy of an in-stent stenosis. Can you believe that?
No.
I mean, yes.
The same device they use for stone?
Yeah, lithotripter on a 7 French catheter, and it fragmented the calcium, and the balloon expanded the stent and permitted insertion of another. So progress is remarkable.
It's incredible. So I didn't realize you had all these stents. I remember the cardiac history, and that's incredible. But the drug-eluting stent you had, was that Taxol? It must have been a chemo drug.
It was Taxol.
It was Taxol, the chemo drug, right?
Yes.
Now they're switching. If the audience is wondering where is he going with this, I'll tell you exactly where I'm going with this. This is what makes it fun to not really tell the people I'm interviewing all my specific questions or where my brain's going. I just had to interview someone, an expert on all the BPH treatments. And one of the BPH treatments they're looking at, which they already, that's already got approval in the area of BPH, and strictures also, is Optilume. And I have no involvement with these companies, but Optilume uses a balloon, which basically, and then they push it out, they open up the canal, the urethra, but they also use Taxol there. So you got Taxol being used as cardiac stents. You got Taxol, Taxotere being used in prostate cancer. Taxotere is a chemo. And now you got Taxol being used as a possible BPH treatment within Optilume and who knows where else. It's incredible how everything's talking to each other now, right?
Yeah, and the reconstructive surgeons with strictures have been using chemotherapy to prevent the proliferation and restricture. So it comes around.
It does come around. Okay, so you're going through that. You think you're doing, how was that run on radiation and ADT? Because sometimes there's a saying that surgery, you have the side effects up front. You pay up front. You know what you're going to get right up front. And some people say with radiation and ADT, you pay a little bit later. So how did you just go through that experience of having surgery and radiation ADT? How was your quality of life going through all of that, those first few years?
Well, yeah, radiation in the year 2001 compared to now was relatively primitive. I got a box of radiation around the presumed area of the anastomosis, AP and lateral. There was no conformal IMRT computer gauged direction. I had some side effects from the proctitis from the radiation, and the ADT was, as most patients described, just a life-altering, slowing, impeding process, which is why going back on it was not particularly looked forward to, and a clinical trial for the lapatinib certainly was a reasonable next step.
So when you went on this clinical trial, how long did you go on it? And it never got approved. So did they just tell you this is not working, or
Yeah, it
what
was PSA.
going with that?
It was PSA monitored. I went up to Hopkins on a monthly basis for about 4 months, and the PSA kept going up, and I guess the same with other patients as well, and it shut down.
So that doesn't work, and then you just keep playing it out. Now you're just going to go on ADT and see how long
Yes.
you can go. You know, we
Yes.
heard stories that some people go 6 months, some people go 26 years, and remember all those stories we used to hear in 2000. So you draw out the ADT here. You're still hormone sensitive, aka hormone naive, but then whammo, in 2008, and I don't like this term, but that's just me. Everybody knows the term now. You become castrate resistant, also used to be known as hormone refractory, also used to be known as androgen independent, blah, blah, blah. But and let me just preface, I'm sorry to do this for you. We never talked about this, but in 2008, if you were told you have hormone insensitive, hormone refractory prostate cancer, there was always a timeline there, in my opinion. In other words, that was a sentence where you said, oh my goodness, this is a problem, correct?
Yeah, that brought sweat to your brow.
Wow. And were you surprised when they told you had this?
No, because I mean, that is the course. I was following the course of events of so many. It was a replay of what I'd seen numerous times with patients. And by the way, now it's called androgen pathway modifier, right? APM.
Yeah.
And I was APM-S sensitive at the time.
Okay. And
but we didn't have the modifiers. We didn't have the ARs. So
you stop responding to the LHRH, but they want to have you stay on it like they do today.
Sure.
Because the idea is there's still it's a heterogeneous mix, so you might still have some hormone sensitive cells.
Yes.
So we're going to keep you basically into male menopause in 2008. But sorry to be so candid, but I've known you for a long time. Is there any way in HE double toothpicks? I want you to be honest. I've never asked you. Is there any way in 2008 they told you you were CRPC, hormone refractory, whatever you want to call it, that you thought you'd be coming into 2028, almost 20 years later, and you'd be alive?
Absolutely not. Absolutely not.
Were you thinking,
I mean, I bought a lot of life insurance. Yeah.
I mean, really? I mean, were you thinking year, 3 years, 5 at that?
Five, hoping for 5 and
then. Pardon?
Maybe hoping for 5 to 10.
So were you still working? Did you want to just retire at that point?
No, I was still working. In fact, that's the year I was president of the AUA.
It was 2008?
Yeah.
Well, that's because I didn't know you had CRPC in 2008.
No, I didn't tell people.
You didn't tell anyone?
No.
Yeah, because then probably people like me would have said, why don't you go have a good time? Go cruise around, go on the boats, go drink more wine or something. It's unbelievable because I know all the books that I did during this time, and I know what we have to say about CRPC. We wanted to be optimistic. We weren't getting drug approvals around then. But this is also around the time where we went to go see the head of the FDA saying we need more drug approvals.
Mm-hmm.
But
yes.
you didn't say in that meeting that you were dealing with this.
Well, I don't know why I didn't. Maybe I should have.
Or maybe not, because I think they looked at you as this world-renowned urologist going, wow, if he feels passionate about it, we probably need to listen.
Yeah.
Okay, so that is an incredible story. 2008, though, when you got CRPC, everything changes. Do you call it the Shellhammer menu? You started to do everything under the sun. So let me give, from my conversations, this is what I caught when we were walking through it. you did clinical, you walk me through each one of these and how you felt about them, but you did a clinical trial, you did Provenge, you did bipolar androgen therapy, BAT, you did estrogen, you started in 2013, which you have basically continued on, which is part 2 of our talk, spot radiation, et cetera, et cetera. Tell me which ones I've missed and walk me through just which ones you did in your experience with those. So you did this, let me start you off if you don't mind. You did this enzalutamide plus abiraterone combination, getting both at the same time, which they don't do anymore. They just give you one or the other.
Right.
You did this phase 3 trial called Alliance. What was that like?
Well, let me say that in 2008,
yeah,
faced with no other option but docetaxel, which I did not want to proceed to, I did at that time learn about transdermal estradiol in 2008 and started that at that time. In 2013, the change was I became metastatic, and it generated another potential for other therapies. And I've said to you, I'm very fortunate to have chosen urology as a field and to have urology as my companion through all of this, because obviously I could keep a pace of what was happening and apply it personally.
So tell me sequentially then from 2008 to as we work our way to now, before you did Pluvicto, take me through some of these drugs that you took and just kind of your brief experiences, the pros and cons of it. Can you do that?
Yeah. Yeah, sure. So 2008 to 2013, transdermal estradiol. 2013, metastatic, this new trial, Abby plus Enza at MD Anderson. I had to stop my transdermal estradiol and resume an LHRH analog to get on the trial, which I did. Went down there monthly. PSA continued to climb, much to the dismay of me and the investigator. At 6 months, the trial was deemed futile. It stopped. I was disappointed, as every clinical trial patient is, when they hear that what they're embarking on didn't work. But I was happy to get back on my transdermal estradiol. I had radiation to the T12 metastatic vertebrae, followed by Provenge, Sepulus LT, which kept things under pretty good control for 3 or 4 years.
How was your experience with Provenge? Did you
Provenge
toxicity, or did you kind of walk through it?
No, it's interesting. I had just on abiraterone, I had required the lisinopril because of the hypertension that was being generated by the abiraterone, and I stayed on it. And when I went to my Provenge leukapheresis, my blood pressure tanked, and everybody said, well, maybe we can't do this for you. What drugs are you on? So I listened, the lisinopril, stop that, please. I did, went back 3 or 4 weeks later and was okay. So it's interesting how one issue morphs into another. So
it is interesting. And
the Provenge was easy. The Provenge was easy.
Still a popular drug. It's an ACE inhibitor. It's a very common blood pressure drug. But, it kind of lost a little bit of favor because the ACE inhibitors can cause a cough. I don't know if you had a cough.
No, I didn't know.
Okay. So that's good, but it's a great drug. So now they have ARBs but that's a great blood pressure drug. Okay, so you get Provenge, but here's some other things. Oh, by the way, before we talk about the other things you did, this combination of enzalutamide and abiraterone, I mean, these are common drugs used today. They're used earlier and earlier. They were used for CRPC. So they did this trial and they published in 2013, and here's what they said. Morris et al. Said this. I found this. I thought you'd find this interesting. This is some of the final results of the trial that you were in. It basically says, okay, overall survival was not statistically significant between the combination arm and the single arm. Were you on the combination, did you ever find out, or the single arm when you started?
I was on the combination.
Okay, so you were on the combination arm. Do you know what they reported? I mean, this is incredible. I don't know. I think you should hear this. What they reported in the study was overall survival was not different between the two arms, and the median overall survival in that trial. And what year did you say that you were in that trial? Do you remember what year?
Yeah, 2013.
2013. Right. So that's when you had the Mets, right?
Yeah.
Okay. Okay, that's 2013, ladies and gentlemen. So this is a classic example of don't let statistics sometimes rule the day or the anxiety or the optimism. The overall survival drumbeat in your trial that you were in from that point was 32 months.
I didn't read the paper, thankfully.
Thankfully, but you know the 95% confidence interval was? It was 30 to 35 months. It was tight. Meaning that you have to be one of a small percentage of individuals that went in this trial and is still alive and thriving today. I mean, that when I read that and I thought about what you had been through 13 years ago, and the survival was less than 3 years, the median survival, and the confidence interval was between 30 and 35 months. I was like, Dr. Shellhammer is sort of a walking miracle, but more on that in a moment. Anyway, what they found, which you might think interesting, is they found that when they combined the two drugs, what happened was there was a drug-drug interaction that resulted in increased turnover of abiraterone.
Yeah.
So in other words, right? So the problem was the drug-drug interaction, although it made abiraterone reduce their amount because it was a faster hepatic clearance, because of all the toxicity in this trial, they didn't recommend trying to increase the dosage or move further. So it's not that they weren't seeing anything, it's just the toxicity was too much.
Prompted by the enzalutamide, CYP, whatever, driving breakdown of abiraterone.
I got to take a minute to just bring that in. I mean, it's just incredible you were in that trial. All right, so we talked about that trial. We talked about your experience at Provenge. We talked about how you favoring transdermal estrogen. You did some spot radiation. And one thing we haven't talked about is you also did a trial called BAT, right?
Yes.
Can you tell us about this bipolar androgen therapy? Because people can still read about it. You tried this.
Well, here's the issue. It sounded very interesting. Specifically that it could resensitize the cancer to one of the amides, one of the ARIs, enzalutamide, darolutamide, apalutamide. So I went to see Dr. Densmead at Johns Hopkins. You had to have metastatic disease that was image visible. And I had an Axumin scan, which is a thing of the past, Axumin scans, which showed a lymph node in the pelvis that was not very easily accessible for biopsy. And one of the criteria for the trial was to get tissue and then go on the trial. And they said, Paul, getting tissue is too difficult. But why don't you you're not on the trial, but here's what the trial does. So I went home and followed the testosterone injections and for approximately 6 weeks. And then it was more like 2 months, then tried to see if I could resensitize at that time to darolutamide. Did not. My PSA it's not much. I mean, with all my testosterone levels were in the 5, 6, 7, 800 range, and my PSA went up 1 or 2 notches from 5 to 7 to 8. But it continued to march up even with the darolutamide addition. So withdrew and went back to my transdermal estradiol, old faithful ADT.
Yeah. So you do all of this. Is there anything in the Dr. Shellhammer menu of options that I brought up is there anything else that you tried during this run from 2013, for example, when you had metastatic disease all the way till the past few years ago? Is there anything else I missed before we get to when your PSA jumps?
No, that covers it.
What's the highest your PSA got during that period of time? Before we talk about Pluvicto, what was your highest PSA during all these trials and tribulations?
Well, 160.
It was. Okay. And then during all these other trials and tribulations before you do Pluvicto, are there any of these drug treatments or did you ever get to a point going, this is stupid. I'm just doing way too much. I'm a complete guinea pig. I'm going to just take a break for a long time and just, I mean, in other words, was there ever a quality of life moment where you said, I don't want to be a patient anymore. I'm just going to take a break from all of this? Or is
No, actually not, because I wasn't feeling particularly bad. I mean, my energy was decent. My get up and go was good. I wasn't suffering other than knowing that you got this marching enemy inside you. But I didn't see any particular benefit from, well, say, sitting back and doing less. But recognize between 2020 or 19, when I stopped the bat, till 2025 or late 24, my PSA was marching up. 1 year doubling time. Started out at 10, 20, 40, 80, 160. So over those 5 years, it went from 10 to 160. I had a few PSMA PETs that showed I had bone metastases. Well, I knew I had bone metastases. They were not symptomatic, and I had some lymph node metastases as well.
Some people, when they're going through this and the trials and tribulations of it, they just go try something just really out of bounds. It could be something over the counter. It could be a repurpose. I'm just curious that while you were going through this, before we get to the last treatment, did you just try something that, I don't know, you found somewhere in the world out of bounds, some pill, or did you just kind of stick?
No more than vitamin D.
Vitamin D, as you said?
Vitamin D, yeah.
Okay. So we'll cut to the chase. And for those of you who are saying, I want to hear more of Dr. Paul's story, where he's going to put his case study on the website. We're going to do that in the next few weeks after the conference, so you can follow his case study and what he did and where he is now. So he's generously, I mean, I didn't even have to twist his arm. I didn't have to offer him a beer. He just volunteered to do that, because it's a lot better than me interviewing him. It doesn't give it justice what this man has gone through. So now let me set this up for you. You have liver, lymph node, and bone metastases, right?
Correct.
This is in the past couple of years. This comes up, and now you need to know that you need to do something probably different. So tell me about that and the decision to go to Pluvicto from that moment, correct?
Correct.
So
well,
give me that story.
The scan in the beginning of 2025, which was an annual scan, really shook my tree when I saw the liver metastases, 2 centimeter, several, and along with the bone and lymph node that had been there before. And that said, Pluvicto must be in my horizon. But as you know, at that time, you had to fail, or most of the time you had to have at least tried docetaxel. But interestingly, I'm a veteran, Vietnam veteran, and the VA, because of Agent Orange exposure, did not require a previous go round with docetaxel. They allowed you to go straight away to Pluvicto, and I took that opportunity. I had it delivered at my local cancer center, provided by the agent provided by the VA. And so I started that in February of 2025. Now I did have, because that lymph node in the pelvis was getting pretty sizable as well, up to 3.5 centimeters, I did have spot radiation to that prior to the Pluvicto.
Yeah.
4 doses of IMRT.
It's interesting. You were always a fan here of spot radiation before it became the du jour. Now people are getting spot radiation all the time for oligometastatic prostate cancer, right? So
if you can see it, radiate it.
Amazing. So then you go into Pluvicto, and then that was every 6 weeks, right? So
yes.
How many treatments of Pluvicto do you get? And then what happens from your PSA, which is 160? What happens?
Well, after the first infusion, out of curiosity, again generated by my own lab request, I got a PSA, and it was 17. I said, that's got to be a mistake. I'm going to get another one. So I went back and got another PSA 5 days later, and it was 12. So it wasn't a mistake. And then I went back and got my second course of Pluvicto, and the PSA went down to 2. And I said to the radiation oncologist, boy, he said, you're a poster boy. I said, yeah, I mean, I'm in the approaching 99% response rate PSA wise. Where do we go from this? Well, let's do another dose. So I did, and it was down to 1. And I asked around, and I said, am I just treating my kidneys and my salivary glands and my lacrimal gland? Because the cancer seems to be going away, PSA monitoring. And so I stopped at 3, got another PSMA PET, and lo and behold, other than scattered bone, the liver had disappeared, the lymph nodes had disappeared. And my PSA continued to go down over 6 months to a nadir of 0.7.
And then so you thought 3 is enough, so you stopped at 3, and now it went down to 0.7.
Yes.
Was there any when you do a PSMA scan, if you light up, theoretically, you should potentially, we were taught, you were supposed to get a better response to a PSMA targeting agent like Pluvicto. So did you light up like a tree, like a Christmas tree? Yeah,
the SUVs were high, 30, 40, 50.
So, okay, so these measurements, these PSMA measurements of intensity, these things they call standard uptake values, the SUVs, they were super high. So it kind of gave you an idea that you might have a good response.
Yes. It would suck up to lutetium.
So this is how you played it from 2008 with CRPC all the way to 2026. You just kept getting in the ring, doing everything from clinical trials to what's coming out, to newly approved things, to other clinical trials, maybe approved things. You keep batting that PSA down, keeping the things at bay. You go back in the ring, and then the final time you've gone in the ring here lately, you do Pluvicto down to 0.7. So where are you right now?
Well, the PSA stayed low for 6 months. And then in February of this year, it started to rise. And it has now risen most recently to 9. So another PSMA PET thankfully showed no liver recurrence, but did show new bone metastases, new areas of bone involvement in the skull, the zygomatic arch, and some other assorted areas in the pelvis, but no lymph node recurrence. So I have now these scattered areas of bony metastases, and I'm debating and cogitating and getting information as to, do I hold? Do I fold? Do I get the next 3 Pluvictos? Do I have radiation to 2 of the metastases that are in the skull? And so far there's been mixed advice. And right now I'm just kind of pedaling in my canoe.
So that's why I decided to make where does Dr. Paul Schellhammer go from here? Because you've kept this thing at bay for almost, I say this and it's just incredibly amazing. Where do you go from here? I made you a list. And I know you don't have to check off any of these boxes. I'm just wondering, I never heard that you went on chemotherapy. You talked about clinical trials. I'm just going to take the audience through this, and then you can take me through anything that you want to. A lot of people do liquid biopsies now. Some people are looking to see if they qualify for further types of immunotherapy. There are clinical trials called personalized vaccines. They get a piece of tumor, they create their own personalized vaccine, right? Metastasis-directed therapy, oligometastatic prostate cancer, keep zapping those spots. You know about these PARP inhibitors. Get a genetic test on your tumor, or maybe the genetics you were born with, see if you qualify. Pluvicto, then there's actinium for some people who failed Pluvicto that's being tested, maybe the next drug approved in the United States, who knows? Then there's repurposed other cancer medications. That was the story, like going back to Tykerb. And then the list goes on. So are you, I know you, are you looking at this huge menu trying to decide what's next in the Dr. Paul Shellhammer realm? And are you favoring anything here, or are you just going to wait till you talk to all of your experts?
Well, I'm going to talk to all of the experts, but my disposition at age 86, having run the gauntlet as successfully as I have, fortunately, is quality of life and not the embarking on AE, adverse event profiles, that would knock me down. And I'll throw this in, any one of those trials would require me discontinuing my sidekick of transdermal estrogen and going back on a LHRH analog, because that's the way the clinical trials are constructed.
Yeah.
And that at this age and at this point is just not in my game plan.
Okay. So we're going to cover that in part 2, which is a little shorter. I know, I'm sorry, I've gone way over in part 1, but I talk to you all the time. But when I kind of see you on video talking about this story, it's still sort of unbelievable who I'm talking to. So I had to ask this question, because everybody else is thinking the same thing right now who's watching this. How do you explain surviving and thriving with advanced CRPC prostate cancer for almost 20 years? Do you attribute it to luck? Do you attribute it to your lifestyle? Did you take something magical over the counter? I know you said you took vitamin D. I don't necessarily attribute it to that, but medications, opinions, your partner, Moyad friendship, I'm sure, is a big one in all of this, probably the biggest factor. But in all seriousness, when you are up at night, you've had to have thought about this. Like, what is the sine qua non? What happened here? What's the element that you think made the difference?
Well, I think I may have mentioned to you, when I see my good friend, urologic oncologist at Urology of Virginia, who is my physician, he says, Paul, I don't understand it, but the only thing difference that distinguishes you from all the other patients that I've cared for is that you're on this patch, this transdermal estradiol patch. So I think there's luck. Okay. I think you can't discount that, some genetic predisposition. But if you had to sort out a difference, that's one of the differences.
So that's partly advice. If you have to give advice to patients, doctors, healthcare professionals, is it the follow the Dr. Paul Shellhammer way? Keep kicking, keep doing clinical trials, keep trying all these things off label. You know that people come up to you and they're looking for that nugget. Is that the advice you give them, that, you know what, you're just still keeping an open mind to all these other things? I mean, I'm still fascinated by the fact.
It depends. You know what William Osler said, it's as important to know about the patient that has the disease than about the disease the patient has. And so everybody's different with regard to their approach. I mean, some folks are battle ready, full bore. Let's try everything and anything because cancer is my enemy and I can't sleep until it's defeated. Then there's a group you know well who say, I can live in symbiosis with this. I want to live more importantly than I want to lengthen the life. And so there's a balance between those extremes as well. So it's not one size fits all, but I'll say in general, it's be tuned into what's going on, be attentive to clinical trials, and try to get the best quality that you can of what you have and what's remaining.
They say prostate cancer is a couple's disease condition based on the research. I wrote that in my first book with one of my friends that you know about from 1997. And I was talking about, more than ever before, we have all this research. I don't know if you have any comment about that, because what the families go through and the couples go through together, it's pretty daunting, and I don't know what your experience was. I know you've had some healthy relationships. Do you have any comment on that quotation, which I think should be used more often?
Yeah, yeah. I mean, when a male is faced with this diminishing capacity, not only energy wise, cognitively, sexually, he withdraws. I mean, he becomes less conversational and less interactive, and that has to affect his relationship with his partner. And so the whole story about doing men or individuals, couples with one has a cancer, having a good relationship, extends survival just in that sphere of association. Obviously, trying to heal that diminution of interaction is incredibly important. And unfortunately, often, I won't say ignored and I won't say dismissed, but not addressed. And I will say that a wife's disposition and interaction to her husband's disease is almost as dramatic, or I should say the treatment of the disease is almost dramatic as the disease itself. So you have two strikes with regard to ADT, the disease that it's fighting, and the mechanism by which you're using to fight it. Both are significantly impactful on individual and couple dyadic life.
I haven't met many urologists that were in Vietnam, right? So you were in Vietnam. Do you want to give a brief overview? What was that like?
Just from the standpoint of separation, I had a 1-year-old son, and so that separation situation was significant. I was a class D as an ABCD surgeon, which put me in a casualty staging unit for the Air Force, which basically said we triaged on a daily basis hundreds of injured to get on flights to either the Philippines or to Japan or to Germany, depending upon the acuity of the situation. So it was a very active emergency room kind of experience, and one that, like all I see combat experiences, makes you wonder why the war cry is so loud and vehement, because it sure is destructive.
So was it akin or similar to a MASH unit? Like I saw.
No, we were one step behind MASH. MASH got people, stopped the bleeding, got things right. We stabilized with blood, sometimes with added surgery, but mainly it was a 24 to 48, 72-hour stabilization so they could get on the plane safely. And often we accompanied that plane to the various hospital destinations.
So MASH, Mobile Army Surgical Hospital, I know it from TV, of course. I never got drafted, but I didn't. How long did you serve?
I was in for 2 years, 1 year in Vietnam, which is the usual physician story.
Wow. So,
and everybody was drafted in my era. I mean, it was a no-brainer. You were going to be drafted. It just was a matter of what service you would enter and where you would be assigned, and would you pull the unlucky straw to cross the pond.
You know how many times in my career I bumped into someone and said, I don't just thank you, I wholeheartedly appreciate you for your service, but I never, ever in talking to you knew I was going to be telling you that. I had no idea that you served. I don't know why it didn't come up. Maybe I remember you and I went to a bar before my lecture because I came in late and I was starving. I know you remember that story.
Yeah.
And we didn't belong in this bar. We were sort of, how can I put it? People were a lot larger than us. And
yes.
They looked like they might hurt us.
And they had been drinking longer than we.
And we look. And we look like we just came from the laboratory of
Yes,
some institute.
we
And
were the wimps. We were the
yeah, this was
wimps.
a place where arm wrestling was a hobby, and we got out of there. So that's an amazing story. Really, thank you. I didn't know you served in Vietnam. Thank you. That's amazing. You also have to know another story about Dr. Shellhammer. I said that he's a big patient advocate. He's a big patient advocate for a lot of things. More drug approvals, getting more research done. He's a part of that with his foundation, Cancer Center. But also, I thought we would call this part 2 with the mystery guest. Now we know who the mystery is. Transdermal estrogen estradiol patch for prostate cancer. Is it making a comeback? Here's the reference. And the reason we're having this interview now is the timing is quite extraordinary. So let me just give people some background. Dr. Shellhammer, throughout the entire journey we talked to in part 1, kept going back twice. He went back on transdermal estradiol because he thought it was better in terms of his quality of life for him. But he was also an advocate of it, saying, why isn't more of this available to patients? So you can look up, for example, in the British Journal of Urology International on PubMed 2017, he wrote an editorial which I highlighted. And he said, estrogen redo, will transdermal delivery rebalance the risk-benefit equation? And I won't say what he said. He's going to talk about it here, but he basically talked about the pros and cons of why we need to give more attention to transdermal estradiol as a potential treatment, a treatment for side effects, and why it worked for him. And so you'll see a lot that he's passionate about. But something quite extraordinary happened when we were trying to set up this interview. He's been talking for years about the benefits of it. And lo and behold, this big trial came out just recently in the New England Journal of Medicine. And transdermal estradiol patches in locally advanced prostate cancer, the patch investigators, Stampede investigators, and you can look at the summary, and you also wrote a summary of it. But the bottom line is, you're living it, so I don't even want to try to summarize it, but we can go back and forth on it. This was an extremely positive study. Can you just tell us a little bit about this study that came out in the past few months? And were you surprised? It basically said that transdermal estradiol as a form of androgen deprivation should be an option. But do you want to tell us about this trial and your experience and anything else surrounding this?
Yeah, yes, because that trial had been conceived at the time that I became aware of transdermal estradiol from papers from the UK that demonstrated that it could achieve a castrate level of T without the cardiovascular issues that had plagued the oral estrogen DES, so the Veterans Association Research Urology Group trials. And the transdermal delivery was the key because it bypassed the enterohepatic circulation. The GI ingestion exposed the liver to the high doses of estrogen, which prompted these thrombotic proteins that resulted in pulmonary embolism, cardiovascular events, and overwhelmed the cancer survival benefit of estrogen, which was indeed the case, but just overwhelmed them with cardiovascular morbidity and mortality. So we had a new way of delivery, and thankfully the UK investigators took it upon themselves to begin this very laborious trial that was initiated in 2007 to accumulate about 1,500 patients in the best of clinical trial procedure, randomized, level 1, comparing an LHRH analog, an agonist in this case, with transdermal estradiol and showing the cancer control was equivalent, the PSA effect was equivalent, the T lowering effect was equivalent, and there were a host of quality of life benefits that accompanied the transdermal estrogen delivery.
That's what was really sort of stunning here. It's like you were an advocate all along. You were doing this most of your journey. And lo and behold, this is a phase 3 trial. And people always tell me that phase 3 trials means when they're positive or they show the pros exceed the cons, then it's supposed to make things more available. It was in 75 United Kingdom medical centers, which is quite striking overall. And here they say in their conclusions, among patients with locally advanced prostate cancer, transdermal estradiol was non-inferior to LHRH agonists for 3-year metastasis-free survival with a lower incidence of hot flashes. But they also point out, and we can go through this, the one caveat they throw out is the higher incidence of breast enlargement. So before we comment on the pros, a little bit more about the pros and cons, what you were talking about was when you were a young man, there was incredible excitement about men taking estrogen and estrogen pills, right? And then they did the trial, and the trial looked good, but taking it as a pill caused these blood clots and cardiovascular events. So we dropped that and started going to other medications. Okay, great. But now we hadn't tested a different route where we bypass that liver metabolism that increases the risk of clots. They did that. You've done that. And now, so let's talk about the cons first. People will say to you, okay, this worked for Dr. Shellhammer. Now this worked in a clinical trial, but wait a second. Breast enlargement, that's the last thing I want. So what do you say to people that say, well, that's the catch and that's too big of a catch, breast enlargement?
Well, if you present the breast enlargement to the patient, Mr. Jones, this is a feminizing female hormone that will cause breast enlargement, and that's the last thing that you want. The conversation will stop because the red-blooded American, European male will say, no mas, not for me. I will say that in the shared decision-making world that we want to embark upon, that it has to be put in perspective. And the perspective is this is a cosmetic issue that can be, on one hand, minimized and the other hand, dealt with if indeed the degree of gynecomastia is bothersome. And what is the degree of gynecomastia? Hard to know because it hasn't been quantitatively assessed and measured in this trial or elsewhere. It just says gynecomastia. What does that mean? Well, we looked just briefly in a paper that we submitted for publication how trans women respond to high doses of estrogen for the purposes specifically of feminizing and developing large breasts. And it was relatively disappointing from their standpoint because 85% had A cup or less. Now there were 10% with B and 5% with C. So you have 15% where the gynecomastia could be significant. Now you're dealing with different levels of men. I mean, there's a 70-year-old who could care less. There's a 55-year-old who could care tremendously about his physique and how he looks. So I was a young guy. How did I address it? First, I had 1 dose of prophylactic radiation.
Yeah.
That diminished the enlargement. That didn't, I had no problem going to the beach. I did have a lot of mastalgia or gynodynia. That was bothersome. And I happened to live next door to a plastic surgeon who dealt with this issue with women with regard to breast surgery and radiation. He said, Paul, I can solve that problem with a quick minor procedure, which I had, a neurectomy of the anterior branch of T4. I'm not advocating that, but I'm saying that I am entirely whole with regard to breast size and breast discomfort, and it's cosmetic, balanced against metabolic, glucose, lipid, bone health, and general sense of well-being. I think the scales, if the conversation is held in a prudent and balanced manner, the scales are quite tipped in favor of the long-term benefits versus this cosmetic issue that probably won't happen and can be addressed if it does become problematic.
And we will, let's go through that checklist. But in the UK, Australia, other places that were still giving estrogen, they would give like one dose, one shot of radiation before you would start it, and that helped prevent the enlargement. Some people just worked with a plastic surgeon, got cosmetic surgery, and were perfectly happy. Other places in the world I've seen, they give tamoxifen or aromatase inhibitor. They give something to reduce the side effect. Okay, so we covered the con, right?
But I have to say, tamoxifen is not good.
Yeah, so tamoxifen.
Why isn't it good?
It
decreases the sensitivity of the receptors in the pituitary to the high dose of estrogen you're giving to signal the pituitary to decrease the LH hormone to stop testosterone production. So you're kind of short-circuiting the pituitary hypothalamic axis. So tamoxifen is, as it says in the paper, contraindicated in this situation for treatment or prevention of gynecomastia. It's an important point because
that's a really important point.
Yeah.
And then what about the other ones that now tamoxifen is not used as much in breast cancer? They use aromatase inhibitors, a variety of them. So I would just wonder if they just still stick with the cosmetics and the breast radiation one time, and they just stay away from these drugs.
Yes. Those others have their own set of side effects, expenses.
Yeah.
There's some thromboembolic issues associated with them. I mean, so it's just adding to the polypharmacy to aging male of adverse events and cost that really don't need to be part of the equation.
Yeah, so radiation and cosmetic, just in the cosmetic procedure was a very short procedure for that I know.
Yeah. That went in at 9, was home at noon, you know?
Yeah. Okay, so I always like to start with the cons because it's transparent, but let's talk about the PAT study and let me get your opinion and your experience. You know the papers and you know the PAT study. So in terms of efficacy against androgen deprivation, LHRH, the efficacy was similar, right?
Mm-hmm.
The paper.
Mm-hmm.
Let's talk about bone health. Which one was superior in terms of bone health?
Estrogen by far. And bone health is a really sneaky issue because the problem doesn't happen immediately or in 6 months or 12 months, but 2, 3, 4 years down the line, the incidence of fracture increases. So estrogen not only prevents the deterioration of bone secondary to the LHRH, it builds bone. So it's not only a suppressive of an adverse event, it is a bonus in addressing what every elderly male encounters, which is some degree of osteopenia and osteoporosis. And so my DEXA scan is a +10 at 86. I have better bone density than the standard 40-year-old man with regard to bone health. Why? I've been on estrogen.
And now you sent me this paper to show you how much of an advocate he is. I don't know where you get energy. I think you do some of those caffeine drinks or something. You haven't told me this. I don't know, maybe you do the Red Bulls and stuff. I don't do those, but you sent me this paper from the Journal of the National Cancer Institute, just published March 7th. It was a look at the risk of fractures following androgen receptor pathway inhibitors in men. So now you're looking at these new pills being added on top of LHRH. And what they're saying in the conclusion, this is one of the longest looks, over 10,000 patients. Fracture risk after androgen receptor pathway inhibitor was high, exceeding 44% within 3 years in those with prior fractures, despite being on bone health agents, all right, suggesting limited benefits in patients with poor bone quality. So what they're saying is we need to do a better job in terms of bone health. Here was the conclusion of the paper. I don't see many journals get away with this kind of alarmist language because you and I have done a ton of peer review. We work for journals in reviewing what gets published. I wouldn't allow necessarily these words through, but I understand why they said this. The fracture risk following some of these new pathway inhibitors is high, especially among those, notably despite bone health agent use. Fracture risk remained alarmingly they use this word. Alarmingly elevated, highlighting the urgent need for early identification of high-risk patients and more bone protective interventions. So bone health is becoming that much bigger of an issue since you've gone on this campaign of we need to look at options for bone health.
Yeah, I mean, the wonderful advances in the treatment of advanced prostate cancer are such that now doublet therapy, one of the MRIs, along with one of the LHRH analogs, is standard of care. So you have the issue of lengthening life,
yes,
but at the same time impacting to a greater degree the quality of life over a longer period of time. So, I mean, Mark, you've seen it over the past 2 or 3 years, appropriately so. There's been a much greater emphasis, whether it be educational sessions, papers, podcasts, on addressing the AE, the adverse events of doublet therapy. And so we have here, a dilemma, longer life, but questionably better life. And the challenge is, how can we address the better side of the equation?
So that's the bone health that it makes your argument incredibly compelling. People are saying, well, what do you think about this? It doesn't matter what I think. This is why I brought Dr. Shellhammer. He's been on this medication for so long, and he's been watching the data, and all this new data is coming out. No one's saying they shouldn't take their anti-androgen, second generation anti-androgen pill. We're just saying this comes with a whole line of new toxicity that we have to, if you're going to embrace these drugs, you have to embrace the toxicity in terms of management, prevention, and making sure people never suffer if they don't have to suffer from that toxicity. Just to end on bone health, because it's such a compelling argument for estradiol, you're going to laugh at one of the signs I've shown in a lot of medical meetings. People always ask me, they're like, hey, you know all these categories. Are we all suffering from a calcium and or vitamin D deficiency? And you know what sign I always held up? I said, yeah, there's only one type of D deficiency we're suffering from. It's a DEXA deficiency. We're not taking bone health seriously enough. So that's the sign. I wanted to show you the sign. I show at all the meetings. In the last big study they did in the SEER medical database, people on androgen deprivation, only 8% of them received a DEXA scan. 8% that qualified. I mean, so to say bone health is an epidemic, bone loss is a crisis in prostate cancer is the understatement of the year. I don't know if there's anything more to say about it, but that makes for a compelling argument.
Yeah, and it's down the road, 3, 4, 5, 8 years down the road. You almost disconnect the outcome from the originating cause because of the time lapse in between.
Yeah, and what the PAT studies showed and other studies is that people tend to associate fractures with, oh, I fell down the stairs, or I tripped and I broke my hip. People have to be able to grasp what doctors are seeing a lot of with these medications is pathologic fractures too. They're seeing a fact that you might not even know it, but you have a little back sore, or maybe you have a bad back. Then you go get an x-ray, or you get another type of imaging scan, and lo and behold, they see a fracture there. They see a big fracture, right? And it could be due to the disease process itself. It could be due to the drug treatment. So it's quite extraordinary. Now that brings me, I'm doing this alphabetically, so there's no favoritism.
Okay.
We talked about efficacy is similar. We talked about the benefits of estradiol for bone health. Again, it's the patch we're talking about, not the pill. But what about going back to the scare we had with the pill of estrogen pills, the cardiovascular toxicity? What are you seeing in terms of this trial and other trials in terms of the cardiovascular toxicity of estradiol versus ADT?
So in this trial, there was no increase in cardiovascular toxicity. There was a benefit with regard to lower cholesterol, better glucose control, metabolic changes that you would say would portend to a better cardiovascular future and better cardiovascular health going forward. In the trial itself, this was not evident, but as it mentioned, further follow-up is certainly in the works to determine, here again, it's long-term stuff, is estrogen going to be protective? And I sent you that article about the drugs of all the hundreds or thousands that were investigated that might prolong life just in of themselves. And there were a couple of them, and estrogen was also on the list. So it's kind of women live longer than men. There are a whole bunch of issues with regard to estrogen that might be life lengthening as well as bone and health and quality protective.
So efficacy in this trial, no different. Bone health is better. Cardiovascular was neutral. Cognitive and ED, they seem to suggest ED was similar, but we want to talk about cognitive for a second because there's been a lot of research going back to 2010. We talked about the Thomas Beer study that found a potential benefit in men of doing estradiol in terms of memory or cognition. Have you been following that?
Yes, but to my knowledge base, and not in this patch trial, the appropriate instruments have not been diligently applied over long term. So it's still somewhat of a assumption based on subjective reporting. Subjective reporting would state that if you sleep better because you don't have hot flashes, you think better, and your cognitive awareness is improved.
There's a lot of people that believe that when you're on ADT, the reason there's cognitive issues is they're getting too deep in the weeds, that the actual explanation is the insomnia, the sleep interruption. And then that makes, right? And so there's a researcher doing work in Canada on that who believes in that and has done work and is showing that they have found that the sleep deprivation has been the issue.
Well, he happens to be a close friend and has been on transdermal estradiol for 20 years and has done rat studies that show that REM castrated rats, so they didn't have any estrogen because we know that all estrogen in men, or 90% of it comes from aromatization of testosterone. Some little bit comes from the adrenal gland. And so these castrated rats, when monitored by brain electrodes, their REM sleep was poor compared to the normal rat. So, rats aren't men, but you have to make some leaps of faith with regard to evidence. But just speaking with men on androgen deprivation therapy, there is almost universal statement that my mind is cloudy, I can't concentrate, I can't make decisions like I used to. And it's very disquieting.
Yeah, it really is. We used to call it in school poverty of thought. They just can't find the words, or they can't find the flow that they used to mentally and verbally. And it's just that they can feel something cognitively happening. But a big one too in this trial that was addressed, and you have been a proponent of this, is when it comes down to fatigue. Because that's a side effect. Once you take testosterone away from an individual, fatigue is one of the things. In fact, it's now its own specialty called cancer-related fatigue, or CRF. So do you want to comment on what they found in terms of fatigue being on transdermal?
So when you take testosterone away, you take estrogen away as well. So androgen deprivation therapy deprives you of both hormones, both of which are important for normal biology, but better be absent one than both. And the ability to, again, sleep better, have better REM sleep, just in itself will manage or address some of the daytime fatigue problem. So, I can say personally, the difference between the two is not imaginary. It's quite clearly changed the way I appreciated life, looked at life, and felt alive. And you get to the, maybe you don't want to jump to ED, but I've told you before
Yeah.
that on an LHRH analog, and I'll go back, which dates me, the woman of my time, Wonder Woman, Linda Crawford. If I were sitting in a room and she came in on an LHRH analog, I wouldn't even turn my head. On estrogen, I took notice. I mean, it's a matter of appreciation and awareness. That is, I'll say, comforting as being a whole person. So that
Interesting.
also, with regard to the rat study, you castrate the rats and they have no interest, male rats, they have no interest in the female. You give them some estrogen, they're still testosterone deprived, you give them estrogen and they start copulating with the female. So it's a important aspect of our whole body system, and sexual as well as bone health, as well as, we'll say, mental cognition and well-being.
The researchers of the patch study, the one that we just pointed out, did call out. They said that we did see lower fatigue. So they said, like you said, they couldn't really see the difference here. It wasn't meant to measure that, some of the other markers, but they did call out lower rates of fatigue, which I thought was striking. We did talk about gynecomastia already, but I just want to add something to this. When you cut off testosterone, regardless of the method, if you cut it off surgically, you know this, if you cut it off with ADT, let's just put aside transdermal estrogen for a moment. There's still quite a significant rate long-term of gynecomastia. This is not right. This is not just in estrogen. Men taking estrogen get gynecomastia. Men on ADT, many of them get gynecomastia in time.
Yes, that's a very good point to bring up. Yes.
And so it's not fair to just to pin it on them. And then you and I know the story without saying the name. I lived this story through research. You and I lived this story. When I was in a clinic, I lived this story. We wrote up a case study at Michigan. There was a famous supplement over the counter that people paid thousands of dollars for in the 2000s, and it was dropping their PSA, and they were doing well. And people said, well, it caused breast enlargement, but it's controlling my PSA, and people paid thousands for it. Lo and behold, it turned out in the investigation that there was potentially estrogen in there. It's since been taken off the market, but I just find it interesting that so many people did not mind the gynecomastia when they thought it was a cheap supplement, but it wasn't cheap. It was expensive when they kind of equated it to being an over-the-counter. So I do agree with you that this side effect that it gets pinned with is not a big side effect in the realm of the others, right? It's just one of the things you have to mention.
And it can be addressed if it becomes a big side effect, rather straightforwardly and safely.
That's right. And so now, to make you look even better today than you already look, hot flashes, that got called out in the trial. Can you please explain, can you say again, when you put up transdermal estradiol, not only are people using it in clinics today as a low dose to reduce hot flashes in some men who are on hormone therapy, but in this trial, hot flashes were significantly less, right?
Yes. And I think, and I can testify myself and to the patients that I did put on estrogen who were having significant problems with their ADT. I was very cautious because there was no level 1 evidence. I was saying to them, there is evidence and I'm doing it, but you're having so much trouble with LHRH analog. Let's give this a try. I mean, their reaction and response was, wow, doc, and their spouse or significant other similarly said, what a difference this has made in how I feel. And the hot flashes are gone.
Yeah. That's and then we talked about the insomnia. This was also mentioned in the trial, and it's so funny. Everything in the trial that was pro you were saying 5, 10 years ago, and everything that was con, you were saying 5, 10 years ago. You used to tell me, look, I sleep better. And in the trial, the suggestion was maybe there is this benefit, which we touched upon coming A to Z. Any other comments?
And that sleep helps the partner as well. I mean, if you're up 3 or 4 times changing your shirt or your trousers, your bedclothes, that makes for a very unhappy evening.
That's right, because it's not just you going through side effects, it's the person right next to you. It's everybody around you. So this is kind of what I was struck to deal with. I had to deal with Dr. Shellhammer lecturing me for almost a decade about him being on, in a good way, being on estradiol. And I'm thinking, well, we really don't have any big studies. And lo and behold, this big study comes out and says, efficacy is similar, bone health's better, cardiovascular is neutral. There might be an advantage cognitively, maybe neutral on ED, less fatigue, gynecomastia happens in everyone, a little bit more in estradiol, much lower hot flashes, especially severe hot flashes when they happen, right?
Mm-hmm.
And then you sleep possibly better. And then there's the miscellaneous, which you've told me about in terms of just your overall energy and your positivity and approach to life. Do you want to have a quick comment on that? It's just, you always kept telling me that your attitude just seems different.
Well, you mentioned the situation of why didn't I get more down and out? I'm sure I would have, was I not only facing the disease, but feeling pretty poorly as well. So at least feeling reasonably well made the approach and the time less burdensome.
It's unbelievable. So I'm going to put some checklists. So if I put the Moyad Red checklist of what this trial made transdermal estradiol look good, look at all the checklists and how good it looked overall. So I just sit there and go, okay, it's kind of like you going through CRPC. How is this guy doing so well so long? I don't try to explain it. I'm just appreciating it. All right. So if this is what he's campaigning for, and this trial showed a benefit, then let's take it to the next level. I don't get it, Dr. Shellhammer. How does this whole patch thing work? So we're going to end today with you taking me out in a realistic way. You're going to tell the audience just how this works, that people are even intrigued talking to their doctor. And that's my job, because you've made this interesting. The first question that comes up, yes, instead of standard LHRH, you're saying it's a possibility, especially for those guys who can't tolerate it anymore. So question number 1, how are you getting this stuff? That's the first question. How do I even get this stuff if I'm remotely interested in it?
Okay. I got it by asking my physician to write a script and a short letter before there was this trial to Anthem Blue Cross, Part D, and they filled the prescription. And for 3 or 4 years, that was my methodology. As you know, Part D plans underwent a significant change last year. They dropped me. So as a Vietnam veteran, I now get my patches through the VA. But Cost Plus sells the patch, a generically written patch, not for any NAM brain, but just for estradiol 0.1 milligram is what all the patches are. I shouldn't say that. The majority of patches are 0.1 milligrams. There are some that are lower.
Yeah.
And that is how they can be procured. I am convinced that insurance companies, knowing that the expense of these patches is much less than the LHRH analogs, and we haven't touched on financial toxicity, but all of these benefits accrue for a cost less than the alternative. So insurance plans will be happy with this level 1 evidence to back them to fill the estradiol patch versus the LHRH analog. That again is an opinion, because this trial is only 2 months in the arena.
And again, how much are you paying for right now?
Well, I'm not paying anything because I'm at the VA. But before that, I paid $60 a month or $2 a day.
$2 a day.
With the Anthem Blue Cross coverage. I paid 60. Yes.
And then tell me again how the dosage you use, how you applied it, and how often. So if someone's
it's a 0.1 milligram patch, as written in the clinical trial, 4 patches twice a week, with time as your test. That was the starting dose. If the testosterone came down to castrate levels,
yes,
you could diminish to 3 patches twice a week. And that was basically the continued standard throughout that trial. So Monday, Thursday is my patch day.
Okay.
I apply it to my anterior abdomen where I can see it. And I fortunately have no dermatitis reaction. I guess there will be some individuals who might have same. They might have to move the patch more frequently, but I can just go A, B, right, left.
So you're doing 3 patches, those 3 patches twice a week you can go down to?
Correct.
That's 3. You're saying, so just so the audience knows, you're putting on 3 patches twice a week. But what are the, but 3 patches can sound like a lot or a little based on the size. How big are these patches? Are they?
They're smaller than between a nickel and a quarter. Some of them are round. There are square ones that are this little bigger than a postage stamp.
So that's tiny. So they're a nickel and a quarter each.
Yes.
And you can put them near each other.
Yes, absolutely.
And they are adhesive enough that, do you worry about sweat?
No, I mean, if I take them off in a shower with a little bit of peeling and pulling. So they do not detach. They're very adhesive.
They're adhesive enough that they're malleable. So you can go run a marathon. You can jump in the chlorinated pool. You can go in Chesapeake Bay. I don't know why you can go in Chesapeake Bay. It's too cold right now, but and they stay on there.
Yes.
And they're that tiny.
Yes.
Every good fisherman would say, what's the catch? What's the catch? What's the catch here? Okay, you told me cost is low. Application size is low. You got to work with your doctor. You can get a short letter. So the catch has to be finding someone that's, I'm going to guess, and then you tell me if I'm wrong. So everything I've heard from you, the catch to me would be finding someone willing to let you do a trial of it, because people would be nervous about it as a practitioner. Is that right?
That's good. No, that's good. That's excellent statement. But also as we'll say, practice changing policy, it's very disruptive. Initially, because my practice that I was in, all practices have appropriately a very set, we'll say, dance time schedule. You get your shot, you get your PSA level, you get your calcium, you get your denosumab, you get your dental approval, and you just go through this. It's all very appropriately and thankfully worked out so no one misses a beat. Renal function monitoring, calcium monitoring for the bone protective agents. All of a sudden, this becomes, I hate to say it, kind of easy. I mean, physicians, and I'm one of them, love to think of mechanisms where rank ligand, where blocking, where LA2. I mean, it's a wonderful biological complexity. I get worked up. He said, "What's the big problem?" It's too straightforward, and it's almost too good to be true. Because if it's too good to be true, what's the follow-up? It can't be true.
Yeah.
How can it be less expensive? How can it be easier? How can it be better?
I know. I mean, we want to sound smart by repeating mechanism of action, right? That makes us sound smart. If you say
it's satisfying.
Intriguing mechanism of action, like when you took Tycarb, that's a tyrosine kinase inhibitor. He goes, boy, that guy's smart. If you say estrogen just works, like estrogen does, it brings down testosterone and men need estrogen. That doesn't sound very sexy or interesting, but But it's so incredible because you've got head-to-head data. You can now get it. The cost is not the question. The application's not the question. The size is not the question. But the catch is, man, at least they have Dr. Selhammer to refer to because that's important, plus a major clinical trial. Because well, my understanding is the patch investigators at the UK, they're now going to push the UK hard, is my understanding in the background, for that this becomes more available in the United Kingdom. I don't know if that's what you heard. That's what I heard.
Yes, but there are obstacles, just like here.
Yeah.
The patch is approved for women, not for men, so it's off-label. It's not yet standard of care. It's been put before the NCCN Guidelines Committee by this clinical trial, which by peer review and everything else meets the highest levels of appropriate level 1 evidence. So right now, there is still the, I'll say, uncertainty of where the physician community should stand, because it does require some leaps of faith and some, I'll say, prodding patients who say, darn, I've heard about this and I please help me try it.
But if I want to,
it sure isn't going to impact adversely on controlling my disease. I mean, there's no evidence that that's going to be a problem. I'm jeopardizing my disease control or my potential for disease control. It does what castration, what ADT does. It drops your T level to castration range. And that is the sine qua non of androgen deprivation therapy.
Well, and also I think that this discussion, people should understand that this is just not yes or no, straight binary. There's so many situations where, let's just say, I'm not to play angel's advocate, there's so many scenarios, as you know, clinically, where there has to be an option B. In other words, someone just can't tolerate androgen deprivation anymore. And it's just a question of whether or not they're going to continue therapy or simply come off and quit. There's plenty of those people who just simply can't tolerate it. Then there's the people who are on it, then they become castrate resistant, and maybe they just want to try something different. And then there's just the people who want the hot flash reduction because the severity of the hot flashes are so bad, they don't necessarily want to continue therapy. There is so many scenarios where there should be an option B, regardless of what side you're on, that this argument's an easy argument just in terms of availability.
Well,
right?
You mentioned option B. The option B now is intermittent androgen deprivation, drug holiday.
Yes.
I mean, some of the current products kind of tout the fact that when you stop them, you're going to feel better. But why are you stopping them? Because you don't feel well. If there's something that can continue your active therapy and you feel well, isn't that a powerful argument? So we don't need to have intermittent ADT or holidays or withdrawals, because the reason for stopping doesn't exist. Namely, the adverse event profile is not overwhelming and significant.
Yeah. And okay, so this, even if I play the game of exceptions, you've got my mind here thinking, let's just take the exception. Let's just take the minority, the small number of patients. Think how many of these patients there are globally. Someone's on a bone protective agent. Let's say they get osteonecrosis of the jaw. Let's say they get an atypical femoral fracture. Those things that really would freak you out. They don't happen that often. What are they supposed to do? Go back on the bone drug? I mean, so right?
Yeah.
So the bottom line is that becomes an alternative. What about all these patients that have such severe hot flashes, they can't sleep at night? It affects their activities of daily living. You know that term. And so what's option B? So there's all these exceptional patients that they come up to these positions where they suffer such a severe consequence of the drug that's trying to mitigate a side effect that what are you supposed to offer them? That is almost an argument in and of itself, Paul. Right?
Well, today's world, what you offer them is figuring out now the receptors for hot flashes and developing a drug that's expensive and has its own side effects to counter the hot flashes. It's a never-ending spiral of pharmacological interaction.
Exactly.
When at the beginning you can start and end with one patch, well, several patches.
So in the trial, to reiterate, it was a 0.1 milligram patch. They used 4 to get down, if they can get it down to castrate, right?
Mm-hmm.
Below 50. And then if they could do that, they would then go to 3 patches twice a week.
Mm-hmm.
Apply near each other, and you could switch sites. And I did fail to mention that you did mention itching, which comes with its own technical term, which we won't go through, can happen to a certain number of people if they don't switch the patch. But again, that's not enough to necessarily stay off therapy. Okay, what did I miss? I mean, that was pretty intriguing. Oh, I'll tell you what I missed, which I feel like I'm now on the Dr. Paul Selhammer rah-rah team, but I'm just the objective reporter here. I'm just trying to get both sides. I did find this paper. This was a paper from 2005. Laidler et al. Anyway, what they were arguing is that when they applied estradiol to some of the androgen insensitive cell lines or other cell lines, it seemed to upregulate PSMA expression. In other words, more PSMA came to the surface. Theoretically, the implication 20 years later is that maybe that's part of the reason you become a better candidate for some of these radioligands or PSMA-directed therapies. Because think about it, if you could take a drug that increases the expression of the PSMA of the prostate cancer that's hiding out, it becomes an easier target. That was their argument in 2005, and I know you and others are looking at that as a possibility in the future if you apply estradiol. Am I right or wrong there?
No, you're right. As part of our investigative efforts at Eastern Virginia Medical School, a scientist is working with cell lines exposing to estrogen, measuring PSMA expression, and hopefully in the next month we'll have some basic scientific data to share. Because it is, again, my SUVs, 50, 60 SUVs are on the higher range of normal. You'd like to see 10 and above.
That's
so
exactly.
Mine were really high. And why is that? We're trying to sort that out. Now, we went to the Australian folks and asked, can you look in your files for any men who might be on estrogen and all the patients you've treated with lutetium? It didn't spark their interest. But somewhere, I've heard it said that in the Medicare database, there are answers to mostly every question that we hope to find, and AI will eventually unveil them. I'm sure that information is there. It's just finding it and pulling it together.
That's awesome. I'll ask some of our Australia colleagues. It's really a fascinating story. Now, before I give you your gift, is there anything I missed or that you want to say? I mean, this is just, you have 2 incredible stories in one. You have the incredible story of survival and thriving and doing well, and then you have the incredible story of this transdermal estradiol patch, which I got to tell you, all those years you were kind of telling me, and then we had the patch study, I thought, hey, maybe he's got something here. I shouldn't hold it against him that he went to Notre Dame, I mean, I just,
yeah.
Well,
I'll say, and you've heard me say it, it's from The Emperor of All Maladies by Mukherjee, where he said, in order to win the war against cancer, we may have to redefine the meaning of victory. And I think that fits in with saying quality of life and improvement of same during therapy is a redefinition of victory. You win on the score of disease control, but also on the score of quality of life benefits.
Well said. Well said. You made me think about a lot of stuff as we're leaving today. I wondered, do you think you might be BRCA2 or maybe one of the cancers that it's growing?
It's been tested. No.
So
I am genetically neutral with regard to prostate cancer. Now, I have not had any of the biopsies any of the lesions biopsied for somatic mutations. The question when I had the liver metastases, shouldn't you do that? And the answer was, it's not going to change what you're going to do, i.e. the Pluvicto, and there is some risk to liver biopsy. So let's pass up on that opportunity for now. I'm sure some clinicians in medical centers would have said, boy, having that information would be helpful, maybe in the future.
Maybe, but a lot would also say liquid biopsies have become so good, they're almost mimicking exactly what soft tissue, right?
Yes.
So I don't know. I mean, that's not a fun biopsy for anybody. Wow. Okay. And then the other thing I thought about in your story is, would you still, in your condition, if you qualify, would you take chemotherapy? Would you?
No.
Why do you say that? Because it's helped a lot of men.
Yeah, but I've seen the side effects of it. I mean, I look and act pretty robust, but I am on we'll say the last slope of a ladder, and I'd rather not be pushed off it by something that may make my PSA go down, or may. The beauty of Pluvicto is compared. I have not had both, but I've seen many men on docetaxel chemotherapy, and I know how I experienced Pluvicto. They're not in the same ballpark. So I have more Pluvicto at a heartbeat, but not chemotherapy.
But the Pluvicto, just to remind people, the con of that, it's an incredible drug, but you do have to watch the dry mouth, and you did experience dry mouth. I think you told me you have grade 2 dry mouth now.
Yeah.
Right. So, but what an amazing response. Man, see how good I am, Paul? I told you this part 1 and 2 would take probably 30 minutes, and we talked 2 hours. See how close?
You haven't lost your touch.
I say thank you for all you do and just being you. You know that. But before I'm going to sign off to you, I have to give you a gift. This is a very difficult. You have no idea the stress. For those of you who think they're so sick and tired of me going to these PCRI things, he's one of my best friends. I've said that about 50 times, but I have a lot of good best friends. I have very few really good friends and mentors that I looked up to. You know some of my old chairs that I looked up to. They were tough. They were tough on me, but man, they made me better. Jim Monty, some of them, David Bloom, my current chairman. You were always great that way. You were always giving me great advice, but you were always telling me, just keep producing. And I appreciated the mentorship and the friendship, always in my top 5 or top 3, along with my current mentors. But so what do I give the guy who has everything? The doctor has everything. So I thought I could give you a funny urologist cup. So here's a couple of the cups I was going to buy you. Then I thought that would be cheesy. The first one said urologist because I'm amazing at keeping things flowing smoothly. I thought that's not a bad coffee cup. The second one I thought was very comical. It said urologist. I make a vas deferens in people's lives. But then I thought, you're not really a fertility guy.
No, yeah.
Vas deferens, that comes from the testicle. It helps move along the sperm. So then it meets up and can help it do what it's supposed to do. And so you're not really a vas deferens guy, a kind of urologist. So I have to give you something. The first gift I have to give you, it has to come when I think of college football and all that. And I thought, well, maybe I'll give you a small Michigan football, but then you would probably throw it away. So we're sending you this official Notre Dame 18-ounce coffee tumbler. What do you think about that?
That's a lot of coffee, more than I drink, but I won't fill it. That looks good.
It does look good. That's
with the leprechaun. With the leprechaun, yeah.
Yeah, it's from the official store. You can put 2 ounces of coffee. You can put hot or cold beverages. It's an official tumbler, so it's going to keep any drink that you want cold, colder, and any drink that you want hot, hotter. And it was not easy, Paul, giving that gift away. I wanted to give you the Michigan tumbler. All right. That was the first gift. Then I thought, why not give him another gift in case he wants to drink even more coffee? So we're going to put your name on this cup. It's going to say Dr. Paul Shellhammer. Both of these gifts will be to you within 1 week. It's a cup.
Whoa!
That
is beautiful. And if you put on the other side testosterone, you would see that it's the same 4 carbon rings and just a couple of different hydroxyl groups. I mean, it's so scaringly similar when you think that one shoots off to me and you and Alex, and the other to Alex's coworker. It's scary.
That's a good point. You know what? Because testosterone in a man is converted to estradiol. It's called through an enzyme called aromatase. And the human body had to make it efficient. And the one way to make it efficient is the chemical structure. It can't be that different, right? So every minute during this entire talk, we've been converting, testosterone to estrogen. So that's a good point. The structure is very similar. But unfortunately, on the other side, it doesn't have the molecule. It says Dr. Paul Shellhammer.
That's okay. I'll take that with gratitude.
Have you ever been given 2 greater gifts in your life than those 2 coffee cups?
No.
Exactly.
Clearly no. And I don't think I ever will.
Well, I could send you the official Michigan National Championship in basketball hat, but that I know that would probably go in Chesapeake Bay, so I don't want that to go there. So what do I say? Thank you so much for doing this. We talked about doing this for a year. We finally did it. It met all my expectations on what we covered. This is going to help so many individuals. Plus, you're going to give your own summary to us, and we're going to put it online. And let me know if there's anything else I can say, but you're an incredible physician, incredible patient advocate. Look at all that you've done. And I hope you can keep doing all of this stuff for us and other people, because it's doing a world of good for the world. It's just really remarkable. So thank you.
Well, I'm going to throw it back on you and say during your career, you have generated, we'll say, a different facet of approach to men's health, well-being in the context of cancer that few others, I'm not sure any others have. So thank you for being unique in your endeavors and in your interviewing skills.
Thank you. I appreciate that.
I'm going to show you just for a second, if I can. That's Chesapeake Bay out there.
Yeah,
I
can see out the window. You're many floors up. So the bay, there I can see it.
12 floors up. So I appreciate a western sunset every night. And that, together with my estrogen, has kept me upbeat.
Well, you better stay upbeat, because after this interview, I can guarantee you a few things, but now you're going to get a ton of calls of people are going to say, I didn't know Shellhammer was that good. I thought that poor guy had no testosterone, so he didn't have enough energy. But now they're going to say, I want him on my whatever cast. I want him on this show. And of course, after this, I'm going to see when we can do something next in the next year or two to get an update, right? An update on you, and an update on the story of side effects, whether it's transdermal estradiol or other type of side effects, or what's happening in the world of prostate cancer, which you follow every single day like me.
And another patch trial will be forthcoming in the next 12 months. This looked at very high risk, but local disease, pelvic N plus, T3, T4, the metastatic. And this was based in 2010, 2012, I'd say 50 to 80% of these men were really metastatic in today's world with staging, but they will bring forth a de novo conventional imaging M plus paper in the next year.
Wow.
with the same outcomes, survival, quality of life, and such. So it'll be more to substantiate what's already been published.
That's awesome. See, as we leave, you make me think of other things. In the past few months, they've been talking about this Proteus surgical trial, because you used to do where they gave 6 months before surgery and 6 months after surgery a type of hormone therapy. Anyway, bottom line is it could completely change the paradigm of how surgery is done in some high-risk individuals.
Yes.
But the thing that didn't come out enough from that trial was that older men had a difficult time with that in terms of overall survival and side effects. But anyway, it makes you wonder if surgery is going to be handled differently in terms of hormone therapy, doing something earlier, because that was never done in our time. And then for those guys who can't do that, do you apply transdermal estradiol before surgery?
Yes.
And
Yes.
do it with the pill. There's
Yes.
just so much to think about from this Proteus trial. That's the one that have been reviewing anyway.
Mhm.
So I want you to be able to have a life and not talk to me for another 28 hours, but you can imagine all the thoughts that are now going in my brain. And thank you.
Yeah, one
I'm
other
looking
point.
forward to seeing you. Next time
Yeah.
I'm in Norfolk, I'm definitely going to let you buy me dinner.
Good. Did the paper you just showed me, was that a New England Journal of Medicine article?
That was a New England Journal of Medicine. So that's Taplin et al., who's at Mass General.
Okay.
And so that was in the May 31st edition. And
So it's interesting that trial got quite a bit of press and publicity at the recent ASCO meeting.
yes, it did.
The patch trial was not mentioned.
No, you have to go. When people think of Patch, they think of that old movie with Robin Williams, Patch Adams. And but if you look outside the United States, I thought that the Patch trial did get some attention. But I mean, that surgical trial, as you know, in surgery, applying hormone therapy was never standard of care. It didn't work.
It didn't work.
Now they're saying if you put one of the second generation androgen inhibitors, just in this case, it was apalutamide. Maybe you do 6 months before, 6 months after, you can change some lives, especially younger men. But it brings up the concept of what do these older men do? And again, where's option B?
Mm-hmm.
So I don't know. I mean, you made me think of that when I was reviewing the paper. Like, well, what about the guys who can't do this because of whatever toxicity? And but I think that's an incredible thing in terms of potentially surgery in people who are high risk for recurrence, who never had that option.
Yes.
And to be fair, everything that we've talked about today, isn't it incredible over the past 10 years, all the amazing achievements we've had? I mean, you mentioned Pluvicto and these anti-androgen inhibitors. I mean, it's pretty incredible how we suddenly now have an ocean of opportunity.
Yes.
When I went to the FDA with you, we were just crying for one drug to get approved.
Yes. Yep. It's been as they say, quite a run, and happy to have been alive when it's happened and alive to some degree because it happened.
Exactly. Yeah. Oh, well, I'll see you soon though, definitely. And I appreciate your time and thanks for your service, as we say.
Yep. Thank you.
Keep on keeping them. I'm excited to talk to you again soon, which will probably be in the next few days.
Keep in touch. Thanks.
All right, I will.
Bye-bye.
Thank you so much, both of you. I just really appreciate the transparency and just bringing that type of power to the channel. The patient experience and the physician experience together is such an awesome thing to see, and we really appreciate it. Now, I would like to remind you that we do have an exhibit hall here on PCRI's website, pcri.org/men's health. There's some incredible resources there. I'd also like to thank our sponsors, Bayer, Pfizer, and Dendreon, for supporting PCRI and helping us make this free for all of you. And don't forget to like and subscribe to this channel and like this video. Leave your comments and questions. It's just a great way. The more energy and likes and clicks and subscribes that we get with this video, we're able to push this out organically to prostate cancer patients all over the world, and this is incredible information that we want to be able to give them for free as well. So please support the channel in that way. We really appreciate it. A big thank you to Dr. Moyad for bringing these speakers, spending countless hours doing research beforehand, and then moderating them the way that you have. You've just done such an incredible job. Every year I'm always blown away by the work that you do, and it's so cool that you volunteer your time and just donate so much to PCRI. We can never thank you enough. And it's so cool that we get to see the urologic mindset and perspective through you, and now we get to see also the oncology side through Dr. Mark Scholz, who's our executive director and founder here at PCRI. I get to film with him and work with him every day, and I just appreciate him so much. He is an actual hero of mine, just like Dr. Moyad, and to see these two come together and to, bring the conference into kind of a reflection period. They go through and the talks and they go through the Q&A, and they're able to share their perspective and the highlights of what they think are important to patients. It's just a very powerful time together. So without further ado, here is Dr. Mark Moyad, and here is Dr. Mark Scholz for our extended Q&A.
Hey, I have a picture today for you before we start. I don't know if they're going to show the picture. That's my dog on the chair staring at me, asking me what I'm doing. I explained that I have another Q&A with Scholz. He explained to me that he's a male dog that has a prostate, and he hears about your popularity. He had a question. He said, I wonder if Dr. Scholz will start seeing dogs in terms of prostate health. If he does, great, I'll make an appointment. And if he doesn't, I have no desire to talk to him. So if you are going to make an announcement today that you'll also be seeing dogs and dealing with prostate with dogs, please let the world know.
We're a little backed up on people, and the skill set for dogs is a little wanting. But I appreciate you trust me with. I know you're a very treasured dog. That's
well, because dogs can get BPH, which is a good segue, right? Dogs can get prostate cancer. Dogs can get prostate problems. Yeah. So since we're talking about my favorite dog, do you want to lead us into the BPH category, which I love so much?
Yes, and thank you for inviting Brian Helfand to come speak to us. What a prestigious and articulate, brilliant speaker on the subject of BPH, and your Q&A with Dr. Helfand afterwards, extremely helpful. What a vast subject, and the way you two covered so much ground in that time is amazing.
Thank you.
I have backdoored into managing BPH as a medical oncologist. So what? But I've been doing prostate cancer for so long that it's been very natural for my clients to, by the way, doc, I got a big prostate, and there is, I think, and I've talked to you about this. I said, why don't, you have influence at the University of Michigan. Why don't you guys bifurcate the urology training program into the cognitive and the procedural? The idea of doctors who aren't doing the procedures, that don't have a conflict of interest, trying to think through what's best for this patient, pills, an operation. When surgeons get paid to do operations, we know inevitably there's going to be sort of a mindset towards operation first. And these aren't bad people. It's called a conflict of interest. And the urology world is the only one where the doctor who is doing the cognitive side and the procedure side is the same person. So I see a lot of men with big prostates, urinary problems, and the fact that I'm not a proceduralist, that I don't do in any of the operations, I think gives me a different perspective. There's so much to say. I think number one, I'd like to talk about, he made a comment about doing procedures so that you don't have to take pills anymore. I think that that's a little bit backwards. I think that the idea of doing a procedure to not have to take pills, there's an intrinsic problem with that viewpoint. One is that these procedures, many of them require general anesthesia. And we're talking about men at an average age of around 70 or something like that. And it's a well-established fact that when we take general anesthesia, I'm 71, that there's a 10 to 20% chance of lingering memory problems afterwards. And this is a common problem with general anesthesia, not just for urologic procedures, but for any kind of a procedure. And this concerns me because as a 70-year-old, I'm already noticing differences in my mental acuity and my memory. And
really, would you like to talk about those?
I can't remember, so the idea of a procedure to fix a situation, if a pill can suffice, doesn't make a lot of sense to me. So I'm sort of not against the quality of the procedures, the effectiveness of the procedures, because these different things, aquablation and whatnot, they certainly do solve problems. And you, in one of your handouts, pointed out some of the scary long-term repercussions of BPH, kidney failure, bladder diverticuli, I don't think you mentioned catheter dependence. So if men's bladders are not allowed to drain for long periods of time, sometimes they stop wanting to drain. And I have a few patients that that need to put a catheter in every time they have to urinate.
Right.
This is a terrible problem. And I think that one underutilized test, which you pointed out, is to do a what's called a post-void urinary residual volume with ultrasonography. Make sure that that bladder actually empties. A very simple test. They just plop a microphone on your lower abdomen and make sure that the bladder isn't retaining a lot of urine. That's a prelude to that possible situation where someone would, their bladder would just give up the ghost and you have to use a catheter the rest of your life. So all of that context, a super professional, very impressive presentation by Dr. Helfand and your Q&A time. Very helpful for introducing people to these various interventions that can really just fix the problem once and for all, which is a beautiful thing. But I honestly look at it completely from the opposite point of view of starting with mild, reversible side effect related treatments with pills. Lifestyle, you mentioned that as well, very effective. I always start with telling patients, stop drinking water after 5 p.m. and maybe take a mild anti-inflammatory with dinner to reduce the urge to urinate, whatnot. So anyway, that's just sort of an overview of my general feeling of the urology realm and the concern that sometimes there's a procedure first mentality. And as I pointed out, so we can get into talking more specifically about these different options and their pros and cons, but I wanted to talk in a global sense about the prioritization, because it went by really quick. I mentioned 10 to 20% of people having lingering memory problems after general anesthesia. This is not a speculative thing. This is a real problem. And so I tell patients that are thinking about a procedure, do you have any other option? Is there any way you can live with this? Do you have to do this? I mean, that's the most obvious problem. There are other complications from any procedure that we can go into, but those are irreversible. Whereas a lot of times the medications that are used and these lifestyle changes, if they don't work, at least the side effects are reversible.
Yeah, there's a progression. And to defend the proceduralist, of course, you had someone that uses general anesthesia. Sometimes they'll use spinal, but the vast majority of what's being sold out there isn't under general. There's these missed procedures, but they come with their own catch. Like I kept showing the sign, the greater the intervention in BPH, the greater potential outcome. But the reason I want to start back at the very beginning is because what you're saying, and which I agree with that part, is there should be a cadence, there should be a rhythm, there should be, you start conservatively, you get the awareness going, and then you move through the options. Because for the people that have the most severe outcomes, people don't understand every day in every emergency room in this country. In fact, we just dealt with this on a friend a few days ago. They'll go in because they're in urinary retention. The man will have BPH symptoms for 20 years. He won't deal with it. That's why I led with this sign, Dr. Scholz. What's the number one cause of hydronephrosis, which means that can ultimately lead to kidney failure in adults? And people think, well, I don't know, it's BPH. And then you're right. The reason I didn't mention self-cathing, which is not fun, which you brought up, that's a good topic. Thanks for picking out the one bullet point I didn't put in my sign. Man, he's tough. He's tough, but I'm okay with that. But if you go through these, you never hear about these. You hear about these symptoms day and night. See, nocturia, getting up at night. Isn't it interesting when someone goes, oh, I only get up 2 or 3 times a night. And now sleep has become such an important part of cardiovascular and overall men's health, right? The job here in men's health is we talk about men's health from head to toe. You can't talk about effective quality and quantity of sleep without addressing nocturia potentially in BPH. And the bladder muscle injury is like heart muscle injury. If you force this bladder into a compromised situation long term, you can do any sort of intervention, but you may never regain.
Well, these are the people that end up with the bladder with the catheter dependence.
That's right.
The ones with bladder wall injury. So that's exactly what you're talking about. And I am so how does one? But Mark, how does one not end up showing up at an ER with a blocked bladder? And the answer is with your family doctor or your urologist are they doing a periodic post-void urinary residual volume? This is something that can sneak up on people where they don't really realize their bladder's not empty. They're urinating excuse me. They're urinating frequently because the bladder's not emptying completely, but they don't know that it's not emptying completely. This is an easy, simple test that can detect this problem before it becomes a major issue.
Dr. Scholz, what's the number one cause of PSA rise in a man? Full stop. What's the number one cause? It's BPH, right? Prostate cancer gets all the attention. I get it. But it's BPH. What's the number one reason, people want to further investigate a rising PSA? It's BPH. Prostate cancer runs second. So BPH is a natural part of aging. And some men, we said, have very small prostates. Some have gigantic prostates. And some gigantic prostates, people do okay. Some gigantic prostates, they get into huge trouble. But the bottom line,
let's talk in practical terms here. So you and I are sitting across the table from someone comes in and says, I'm waking up at night. I can't get a good night's sleep. I have urinary urgency and frequency, and this has been going on for a while. Help me. So the first tier, and you pointed out the same thing, is to talk to patients about changing their lifestyle, cutting back on water intake after 5 p.m. I mean, getting really serious about that. And that can make a big difference. The next tier is some sort of a modest pill to try and enhance these things. And there's a whole long list of them. We won't go through them again. And these things can be used sequentially to see what works for someone, or they can even be used in combinations.
Yeah.
And they all have potential upsides and downsides. And then if those things are not working, or if someone does have retraining urinary, they're not emptying their bladder completely, the next tier in my practice has been something that was mentioned briefly with Dr. Helfand, but not in much depth, and that's called prostatic arterial embolization. The interventional radiologists that do this, who's pointed out in your conversation with him, have to know what they're doing, of course, but that's true for any procedure.
I mean, we can cover PAE a little bit, some of the cons of it, but I still want to go back. I still want to go back to the awareness issue, because I give you and me a D+ when it comes to BPH awareness. And I'll tell you why. Because it's not a bad thing. It's not a bad grade. The reason we did a men's health talk is because we need a level of awareness in men that's just as much in prostate cancer about this whole BPH game in terms of the lifestyle changes, the conservative options, and the missed procedures, and maybe the more invasive procedures. There's just not a regular source to inform men about BPH. Prostate cancer gets all the attention. I understand that. Let me read you the latest guideline statement from the AUA number 14. It might surprise you. For patients with BPH, clinicians should provide now behavioral lifestyle interventions prior to or addition to initiating pharmacologic treatment. So now in the guidelines, they're saying, hey, you know what? And what's getting missed in all of this is people talk about watchful waiting and active surveillance in prostate cancer, but they don't talk about it for BPH. A lot of men who necessarily have mild BPH or moderate BPH, if they're followed by a trained individual, some of them don't progress rapidly, some do. So there are many men who work with really good urologists who are on a watchful waiting protocol, and all they do is behavioral changes. You mentioned they reduce fluid intake. There's a whole bunch of recommendations, a few hours per fed. They do something called double void. They go to the bathroom, they wait, and then try to go to the bathroom 30 seconds later. They stay away from alcohol, which causes nocturia. They reduce their caffeine intake at night. And what's so shocking about this, every time you go up against over-the-counter and sometimes pharmacologic pills, the men who are doing some of these things sometimes equal that effect. Now, I know they're complementary, but this has been a mistake in clinical trials, Mark. It's been a mistake because the placebo group, theoretically, should be the lifestyle change group. That should be the threshold, right? So if you ever go look on Amazon or other places. If there's people taking prescriptions or over the counters, you'll see they'll go, hey, this doesn't work at all for me. Or you'll see someone go, hey, this works for me, but you know what? I reduced my caffeine intake too, or I reduced my fluid intake. What I'm trying to say is the behavioral changes, I just want to start with that, don't get enough love. That's one of the problems I have. The second problem you brought up is that the subjective and objective tests to tell you whether or not you have mild, moderate, or severe BPH don't get enough love. This should be in everyone's computer the moment you hit 50. This is a symptom score. You should fill it out at home. So you talked about a post-void residual, which has to be done in the clinic. But we also have these things called symptom scores. So you're getting me all hot and bothered. So now I'm spitting on my computer. And this can be filled out, and you can put a date on it. And then when you go back to your primary care 6 months later, you can fill it out again. And it's a subjective measure, but it's a darn good measure of how well your behavioral changes are working, how well your pharmacologic change is working. And so the bottom line is there's all these different tests that I brought up. I brought up urodynamics. You brought up PVR. I could go on and on again. And we have to start familiarizing people with how they can evaluate their symptoms. You know what was really interesting? I don't know if you caught it, and I'm trying to find it on my desk, and it's driving me absolutely bonkers that I can't find it. Anyway, he told me there's an app now. He told me there's an app where the app listens to your urination. You put it by the toilet, and it can tell you your flow rate, because the greater the flow rate, the less the BPH in general. As the flow rate begins to be compromised, you have more severe BPH. That always had to be done in the clinic. Okay? I think it's called Proud P or something like that. But anyway, now that can be done at home with an app. So we need to do a better job of educating people about all these things that they can do at home or ask their doctor about in terms of flow rate, in terms of PVR, in terms of the symptom score, in terms of if I'm getting up at night. I don't know if you laughed or not. I said to him, I was one laugh I get. He doesn't. I don't make him laugh like I make you laugh. I don't know why that is. Maybe because we're closer in our relationship. I said, when you meet someone in the clinic and you ask them about nocturia, getting up at night, don't you think you should change the requirement to bring the partner in and say, how often do you get up at night? And then the patient answers, he answers, but then the partner should give an answer, right? Because I wonder how many times you've gone in there and the patient goes, oh, well, once, maybe twice. And the partner goes, what? No, it's like 3-4 times. It's affecting me, you know? And we also, if you agree with this, I know you'll agree. We also have to teach men and their partners that a DRE has value, a rectal exam. But a rectal exam is not good. Based on all the research, it's not good at predicting the actual size of the prostate, right? It's guessing. It's like going to the fair and the guy guesses your weight. I mean, maybe he comes close, maybe he doesn't, but there are lots of other ways to figure out the true size of your prostate, which you can use with PSA density. So what I tended to go through with him is, look, we have questionnaires. They can measure your size of your prostate with MRI, whether you get a PET CT, ultrasound. You get a PSA, you get a DRE, you get this post-void residual. There's this thing called flow rate, and there's quality of life questionnaires. And now you're really getting a better idea of, is this BPH that should be more worrisome or that doesn't even need to be treated? And this is what really strikes me as one of the most important things for the Men's Health Conference. I just don't think there's that level of awareness out there. And I think it's because we've put so much emphasis into other men's situations. Tell me I'm right to make my day.
Well, I mean, men's health is something that happens in the course. Prostate is the doorway to men's health. Men come to my office because they hear the word cancer. If they hadn't heard the word cancer, they wouldn't be in my office.
Yes.
And thankfully, many of the prostate cancers, not all, but many are relatively harmless. And that gives us an opportunity then to talk about optimizing their sleep, as you pointed out. That's probably one of the main concerns with BPH, is that it messes up the normal sleep patterns. And then cardiovascular disease, screening for colon cancer, making sure that you get vaccinated against shingles. So these things are real low-lying fruit that somehow in the shuffle don't get discussed.
They don't get discussed.
Yeah,
and men should not be getting up 2, 3, 4 times a night. That's the bottom line. And we don't discuss the studies. In the PLCO study, which was so famous for prostate cancer screening in the United States, There was a researcher named Wolin. I'll never forget this article. I had to review it for doctors. They looked at that study and they found that the men who were more physically active had a lower rate of nocturia. And we can actually start explaining why that is. We don't explain the beneficial effect of even just physical exercise, aerobic exercise in terms of BPH symptoms. I found it. Look at this. This is Proud P. This is an app. Now, you might have to pay a little bit for it, but you put it by the toilet. It helps measure your flow rate. It charts it for you. You could take it in your urologist and say, hey, a year later, I just want to know how my BPH is going, and your urologist can help you, but you can also help your urologist. You can help Mark Scholz. You can bring things in like Proud P. No, I don't have any involvement with this company. No, if you work for this company, I won't answer your phone call. But this is really interesting. I think these devices are moving home. You can do many of these things now at home to make sure your diagnosis and treatment options become that much better. How about that?
Yeah, I mean, it's if it gets extreme, and your list you pointed out, we have, thank God, excellent solutions, and it's nice to be introduced to someone who's done 800 procedures. This is something that you and he emphasized, that when the day and the time comes where something must be done, patients unfortunately don't spend enough time shopping to ensure that they're getting a top dog. The prostate area of our bodies is a very sensitive area. It's not like taking an appendix out or a gallbladder, and any old surgeon can do that. When you start fiddling with a very, finely balanced functionality, this is a complex action. And so someone goes in there and rearranges the furniture, how's it going to turn out? So having someone of his experience and who's highly trained and is even training other people, these are the kind of doctors that we need to look for when the day comes that it's time to do something where potentially irreversible.
But where I agree with you is, how can someone truly diagnose and figure out the best possible treatment for someone when all the metrics aren't being utilized? And what I mean by that,
for me, I don't. The problem it's a partnership with the patients. So patients who are experiencing problems are the final outcome. If we intervene with a pill or a lifestyle change, are they satisfied ultimately with the status quo after the intervention? So it's very a patient-centric process in terms of what. It's not a matter of fixing big prostates. It's not a matter of optimizing some number. It's really about patients getting the lifestyle without, hopefully, distracting side effects or problems from the treatment itself.
I mean, I do think, and we covered this, and we'll cover this before we end on a couple of the treatments, but I did want to cover the Wild West of pills. I mean, men are inundated by pills, and the dropout rate or the withdrawal rate or the cessation rate on some of these pills are pretty extraordinary. And it's not that they're not great. It's just that men are being hammered by the over-the-counter plus the prescription stuff, trying to get their hands around it and trying to understand the pros and the cons of it. And I think we did a good job. You can go back on the tape of looking at what the potential catches are and the benefits. And the prices of some of these pills, including over-the-counter pills, not so much prescriptions anymore because many are becoming generic. I mean, these can be huge cost, right? These can be huge cost. And what can also happen is that, especially I see in the over-the-counter area, someone can take something and then just shut off. They just go home and they take it, and they don't follow up with their doctor. So I think we're also saying that whatever you do at home, behavioral, even if you're taking a pill, if you don't follow up on a regular basis with an expert, you could run into problems. And that's why, like I said, go talk to any emergency room physician. Every day, every week, they have someone that comes in retention. So I just wanted to throw that in there when it came to pills. There's also something else I want to mention, and you know me, I'm a big fan of over-the-counter and other stuff. But sometimes we don't police ourselves well enough. there's so many pills available. People don't talk about DILI, and DILI is called drug-induced liver injury. It's a very big problem in the United States. The last time one of the largest surveys were done of DILI, 20% of that came from over-the-counter. And one of the biggest areas of over-the-counter is BPH. So all I'm just telling you is a wild west out there. If you think there's a wild west with treatment, there's a huge wild west with over-the-counter products and people just trying to understand what to do. And we have very few products that have any sort of third-party label on it, even over the counter, that shows that it's been tested and that it has been safe. And so it's another thing to remind men that just because you're paying more for something over the counter doesn't mean it's been tested more, doesn't mean it has high quality. There's an old saying I use with the residents: if it costs more than Costco, you have to ask why. Costco does third-party quality control. I don't work for Costco, and they sell some of the cheaper ones. And if someone wants to pay more, then they have to understand why they're paying more. And so I'll get off my soapbox, but we could do an entire session on the wild, wild west of prescriptions and over-the-counters and how to make heads or tails of it.
Yeah, I don't honestly think it's that complicated. You do have to have a relationship with your physician. I mean, I think that's what's being ignored in here, is that people come in, have a procedure, and they never see the doctor again. Yeah, you got a problem. The nature in my world, we've watched people for years. We build long-term relationships with our clients, and these are intelligent people, lawyers, doctors, engineers, and who are involved in trying. It's not just the doctor telling them what to do. These are intelligent problem solvers that are looking at the options and then reporting back on an ongoing basis. We tried this, we got this kind of benefit. Yes, the questionnaire did this. Yes, the post-void did this. This is how I felt. This is how I slept. And maybe we try half the dose of that same medicine, or maybe we'll double the dose of that same medicine. And in other words, there's this idea of give one thing, give up, give another thing, give up, get a procedure. That is just not in touch with the way doctors interact with patients. Doctors have a living relationship with these patients, and there's communication going back and forth constantly in terms of how these things work, what the risks are, what the potential upside is, and then testing the water, seeing how the outcome, and making adjustments, abandoning something that's not working, trying something different. And but what I wanted to emphasize at the outset is that I see it in terms of tiers, in terms of lifestyle things first. That's not enough. Medication second. Why medications rather than going to an operation? Because the side effects are almost invariably reversible. You're not making a commitment that you can't back out of later. So that's why I think I see it as the second tier, some sort of medication. And it's true, you're not going to solve everybody's problem. Some people will have to advance on to some sort of a procedure. Does that rule or that sequence have to be followed in every single individual? No, of course not. If someone comes in and they have a catheter because they obstructed in the ER, no, we're not going to go to lifestyle changes. But the context is the individual needs of the patient and managing risk. How often does general anesthesia occur lingering memory problems in men around 70 years old? This is the answer I got. Lingering memory problems, often called postoperative cognitive dysfunction, or POCD, after general anesthesia, are relatively common in older adults around age 7, but they're usually temporary, with most people recovering or seeing significant improvement. Studies in elderly patients show that 25 to 40% of older adults have short-term problems lasting a week or so. Rates drop to about 10 to 12%, but up to 40% in some cohorts for medium-term POCD lasting 3 months. Persistent effects beyond 3 to 12 months are less common, but can occur in a subset, often as subtle declines in memory. These figures vary widely due to differences in surgery and cardiac and all this sort of thing.
That's
so
right.
Age is the strongest risk factor. Risk rises notably after age 60 to 65. And this is something that it's not just, urology procedures. It's all, knee replacements, hip replacements, all these sorts of things, which I refer patients for all the time. I'm not trying to say no one should have procedures, but in men that could possibly solve their BPH problems with a medical therapy, they're able to sidestep this risk. And surgeons, I don't think they even talk about this as a risk. I think it's terrifying. And they figure patients aren't going to want to do an operation if they mention that you may end up with lingering memory problems afterwards just from the anesthesia.
Well, you see, the top people I do too. The top people I know are very sensitive to the general anesthesia or not. They're very sensitive to the comorbidities, the age, the duration, the treatment time, the risk. And the people who end up getting these procedures, it's like prostate, right? You don't rush into a procedure. It's so funny because if I listen to you talk and I inserted the word prostate cancer 20 years ago when I met, it would be the exact same speech you're giving, which I mean, you're basically saying there's an awareness issue. Essentially, there is a progression issue. People should start conservatively. They should understand what they have. They should be able to question their doctor. They should find the top specialists. I could have inserted in there, in your speech that you gave, I could have inserted the word prostate cancer, and you're almost talking about the same thing. But the problem is BPH has so much further to go in terms of advocacy that we're basically arguing. We agree. We're arguing the same thing that we argued 20 years ago where prostate cancer should be. And now prostate cancer has gone there in terms of advocacy. But the lack of knowledge in BPH, the lack of the treatment options, the wild, wild west, like he called it, which I appreciated that, of the treatment options, it's really stunning. So it's kind of given me some oomph to really jump in this and talk about it some more. And so I don't know anywhere where there's a class on behavior. I don't know where any class there's a class on pharmacology. Look, one of the biggest risk factors, one of the biggest thing people deal with in just dealing with bladder issues and BPH and getting up at night is constipation. That's why all the behavioral recommendations say avoid or prevent constipation. Like, who wants to have a course on constipation? Well, there should be a course on it because people should understand how they could reduce their risk. Because right here is the bladder and the prostate and the rectum's back here. So if this is full and you're constipated, it pushes up against that anatomy and it makes you want to it gives you urge. It makes you want to get up at night. So listen, I don't disagree about that. Where I think people need to understand, and we're going to do a better job, is that you're talking about in-office procedures and then you're talking about surgical procedures. And there's so many of them that we could spend 5 hours on it. But our job is to make sure that we cover all of them, the pros and cons of that. And I think Helfand did a good job of that. The only place I disagreed with Helfand, and he always laughs, he doesn't address it with me. Maybe if I have a soda with him, like a green tea. He says that the learning curve is very short with aquablation. And I go, well, that's fine. But I still don't want the guy or gal who's done 50 of them. I want the person who's done 850, right? Because I don't care if it's the anesthesia. I don't care if it's a complicated prostate. Prostate's not just about size. It's about shape. Things can get very complicated. And if you don't have that experience of some practitioner that has done a ton of these cases, we had someone on, Casey Dow, who's done HOLEP, but this is what he does. He does them constantly. He changes people's lives in an incredible way, but this is what he does. This is what he teaches. My problem in BPH is different from your problem. And there's too many people dabbling. There's too many people dabbling in too many procedures. So you see all the really good PAE people, that's fine. But what you have to see is if you talk to some of the top PA people in the world, they'll tell you about other PAE people doing embolization that haven't done a ton of procedures, and the procedure itself gets complicated from where to enter, the hand, the pelvis, the anesthesia, the vascular complications that can occur. Not everybody is anatomically the same. The retreatment rate with all these procedures in the hands of someone who's not competent doing it is really high. So I'm going to share with you the largest...
That's a separate issue, Mark. You are 100% correct that if you're going to do something potentially irreversible to your body, spend less time deciding what it is you're going to do and spend more time figuring about who is going to do it. The quality, the skill level of the doctor doing this vaunted procedure is more important than the actual procedure. Now, it's nice to have both the best procedure and the best doctor. But if you're going to spend your energy spend your energy finding the best doctor. This is what makes us think that all doctors are, we don't see it in sports, right? Not everyone is a Tiger Woods. Not everyone is an Arnold Palmer. These people they were born to play golf, and there are certain doctors that are born to do these procedures. And the trick is finding them
That's right.
and not talking about the kind of outcomes that you get from average people.
I know, but you have to admit, I watched you complain for 10 plus years on who are the best in prostate. You need to find these people. And here's where we are at BPH, my friend. We are in a situation where there's so many procedures. And I listed a lot of them: aquablation, HOLEP, PVP, Optilume. A whole bunch of them are in office and a whole bunch of them are surgical. So I think what you've done today, is you've helped me recommit on the idea of making sure all of these procedures, that people understand the pros and the cons. And what we did well in the old days is we would tell people where the best people who do prostate cancer procedures, where to find them, like where to and this is for everything that we do.
I mean,
PCRI.
by inviting Dr. Helfand, with his experience, he's training other people. This is implicitly saying, here's the kind of caliber doctor. If you need, a definitive treatment because you've blocked urinary outflow, that aquablation in the hands of a highly experienced, talented doctor is a reasonable option. So I think that we, in a sense, do provide that service by inviting the best people to come do these presentations. We're highly selective in terms of who's invited to.
We absolutely are, but we're gonna do a better job of it. But why did you have Margolis on there from in New York about imaging? Because there's a difference between his skill. Why do we have Epstein on? There's a difference between his skill. The greatest thing you can learn from my back and forth with Dr. Scholz today is this also applies to BPH. There is a different level of skill. There's the NBA, and then there's high school basketball. And what we're trying to find you, whether we find you Casey Dow, where we find you Helfand, where we're trying to find you, and we're doing a good job, but we just don't have enough time. We're going to do a better job in BPH. There are the top NBA all-stars in BPH. We just got to make more people familiar with them.
Yeah. And I'm glad we spent a lot of time talking about this because it cannot be overemphasized that the skills and the experience of these doctors makes so much difference. Everyone kind of knows that, and everyone is a little frustrated because they don't have batting averages. And how do you really get to the nitty-gritty of who the quality people are? And it's not an easy process, but it is a necessary endeavor if people are going to go into a potentially irreversible procedure to do extensive homework about the person who's going to do it. And I'm glad we spent time on that. It cannot be overemphasized. And this is in prostate cancer. This is in BPH. It's such a sensitive area of the body. It needs this type of care. All right.
The greatest compliment I got before this Men's Health event. Let me share with you something private. The greatest compliment I got was from my general surgeon, lives not too far from me. I had this little. People know that I've been doing marathons and lifting and doing all this stuff, and I cut the grass and I still act like a farmer boy. But I have this little inguinal hernia on the left side. There's a lot of history in my family of little inguinal hernias. So I'm just kind of now sizing up who might repair it if it continues to get bigger. So I've talked to a couple of my friends. One of my friends does hundreds upon hundreds of these things every year. And I finally went for my third visit. He looked at my wife and he said, "Man, if I ever do this with him, we need to all go out and celebrate and have a drink." It was the greatest compliment I heard because basically what he was saying is I was a pain in his gluteus maximus. I had basically asked him so many questions about anesthesia, about blood loss, about how many of these procedures he's done, about whether or not to use a mesh. I had inundated with him with so many questions that I finally realized he's my guy if I'm going to go there. But he clearly looked at my wife thinking, "Get this guy out of my office. He's too much of a patient advocate." That was the greatest day of my week. Anyway, let's move on. Sorry.
Thank you for sharing that. That is so, this is a type of patients that do well. They're considered pains in the asses by all the doctors. And no, they are.
You're right.
But you look at their outcomes. I end up learning from these patients. They go from door to door doing their research. Finally, I'm going here. It's so common that becomes my go-to doctor for that particular procedure because of all the legwork that pain in the ass patient went through in finding these people.
Exactly.
There was a hernia doctor up in Northern California, unfortunately retired now. One patient of mine, it literally interviewed 7 or 8 different places, found a hernia doctor that's doing old-fashioned hernia repair without the mesh.
Yeah, open.
Yes. And he had a great outcome. And that particular doctor impressed me so much, I referred a number of other patients to him after he found him. And unfortunately, he retired. But this is the process that you're exemplifying. You're trying to protect your most valuable asset, which is your health.
That's right.
Putting it on the line when you go into an operating room. And the other thing that you've talked about, and just briefly, it went by really quickly, and I don't mind spending time on this because this is a super important thing. You talked about who is going to do the anesthesia. I had an anesthesia patient that was going through a procedure, and he said, people are fools. They interview their doctors and they don't interview their anesthesiologist. It's the anesthesiologist that could kill you. And so he, as a general anesthesiologist, would always interview the anesthesiologist in advance and get a sense of, is this going to be, what's their experience? So
that's a good point.
You know all this.
I know all this, but the reason this is so critical today, and believe me, I'm going to chronicle this journey for the PCRI because I will. I've already asked him to come on after we make some more decisions, but the vetting process, people need to understand it. That is a good vetting process to bring in a list, to make a checklist. They spend time to understand who does the most procedures, not only who does the most procedures, but what are the other procedures out there? How do they compare? There's a whole list. Unfortunately, what gets more credit in the world of prostate cancer and BPH, and this is how we can end it, then go on to the rest. And maybe you'll agree, maybe you'll not, but this is my biggest pet peeve. That we've taught people to look at their doctor and say, hey, if I was your brother, what would you want? What would you do? Or if this was you, what would you do? Thinking they're going to get the inside knowledge. It's not a bad question, but it's completely set up for subjectivity. So if someone's doing a lot of a certain procedure they like, a lot of times they'll go, well, I'll do that procedure. Or if it's my brother, I would do what I do. It's not necessarily getting inside information. So I used to joke that if you say, well, if I was your father, what would you do? Well, maybe the guy doesn't like his father. I mean, who knows, right? I understand trying to get that inside information, but that can't be where the patient stops. It has to be on a much longer list of criteria that evaluates the pros and cons of that procedure. It can't be just, hey, if I'm your brother that you like, what would you recommend? And I understand why people ask it, but we need to make sure people go so much further than that. I'm done with that. Sorry.
No. And please do chronicle your process. I think that would be very informative for people. Obviously, you're a sophisticated consumer of healthcare services, and we have a lot to learn from that. And it's a process, and this is a process that we have the luxury of when you're doing a routine procedure. We're not talking about emergency procedures. This is when people go into an emergency room and have to have whatever the surgeon is on call. Obviously, we want to avoid that ever happening. But
you've outlined all the same issues, which is why I'm going to chronicle it. Anywhere from 1/4 to 1/3 of men will be dealing with this. It's an epidemic problem in men because of anatomy. Because long story short, as the testes descend, for a lot of people, it comes down a tube, it comes down a chute. That chute doesn't adequately always close. So it's a epidemic problem with a lot of options. You mentioned mesh or no mesh. There's types of mesh. There's biodegradable mesh. There's permanent mesh. There's laparoscopic. There's robotic. There's open. And they all have to be looked at. Some of my friends go, you're microanalyzing this too much. I'm going, no, I'm not. This is my body. I haven't had a cold in 61 years. So if someone's going to touch my body, I've had an incredible run, an incredible quality of life. Just did the New York City Marathon. But if someone's going to touch me in the next 3 to 4 years, here's my medal, by the way, not that I'm being too arrogant, I'm going to find out who the perfect surgeon is for me. Full stop. Thank you for that.
And that will end up benefiting a lot of people because in the future, when people query you about, hey, I got an inguinal hernia, you say, I know the guy. this is a powerful thing. Anyway, let's talk
Okay.
about
What's
Dr.
next?
Shellhammer and the incredible conversation that you had with him that so beautifully illustrates the unpredictability and the creativity that is needed to walk into an amazing outcome. Androgen-independent prostate cancer, which is where men have been taking Lupron shots or testosterone deprivation, and it stops working, is the biggest watershed moment in the whole chronology of prostate cancer. Historically, that meant you were on to chemotherapy and mortality at some point. Things have changed to a certain degree with these wonderful second-generation hormone therapies and a lot of new things. Dr. Shellhammer has benefited beautifully from Pluvicto, which is a breakthrough targeted type of radiation therapy. But the long story of decades is not as uncommon as you might think. Yes, he is an outlier, but the people who do live for extended periods live for extended periods. I see a number of patients like this, and the story is almost always uniquely tailored to that individual. What people don't realize is that there are literally thousands of different genetic variations of prostate cancer that grow at different rates, spread at different rates, respond to different medicines, and sometimes respond to unexpected medicines. You and he talked about transdermal estrogen, which is used commonly to help get rid of hot flashes in the prostate world, very effective for that. But it also lowers testosterone. And in his case, he pointed out that it also improved his subjective sense of well-being and even gave him a little bit of libido, which is an amazing thing for someone with no testosterone. So that was just a brilliant invitation to bring him and his willingness to open the window to his life. Obviously, one of the most respected urologists in the field of urology.
That's right.
Who's changed the field of urology and who has survived now into his mid to late 80s, still productive with, how long? Androgen-independent prostate cancer for 15 years? I mean,
almost
incredible.
20.
20 years. Amazing.
That's just, is that just
it
like
gives
the
everyone
thing?
tremendous hope that this idea that we know your future, you have this, you have that, is so arrogantly incorrect. The way the story plays out is the way the story plays out. What happened to other people is not a guarantee of what's going to happen to you.
No, but he's accepted that, and he's gone through. It's amazing how he keeps moving. He keeps moving through clinical trials. He keeps moving through breakthrough medicines. But what people don't know, we weren't able to cover it a lot, is he doesn't make another move until he thinks about it. He's analytical. Plus, he talks to a whole bunch of people. He kind of gets their He kind of gets their pros versus the cons. So it's a good lesson for the BPH discussion we had. He's one of the most famous urologists in the history of urology. And lo and behold, he's just methodical. He's looking at anything, repurposed medications, over the counter. He's looking at, what's coming through clinical trial, what's coming from Europe, what's coming from Australia. He's sharp. When you listen to him and you think that he's 86, and he was originally diagnosed in 2000, and he was CRPC basically 2007, 2008. So you're coming up on 20 years. You don't even, he believes he's on ADT of any kind. I mean, cognitively, he's sharp. He can mention paper. It's just like talking. If you were talking to an 86-year-old who you thought was really on the ball and sharp and not on anything, that's the kind of interview you have. So
yeah.
But I do want you to comment, because I do think, obviously you and I agree and disagree on certain things. For today's, I'm going to be Switzerland today. I'm going to be nice until the fall, then we can have at it again. And plus, you have a nice tie on, so I'm going to let it go. But you have done a lot of work with transdermal estradiol. That I know. And I just want you to just do a quick overview of the fact that you can use it in some cases instead of ADT, or you can be on ADT and just use it as a medication to reduce side effects, right? And so he's talking exclusively about the patch. And you've been talking exclusively most of my career that I've known you about the patch. So I just want you to give kind of your 1 minute experience with using estradiol in prostate cancer, and then we can talk more about this in the fall.
Sure. Well, the number one thing is that it's the best way to get rid of hot flashes. That's bar none. So there's a number of products out there, Effexor, gabapentin, Vesicare, these things that will lower hot flashes. But if a person's desperate, the success rate with estrogen is much higher than any of the others. The reason they want to use transdermal patches rather than pills is that if you swallow a pill, it goes through your liver, increases clotting enzymes, and can predispose to blood clots. So estrogen transdermally was a big breakthrough because we found a safe way to get estrogen into the system for men. And the second, as an alternative, he's using it as an alternative to Lupron. And it sets up nicely as an alternative to Lupron because the restoration of estrogen restores some of the normalcy that men have because when they have testosterone, they also have estrogen. When you block testosterone with Lupron, you lose the estrogen. So you get to keep the estrogen, which helps men feel a little bit more normal. And I've seen this before where some men will have a sex drive when they're on estrogen. And it gives us a sense of well-being as well that the sex hormones do. I haven't used it as much recently since the advent of Orgovyx because when you stop the production of testosterone, the recrudescence of the coming back of the testosterone when you stop therapy, men on intermittent therapy, is less predictable than with Orgovyx. Orgovyx, for some reason, when you stop it, it's pretty much universal that you'll get your testosterone back. With estrogen and with Lupron shots, the recovery of testosterone is a little less predictable. So it hasn't been a major go-to for me, but it works very well. It blocks testosterone very thoroughly. And yes, if men are going to be on a blocked situation long-term, it may lead to a better subjective quality of life. There was the issue of breast enlargement, which is variable from patient to patient, usually can be circumvented with some prophylactic radiation to the nipples prior to starting the estrogen. But in general, it's an underutilized treatment, no doubt about it.
Yeah. And in terms of the bone, I understand people want to say that the bone health situation is very binary. You can take something for it. But the reality is estradiol has been very good for men's bones and the men that qualify, right? Yep. Not everybody can take all these bone agents. Not everybody can tolerate them. Some people are worried about the very rare side effects. I just think it's so healthy that we're having this conversation, this resurgence of an option, because this one-size-fits-all discussion that sometimes you hear at meetings makes me nauseous. Like, this is the only route you can go. That if this is the only route you can go, why do you even need a doctor anymore? Just put your stuff into a machine, grab the advice and leave. This is the art of medicine. There are some people who can't tolerate many of these medications. Some of the hot flash medications they're taking come with an enormous number of catches, potentially. And so I love that this cheap option that has turned out to be safe and now has this patch clinical trial to give it some oomph from the United Kingdom, published in the New England Journal of Medicine. I just love that it's just another option for patients. So that's why I'm glad.
But it's nice to bring in a person of his caliber who it's really been the central treatment of his status for, over a decade. And a living example of the effectiveness of this treatment. You really bring the message more than an article. There's an article showing you can do this, but does anyone actually practically act on that information? Exactly. Well, someone very smart acted on this information.
Yeah, and felt just like the trial said, from less insomnia, less fatigue, it worked for him. And for other people, LHRHs are fine. Orgovyx is fine. All these drugs are fine. But for some of the guys who want to go a different route, and there'll always be these exceptions, you just can't say, oh, buck it up. He had a really funny editorial he wrote. People should read it. It goes back many years. He basically said in an editorial in Medical Journal, any doctor that thinks ADT is an easy ride should basically inject themselves in the gluteus maximus or take the pills for them. You're putting men into male menopause within a few weeks. This is a rough ride. And to simply not admit that it's a rough ride is one of the biggest mistakes that we make.
Yes.
It was a great editorial.
No, this is, let me just mention briefly that, there's a big undercurrent of change going on ever since the advent of PSMA PET scans. Men with high-risk prostate cancer, Gleason 8s, PSAs above 20, historically had to get treated with Lupron and other testosterone blocking agents for 18 to 24 months, based on the concern that there might be metastasis out there somewhere that we didn't know about. There are no studies yet proving that in men whose PET scans show no spread outside. We have this new information since 2022. These PET scans were commercialized. That possibly these high-risk patients can use less than 18 months of hormone therapy is a gigantic potential upgrade in quality of life. This question mark of whether we still need to be giving men, a year and a half to 2 years of testosterone deprivation, usually another 6 to 12 months of recovery. So you're looking at close to 3 years without testosterone to buy maybe an additional 5% better cure rate. Is this truly justified in this era now where we have PET scans that not only can find metastatic disease at the get-go, but if in the future the cancer comes back, you just had to go back on hormone therapy. Now you can find the site of relapse and radiate it, and some of those relapse patients can still be cured. So these breakthroughs are not being incorporated into day-to-day practice yet, but this is something that people need to be aware of in light of how heavy-handed testosterone blockade is.
No, that's a really good point. And I thought it was interesting when I said, hey, for example, when you went from Pluvicto in the 160 or what it was now to 0.7, was this predictable from the scan? And he said, oh, my SUV, I was so imaging sensitive, it lit up. So the idea was I was very PSMA avid. In other words, like, I might be a really, really good candidate. And certainly enough. But I don't want to leave that, we forgot to mention.
But the other point was, there's a question in the air as to whether him having been on estrogen promoted that pattern.
And we talked about, exactly,
Yes.
We talked about the upregulation of PSMA, and this is what his research is funding. He's wondering if we could start using agents that upregulate PSMA that make you a better candidate for Pluvicto, make you a better candidate for actinium. And he believes the answer is yes. And he believed that one of the routes is estradiol. So, I trust the guy. We'll see what his research says. But in his case, there is preliminary research to show that, not just in his case. There's some background research going back 20 years ago to suggest that. So wouldn't that be something? But
yes,
we can't leave here without talking about the sex therapist, my good friend, Dr. Jeff Alba, who came up here to visit me, unlike you. My good friends come to visit me up North Michigan when I'm spending time here. I had coffee with him. We sat at a diner in Traverse City. I met his wife. And I spent most of my time looking at him when he was here a month ago. And I said, you've done something that Scholz has never done. You came to visit me. And so maybe this will encourage you and put pressure on you to visit me. But that's a whole other therapy session.
He is, he's not just a sex therapist. He's a counselor. And, he's into how to build better relationships. So he's more of a professional than I am, Mark. I was so impressed. He didn't just talk about how to, have better orgasms. He talked how to have better communication, how to build intimacy. He talked about the challenges that these things require. What a pro.
He was a pro.
He was a total pro, and he was able to communicate really complex ideas with such aplomb. I so enjoyed his presentations. The guy's brilliant, and of course, it makes me look at why haven't I visited Dr. Moyad? Well, I've got to grow up a little bit in this communication and this relationship stuff, this intimacy building. I'm very good at prostate cancer, but I'm not very good at those things. This is so I appreciate your introducing him to us.
And what did he say? He said vulnerability is the key. Don't be scared to be vulnerable. So like I shared with you that I might be following an inguinal hernia. I share that vulnerability with you. You don't share any vulnerability with me, but maybe you'll do that when you come to visit. But he has this book. It's for free. And we gave all the information, but he's going to be there in September now doing a breakout on Friday. And I'm going to tell the audience what I've been telling all of you behind the scenes. And for those of you who are sick of me having so many friends, 30, 35 experts, I'm going to explain myself one more time before I give kudos to the fall conference. I used to travel and give a course for 30 years. I met the best and the worst of the experts I could have ever imagined. The best experts became my friends because not only did I want to show the world that they're amazing, that if I ever needed help, I was selfish. I wanted to use them. So the bottom line is he was always, Mulhall, him, he was always the top guy I saw. I've been dealing with him just sitting in diners for 30 years. What I'm telling you is he's 10 times better live. I'm telling the audience this. For those of you who are, I know it's filling up fast to come in September. He's going to do a breakout with couples on Friday before the Saturday conference. He's 10 times better live than he is at Zoom. Think about what I just said. That's how impactful he is.
Thank you, Mark. Thank you for these amazing speakers. Thank you for your scintillating Q&A afterwards. And people don't realize it, that in your Q&A, they're actually getting a lot of new, fresh, pertinent, and relevant information about these things, especially BPH. As you pointed out, the BPH problem dwarfs the prostate cancer problem.
That's right.
Dwarfs the prostate cancer problem. And this is a private area of people's lives that doesn't get talked about, and people suffer silently. And so thank you for bringing in Dr. Helfand and these other wonderful, wonderful speakers. So appreciate it.
My pleasure. I did one faux pas. My wife said not to wear this scarf. It doesn't match with my tie. So let me just take that off. But thank you very much. It's always a pleasure being with you. I look forward to our Q&A on that Sunday where we can battle it out. Maybe this time it might get physical. We might have to talk about why I think some of the BPH procedures are awesome for the people that qualify, But it might be a cage match. So if you're smart, you'll start working out now in order to deal with me. You'll have the height on me, but I have the muscle. So it will be a good competition, right? You have height, I have strength and muscle, and so we can see who wins. So for the people that attend our Sunday session,
Yes, I appreciate you warning me in advance. I'll be prepared. And the usual namby-pamby, sweet, kind Scholz just ain't going to show up this time.
That's fine. We'll have Alex and Peter referee, and I'm just telling you, there's a 3-second rule where when I pin you, you're going to have to give up. But you have a lot of fans out there, so I can't hurt you too much. Then someone might hurt me. So I'll be gentle. But really, I love you, man. I'm showing my vulnerability. I am so excited for fall. Let's just do one more kudos for fall before I know you have to run to clinic. We have that Friday Alba. You have Sunday Q&A with me. We start off the conference with Scholz, not just talking about active surveillance. He's also going to talk about focal therapy. Why? Because we've been inundated with, why doesn't Scholz talk about focal therapy? He's involved in Tulsa Pro, for example, and some of the other focal therapies. So we're going to do that. Tanya Dorf.
That's a miracle because you and I both know we're entering an age of where, for the first time, patients, the clinical trials out there are actually benefiting patients enough to justify you've got to know your stuff on clinical trials. Tanya Dorf probably is one of the top researchers in prostate cancer. And this is a unmet need now because people have to shop around. We talked about shopping around for the right proceduralist. People have to shop around for the right clinical trials. Some of these new medicines coming out are game changers. You mentioned actinium earlier. Actinium is Pluvicto on steroids. And you and I have had patients together that have benefited from this, and there's many more. So Dr. Dorf is going to be talking about all the new clinical trials and the things that are around the corner. Exciting, exciting stuff.
And then I want you to comment on one other person. I'll comment on the rest. Dr. Mac Roach will be here. He's a radiation guru. It's always fun when I get on stage with him. We argue so much. It's amazing that we actually even get along. So Dr. Roach will be talking about all the different types of radiation treatment, which will be awesome. We have someone coming from UCSD who's he's really good at talking about lifestyle. He's also going to talk about the microbiome. He's just going to talk about a lot of the studies he's doing with lifestyle and prostate cancer. And so we'll reveal him soon, but he's another good friend of mine. But like all my other friends, they got to work on their personality in terms of humor. And then we have Alex finishing off. Last year, she finished off about how to appeal in insurance rejection and did an incredible job. But now we've assigned her with the task of how do you appeal to all these companies to possibly get a drug or access to a drug if you can't get it, not just to access it, but to access it cheaply and in some cases for free. That's a daunting task, but she's up to the task. But then you guys have a friend in Australia coming. So I don't know if you want to talk about this doctor from Australia that everybody says is so great, but he has never been up against the Moyad.
Yeah, Dr. Lenzo is an expert in let's say, just so everyone can grasp it easily, an expert in Pluvicto, got in on the ground floor. But there are many new layers of, as we mentioned before, actinium and these sorts of things. So the last word in the smart bomb, targeted radiation therapies, coming in all the way from Australia, tremendous individual, and even Mark Moyad will like him. It's he's so nice.
That's awesome. I've known so many people in Australia. I've been there 3 times teaching. I haven't run into him. I've run into almost everybody else. So I'm excited to see him. I'm excited to just kind of talk with him about this whole Pluvicto area. And where we're going. And I think we have people coming from Australia to this conference just to see him. So anyway, I'll let you go. I got to finish my green tea that looks like a urine sample. I don't know what happened to it this morning, but you got to do what you got to do on my tight budget.
Thanks again, Mark, for all your hard work.
Thank you.
Great conference. And thanks for reminding people about September. Sure appreciate it. Have a lovely one.
Yeah, you too. And listen, I'm going to end this way. I'm going to end with vulnerability. I love you, Dr. Mark Scholz. Do you want to see something?
I can't handle this much vulnerability. Oh.
All right.
I don't know what
we'll
to do.
We'll cut it there. We'll make this interesting. Let's see if he can say we're talking about friendship. We'll see if he can say the same thing back to me. Stay tuned on September 20th when we do our Q&A on that Sunday. We'll push him to finally express himself in his vulnerability. All right. See you soon, my friend. Come visit me. Come visit.
All right. God bless.
God bless.
Thank you, Dr. Scholz, and thank you, Dr. Moyad. We really appreciate both of your perspectives. We appreciate the time that you take and the volunteer work you do here at PCRI. Speaking on behalf of the patients that I have the honor of representing, we just say thank you to you both. It is incredible. Also, I'd like to say thank you to all of our speakers. They've just done an incredible job. We thank you for your time and your candidness and just giving us your perspective in order for us to learn and understand. And also, thank you to all of you who have watched this video. We really appreciate your support here at PCRI. We thank you so much just for your, subscribing to the channel, for watching, for the likes, for the comments. It helps us to build further content so that we can help you and remind you that most of all, you're not alone. We look forward to hopefully seeing you in person in September. You're going to hear us talk a lot about this conference in the next couple months, but it's because we do want to see you in person. But we also want you to be able to ask your questions in person, but we also want you to share your experience with other patients as they share their experiences as well. It's a great way for the prostate cancer community to come together and to support each other. And we look forward to that. You can learn more at pcri.org/conference. I'd also like to thank our sponsors, Dendreon, Pfizer, and Bayer, for your support in helping us make this for free. And also don't forget to visit our website at pcri.org/men's health for a wealth of information. Please remember, most of all, you are not alone. And I hope you have a great week.
Why do we come? Because knowledge is power, and knowledge provides hope.
And this is a place of hope and healing. And that's why I like coming here.
People come to this conference, they're uncertain, and they walk out of here with hope.
This is my 5th time. I learn something every year.
That was my first conference.
This is my 4th.
I think this is my 6th, and I love it. It's part of my treatment plan.
I've come to quite a few of these PCRI conferences and enjoyed all of them.
I've been to probably 9 PCRI conferences. Every one there's something different, so I keep coming every year.
But the key is to be able to go and even have direct, individual questions answered with such kindness and such patience by folks that are at the top of their field.
It surprised me how accurate and up-to-date all the physicians are.
And they're very warm, they're open, they're available, and they present scientific information in a way that's very easy to understand and also quite entertaining.
The way they keep it moving and engaging, I mean, this is not a dull conference. This is, I don't want to use the word entertaining, I mean, it is entertaining, but it keeps you focused, keeps you engaged, anxious to hear the next thing.
I would say you have to come here and experience it.
Excellent beyond description what this conference brings to our lives.
Provenge is an established cellular immunotherapy used to treat certain men with advanced prostate cancer. Provenge is customized to each individual and is made from his own immune cells. Immunotherapy is the prevention or treatment of disease with substances that may stimulate an immune response. The immune system has memory and can recognize substances it has encountered previously. Immunotherapy is designed to boost the immune system to target and attack advanced prostate cancer. This is why immunotherapy empowers the immune system to fight the cancer immediately and allow the effects to last over time. Indication: Provenge is a prescription medication used to treat certain men with advanced prostate cancer. Provenge is an established cellular immunotherapy and is customized to each individual by using his own immune cells. Important safety information. Before receiving Provenge, tell your doctor about any medical conditions, including heart or lung problems, or if you have had a stroke. Tell your doctor about any medicines you take, including prescription and non-prescription drugs, vitamins, or dietary supplements. The most common side effects of Provenge include chills, fatigue, fever, back pain, nausea, joint ache, and headache. These are not all the possible side effects of Provenge treatment. Provenge is made from your own immune cells, which are collected during a process called leukapheresis. The cells are processed, returned, and then infused back into the patient through an IV, intravenous infusion, approximately 3 days later. This process is completed in 3 cycles, about 2 weeks apart. Each infusion takes approximately 1 hour and requires 30 minutes of post-infusion monitoring. Provenge infusion can cause serious reactions. Tell your doctor right away if you have signs of a heart attack or lung problems, such as trouble breathing, chest pains, racing or irregular heartbeats, high or low blood pressure, dizziness, fainting, nausea, or vomiting. Have signs of a stroke, such as numbness or weakness on one side of the body, decreased vision in one eye, or difficulty speaking. Develop symptoms of thrombosis, which may include pain and/or swelling of an arm or leg with warmth over the affected area, discoloration of an arm or leg, shortness of breath, chest pain that worsens on deep breathing. Have signs of infection, such as fever over 100 degrees Fahrenheit, redness or pain at the infusion or collection sites. Tell your doctor about any side effects that concerns you or does not go away. For more information, talk with your doctor. You are encouraged to report negative side effects of prescription drugs to the FDA. Visit www.fda.gov/medwatch or call 1-800-FDA-1088. Please see accompanying full prescribing information.